Health Community Medicine knows. He is the chair of Program Advisory Committee in National Institute of Health and Family Welfare and also holds multiple positions in different forums. So, and Madam has also been not only in tobacco control, but a lot of issues of public health. She's very actively participating for so many years. So immense energy she has. So thank you, ma'am. I think both of them will be chairs. So I invite chairs on the dais, Dr. L. Swasticharan and Dr. Sunila Garg. So besides this, I'll just introduce, I think we have Dr. Madan Gopal, Dr. Preetam, Dr. Preetam Datta, and Dr. Harish Kumar Meena, Mr. Sanjay Seth, and Mr. Ranjit will be our panelists, and they will be introduced by our session chairs. So before that, I'll just have a brief outlook of the project which is there, which we are running for the last 8 years now with the vital strategy, that is bolstering tobacco control in India through capacity building, networking, partnerships, and comprehensive empower implementation and stopping tobacco industry interference. So how we can move that slides? Do we have slides? So I take this opportunity to, I think those who are sitting off the dais, my teachers and my, I think mates who are there in the PG. So I think, thank you all of you for being here. Just there. Yes. So, so this project which we are running at the national level for the last 8 years. So the main objective of this center is to develop and strengthen a national resource center for tobacco control. So this is a center which was established in 2016 under leadership of Madam Preeti Sudan. So Madam Preeti Sudan was the health secretary at that point of time. So she inaugurated that center and almost 45 organizations were present during the inaugural and development, guiding the development of this center. So it has been a long journey, 8 years now. We are having this National Resource Center. And we have a stall outside of National Resource Center. If somebody wants to visit that stall, you're most welcome. Then second is to support empower implementation, because WHO has developed a key that is MPOWER. These are the 6 strategies. WHO says if we work on those strategies, we'll be able to effectively control tobacco control. So that is one thing which we are working on. And then third is underpinning the whole of the government approach in implementation of Article 5.3 of FCTC. In tobacco control, the most important problem is the tobacco industry interference, because whatever work our crusaders are doing in tobacco control, they are being nullified by the tobacco industry. So that is what we are working on, how we can have the whole of the government approach for effective implementation of Article 5.3. So 5.3 says that as a public health institution, or we cannot take sponsorship, funding, and we cannot meet those tobacco industry officials. So that is one thing. And fourth is enhance networking and partnership with diverse stakeholders. So when we undertook this project, so primarily tobacco control was looked after by the NGOs. So mainly their civil society has actually driven tobacco control for such a long time. So at that point of time, academia, we just entered, and then we are trying to build partnership with various AIMS and medical institutes to drive the tobacco control. So this is basically the brief thing about Resource Center. So we have done some capacity building. We have 87 plus plenary sessions, capacity building sessions, which we have done. We have organized a national conference on tobacco or health, the 5th national conference on tobacco or health. And we have conducted 4 national summits on tobacco, World No Tobacco Day, which was attended by almost 1,500 to 2,000 participants in every summit. And we are currently conducting 2 courses, one 3 months and one 6 months course on tobacco control, that is basic and advanced course on tobacco control through Resource Center for Tobacco Control. Then We have a global outreach of around 9.8 lakh users from 110 countries. So they are actively seeing the portal and they are retrieving various documents which are there as a repository, because this is a repository of documents, global documents as well as national documents. And then it has almost 1,400 circulars which are arranged state-wise. There is basically there are various circulars and orders which are released by various states, but they don't have a proper place where they are being there. They are either present in the physical form or they are present on the website, but we cannot archive them. So this is an archive where we have a repository of 1,400 plus circulars and 300 plus IEC material in various languages. So different languages IEC material. Again, it's a compilation. Some are developed by RCTC and some are being compiled by RCTC from various websites, reliable websites of their state level. We have our own publication. Dr. Sood has pointed out about, I think we are interested with a national task force on tobacco control. So around 80 people, some of them are sitting in this room as well, around 80 experts in tobacco control. So they contributed 8 chapters on various aspects, priority aspects of tobacco control. So that is one publication which we have. Besides it, we have a tobacco-free time, which is coming from last 8 years, every 2 monthly. So that's a theme-based issue. If somebody wants to learn about tobacco control, so that tobacco-free time is one thing which we can read. Every time there is a new theme on tobacco. So we have around 37 tobacco-free time which has been released. So that is one thing. And today we will be releasing in the August ceremony this 38th edition of tobacco-free times. So I think we have so we are also leveraging research for strengthening national tobacco control program. And there are multiple research. If you can see, these are the current manuscripts which are undergoing. Around 38 manuscripts are undergoing various stages of publication through our manuscript writing program, where we have involved almost 100 plus researchers from across country on different aspects. See, you can see tobacco industry interference, youth protection, digital tobacco control, civil society involvement, tobacco taxation, tobacco product regulation, cessation behavior, health and disease burden, and so on. So these are 38 publications which are running right now. And this is what we are doing on Article 5.3. We are visiting various states and we are meeting their secretaries, and so that they can implement effectively the Article 5.3 FCTC. So these are some of the things which we are doing in this. We are developing the networking. I've already told about 2 consortium which has been developed. One with All India Institute of Medical Sciences, 14 AIMS have joined, and one medical colleges, around 30 medical colleges have joined, and we are having regular meetings with them. So that's why I think multi-sectoral collaboration is very important. Alone health cannot work. I think tobacco is not only a health issue, it's a issue of law enforcement, taxation, education, agriculture, and communication. That's why unified approach is necessary. And that's why we are here, that how we can effectively have the multi-stakeholder collaboration in it. So these are various departments which have different roles of at different stages. So I think, again, it's not our own responsibility, health sector. It's a shared duty of every sector to work on tobacco control. So I think this was just the introductory presentation. So I'll just welcome the introductory remarks from our chairs before we start the plenary session.
Good morning, all. Thank you, Dr. Sonu, for very, very comprehensively telling about RCTC and its journey. And personally, it's very close to me, because when we inaugurated the center, it was in Maulana Azad Medical College, and being head of department, I had the honor to come over there to the dental college, where, Madam Susan was there, and all, dignitaries were there to look at the center. And this center has taken really a kind of, I'll say, a journey which has been very steady, multi-centric, multidisciplinary, and across. And you really mentioned that, basically it's not only journey, but along with journey, many people, got added together from various forums. It was not only a game of health sector, but we also, looked at different sectors so that, we can broaden the scope of this, not only in India, but in global context also.
Right.
So that was one of the very important things. And another important thing which you passed a message was, and here also, all students, all faculty who are sitting over here, please make a note of these two capacity building programs. In addition, you have an international program as well where you talk about leadership. So RCTC is very closely linked to capacity building, which is one of the most important critical pillars of taking, tobacco control forward. And another important thing which I'll say is that basically we have to, you see, no program is successful, because from my lessons in fellowship in HIV medicine, which was something similar to what you're doing, we used to have, out of 100 or 200 applicants, we used to select 15 applicants, and those applicants used to strengthen HIV/AIDS work at their workplace, and they also used to take a project. And that is where, from the project came research, and that is something which is very, very challenging for the students. And at the end of the project, at the end of the program, they are the happiest people, and their center also benefits more. And in order to make, yesterday when we were talking about, different programs, and I remember that, we focus on one issue, that is implementation research, which was there, in the last session. And one thing, it is in the form of a mode. You took implementation research, and now with the ministry, it has become a sustainable option so that, tobacco control can move forward. And we do have a crusader in form of Dr. Swasti Charan, which is, whom at least sitting in Delhi, I've seen him from many, many decades, who has, steadily provided support at many fronts. And it is really very good that Dr. Swasti is now today there, and he's going to talk basically when we look at the program of and National Tobacco Control Program, the need for multi-sectoral convergence. You already mentioned that tobacco control is not under the domain of one department, but we have to look at various sectors, whether we talk of health, whether we talk of education, whether we talk of agriculture, whether we talk of, so civil society as a whole. An important part is that till we have community engagement, no program is going to be successful. So good leadership till community engagement has got an important role in this program. And thank you, Dr. Sonu, for always being there for, kind of addressing this important issue of tobacco control, because we cannot control NCD, we cannot control low birth weight babies if we are 12 task forces at Ayushman Arogya Mandirs, some way or the other, they are affected by tobacco. So that is where tobacco control becomes the key challenge, for addressing all the issues. So thank you so much. And I think, Dr. Swati, we would like to have a keynote address from you. And after that, we will go for the panel discussion. If there's anything else you like, and you will speak from there, right?
Yeah. Please, Dr. Swasti, you can be here. Yeah.
Good morning to all the respected colleagues, faculty members, program leaders, and also partners in public health. If you remember the history of tobacco control, we all know that when we had the WHO working as a technical expert, we realized long ago that it is not going to solve the rising epidemic of tobacco-related diseases, which has also got its implications on the environment and also the economy of this country. That's how the WHO Framework Convention on Tobacco Control was born in 2003. And when we have implemented the WHO FCTC, we realized that there are many issues, including illicit trade of tobacco, and the WHO, FCTC itself was not enough, and we had to come up again with illicit trade protocol. So that implies that the problems of tobacco is well beyond health, as also mentioned by Dr. Sonu, and the solution lies elsewhere. That's why today's topic is very, very important. And we all know that India is conducting the Global Adult Tobacco Survey 2025-26 in the third round, and also the fifth round of the Global Youth Tobacco Survey. This is going to give us some burden, and we hope that the prevalence is going to decrease. But after some time, the prevalence is going to remain stagnant, and we will have a hard time, pushing it further down. So these are not statistics, but these are real lives whose livelihood is stripped away because the bread earner is dying, and also many diseases for which we have to cater in lots of infrastructure, manpower, as well as the logistics, including medicine. You have heard the announcement of during the budget announcement by the Honorable Finance Minister regarding the daycare centers, which we are trying to establish around 200 of them this year, and we have a demand from the states which has increased to about 281 this year alone. So next 2 years, we are going to saturate all of that. But these daycare centers are only providing chemotherapy. Many of them, we know 33% of them will be related to tobacco-related cancer. So these are not going to come back into the full life. Many of them would be sustaining some quality of life till they finally die. So this is the huge burden which we have already only with cancer. And tobacco is responsible for many of the other cardiovascular diseases, COPDs, and also many diseases which Dr. Sunila Garg has also highlighted. So we need to adjust what we are already doing. So we have something unique in this country. All across the world, you will see that many of us are focusing on the smoking forms of tobacco, the cigarettes and the cigars to some extent. But in India, we have, among the smoking forms, we have bidis, which is again regarded as poor man's luxury. I do not know what luxury we give to the poor people. They die from cancer, they die from various diseases. But the moment you touch bidi, then we are touching somebody's luxury. But the luxury, ironically, is cancer, cardiovascular diseases, COPDs, and tuberculosis, for which the poor population do not have access to quality care, apart from what we roll out under the Ayushman Arogya Mandis or the PMJ. And also the different forms need to be adjusted with the various strategies which has been provided by the WHO. We have got what is known as the Empower strategy, which the Dr. Sonu's center and all of us are working. It works, but then we need to sift together to cater to the unpackaged, smokeless tobacco that we have in our country, the loose sales of tobacco products, particularly bidis also. And also these products do not come in packs, and they are socially and culturally embedded. If you go to Assam, if you're not offered the Tamil with the tobacco nowadays, tobacco is little less now, but then you are not welcome into that house. And then if you want to ostracize somebody in North India, we still say hookah pani ban kar do, like that. So that is culturally and socially accepted. So we need to reform our multi-sectoral convergence. And the moment we say multi-sectoral involvement, then we think about a conference where all of us sit together, attend a conference, and then discuss something, and then we go back. But it is beyond that we need to work now. We need education to lead for the prevention of initiation in the schools and colleges to the tobacco-free educational institutes. We also need the self-help groups and panchayat leading the community norms. So we have to, go deep into the community, as Madam Sunila Garg was also saying, and then work it from inside. And then we have to have the police, the Ministry of Home, Department of Home, to lead from the KOTPA and the PECA enforcement. And the NHM will have to lead the cessation, which we have done to a great extent in this country. And the food safety, excise, agriculture, etc., will also have to play in both the demand and the supply side of tobacco. So we would like to propose something like the Empower for this country, what is known as PY2CS. So the P will be prevention in schools, and also Y by the youth and the community, and the C for the enforcement of KOTPA and PECA, and the second C for cessation, and the S for the supply and the product control. So this kind of strategy we need to look at from the multi-sectoral convergence, not just attendance, but through execution. And we must also build the capacity. The capacity building must shift now. We should be very specific and they should be targeted on the role specific. So we cannot talk of tobacco cessation to the police. They are not the people who will do the cessation. So you have to tell their role, and it has to be role specific, and it has to be continuous, not something which we do just one as one of the checkbox, tick the box, and then it should be digitally supported. It has to be, I need a dashboard to tell us how many things have happened in that particular direction, and then certification link to ensure that quality is adhered. So this is what we look forward to: behavior change and not just knowledge change. So in conclusion, we have come a long way, and we have laid a very strong foundation in this country for the next steps for the tobacco control. The National Tobacco Control should now focus on outcome rather than the activities alone. The activities should be linked with outcomes, and also we should reach the scale through departmental verticals. So in India, we need an order for the left hand and an order for the right hand. Sometimes we think that the right hand order works for the left hand, but it doesn't work. So your health ministry's letter doesn't work in education ministry. So it has to be an education ministry's letter which will work there. So the multi-sectorial convergence will also drive behavior and norm change through the schools, the self-help groups in the families, the panchayats, and the enforcement and the cessation facilities that we have. So we must now mean operational alignment and sustained execution. So this framework will provide us a very clear and scalable architecture to deliver this, and the National Tobacco Control Program should be, and we are ready for the next phase, and together we can move closer to the goal of tobacco-free generation towards a Viksit Bharat that we all have been dreaming together. With this, thank you very much for inviting me here.
Thank you, Dr. Swasti, for a very lucid presentation. And definitely, if we are aiming at Viksit Bharat, tobacco control is going to be the key thing. Because I remember when he said that word, अगर हम किसी को कुछ कहना चाहते हैं, इसका हुक्का पानी बंद कर दो, हमें कहना चाहिए इसका खाना बंद कर दो, इसका कुछ भी. But we need to get off of this word. But thank you so much for again re-emphasizing on community engagement and empowering the communities. Over to you, Dr. Sonu.
Yeah, thank you, ma'am, and thank you, Dr. Swasti, for highlighting the importance of multi-sectoral collaboration. And I think this is one of the program. I'm not saying only program. Other programs also need multi-sectoral collaboration, but this is the program where we talk about tobacco, and tobacco is a issue which cannot be only dealt by, I think, health sector. So today we have a very illustrious panel of panelists, which consist of health sector, taxation sector, education sector, civil society sector, and sector working in law and governance. So I will just like to invite maybe, so in the meantime, I think, can we have, yeah, maybe we can have some chairs in the center. So may I invite Dr. Madan Gopal. Sir has been advisor of Public Health Division, National Health System Resource Center, and very, I think, avid public health researcher. So, sir, please take the seat, sir. I'd like to invite Dr. Preetam Datta. Dr. Preetam is a fellow of National Institute of Public Finance and Policy, and has been working effectively on how we can drive taxation to the tune of 75%, which is the WHO norms. So welcome, Dr. Preetam. May I invite Mr. Sanjay Seth. Mr. Sanjay Seth is president of Sambandh Health Foundation, Gurgaon, and he has been very actively involved through his very interesting and very effective model of involving schools in a large way to have tobacco-free youths. So welcome, sir. Welcome for this panel. Do we have Dr. Harish here? Dr. Harish. Okay. So we have Dr. Harish Kumar Meena. So Dr. Harish is Associate Professor of Population Education, Department of Education in Social Sciences, NCRT. Welcome, sir. Welcome for this panel discussion. And lastly, we have Mr. Ranjit. So Mr. Ranjit is an advocate, legal expert from Supreme Court of India, and not only in tobacco control, he has been working on various public health issues. Welcome, Mr. Ranjit. So can we have one word from maybe start from Dr. Swasti?
Thank you, Dr. Sonu. And we have a very exciting panel discussion here. I must say that just like in movie halls, we have started with Sunita and, Mukesh. You have all seen when you go for a movie hall, you are supposed to see the tobacco spots that we roll out from the Ministry of Health. So EFICON has started with
Yes.
tobacco control,
Yes.
just like the film rules that we have, and which is very, very apt as well as, important, because all the root causes of many of the diseases, including the NCDs, start with tobacco. If you do the tobacco, I think epidemiologically we are closing the tap, so many of the disease will go away. So with this remark, we would like to start this panel, and to do that, I'll request Madam Sunila Garg.
Yesterday we started with One Health, and I realized tobacco is an integral part of that also. So
Right.
Talk of we look at tobacco and its control.
Right. So what a good way to start. I think I was not thinking about it, but yes, tobacco is very important problem, which is root of major other problems. So let me start with our panel discussion. So we have, I'll just checking on the time because we are 9:40 now. So from the organizers, so how much more? 20 minutes? 25? Okay, right. So we have, I think we had 3 questions initially, but I'll have 2 rounds. So what we request from the panelists is we have to be crisp in those answering those questions so that we can move arrange, and towards the end we can give some time to the chairs to summarize. Right. So let me take the first question from health sector, Dr. Madan Gopal. So, Dr. Madan, I think you have been working in National Health System Resource Center for quite some long time. And so now, can you, what do you think how can health sector strengthen integration of various things like tobacco cessation, surveillance, workforce capacity within the primary healthcare? I think you can take the mic here.
Thank you, Sonu. It's a very interesting question because when I used to work with my previous organization, Niti Aayog, at that time, I had the opportunity to see how the multi-sectoral they usually work. The brief background we should understand. Tobacco is regulated by Commerce Ministry, whereas the Agriculture Ministry is pushing for alternative crops for tobacco. That's the biggest fallacy which is there. And you can think about the multi-sectoral integration which we are pushing for that. That means if we want to offer a alternate livelihood to the people who are growing tobacco, is the Agriculture Ministry is pushing, but it is regulated by Commerce Ministry. That's another thing.
Right.
But I will be just restricting myself to the primary care. We do have tobacco cessation centers. That government has been putting it, state-of-art cessation centers are there. We have started with the Ayushman Arogya Mandir. We have around 178,000 Ayushman Arogya Mandir. We are having a CBAC form which talks about collecting information from the population. That means they are collecting information from the population.
Right.
That activity is there. But are we able to provide services? That's the question which we have to ask.
Right.
As we do the research, we say that the tobacco and the tobacco-related products, as you have rightly mentioned, that the smokeless use of smokeless tobacco consumption is very high. It's not that we are having that challenge. It's very different forms are there. When we were doing the taxation thing, when we came across, there were a lot of complaints because one of the problem with the challenges with the cessation activities, it's not the cessation activities per se which the government is rolling it out. It's the And it's the legal issues which are coming up, the enforcement of the COPTA as well as the Food Safety Act. These are the hindrance for our cessation activity. With this background, I will say that what we have been doing, one of the important thing in the routine screening, we have to ensure that we have been able to build capacities of the health workers, right up to training of trainers have been completed. And that after training of trainers, what? We have to see that how it translates into action. That means a routine screening happens at the lower level.
Right.
In the routine screening, what we have to do, what cessation advice we have to give. Are we asking the patient? Are we advising the patient? Are we assisting the patient? Are we assessing the patient, or are we arranging any cessation activities or not? These are the questions, 5 A's we have to ask so that we know that we are providing the right advice. That's the first thing. In the routine screening, it is happening, but it's only a mechanical checkbox. We have to move beyond checkbox and see that how this translates into the actual advice, assistance, and arranging for treatment. Other thing is the population-based screening we have been talking about, but it's more or less restricted to cancer screening.
Right.
We have to screen for the this social determinants and the risk factors for tobacco, because introduction to tobacco happens as early as 6 years of age. So that's the kind of experience which people are having. That's why you have rightly mentioned in your presentation that the school department is more important. They will not be listening to our letter which has been written by Health Ministry. Their ministry should be there. But besides that, we have been focusing on mandatory capacity building of the health workers, and other TOTs are there. But we have to move beyond TOTs, see that the actual people who are trained and do the proper advice, as I mentioned about, they should be asking, repeating again, asking, assessing, assisting, then advising and arranging for cessation activities.
Right.
I stop here. I will be taking.
We'll be coming back to you, sir.
Thank you.
So maybe we can shift the discussion to taxation, because recently there has been some reforms, the new GST reforms, which are, I think, GST 2, which has come. So how do you think, Dr. Preetham, that taxation and current fiscal measures can be strategically aligned with public health goal? And are you satisfied with the current GST norms, which has been there for various type of tobacco products?
Thanks for the question. It's one of the critical question I ever faced. It's a central question of any taxation, tobacco taxation thing. The issue is that I'm not very satisfied with the recent move what we got in terms of GST 2.0, because in one hand we achieved to specify 40% tax rate for the most of the tobacco products. At the same time, we went backward and make our BD sector as Achilles heel for the tobacco control in our country. So where the purpose of taxation is increasingly making the tobacco products unaffordable, as well as not making differentiation across the different tobacco products.
Right.
But that is happening. Earlier, all tobacco products are in the same bracket, but unfortunately, I don't know what kind of merit they found in Tendupatta. So they revised 18% to 5%, that is marked as a merit bracket, and 28% to 18%. So BD is one of the most critical tobacco products in our country, which is most common form of smoking, but where we are going backward. At the same time, we reach 40%. That is a welcome thing, but I am not very satisfied with the current.
Right. So I'll come to you for the next question about how coordination can help in this. So maybe in the next round. So I'll shift my talk to education sector. Dr. Harish Kumar Meena. So, sir, you have been there in this sector, and do you feel that education sector can play a very important role and has been playing a very important role in tobacco control? So, can you just list some of the things which the education sector is doing?
So, good morning to all of you. As rightly said, that education, the most of the stakeholders are with the education sector, means children in schools and university and colleges. So the initiation is started in this age only. So interventions by education sector will help us in tobacco control. So already Ministry of Education is doing, like in NCRT, we are doing a National Population Education Project, and Madam Sundara, I met her after almost 10 years. So she was also a resource person in our program. So we are doing some activities at in schools on tobacco control and drug abuse. And later on, under adolescence education program, out of three modules, one of the module was on drug abuse. And later in under Ayushman Bharat School Health and Wellness program, we have a dedicated module on prevention and management of substance abuse. And this program is funded by Ministry of Health, and in almost in 500 districts, we have launched this program. And the program aims at skill development and behavior change, apart from awareness on the harmful effects of tobacco and other products. So the need is the behavior change. So we are targeting the behavior change and the life skills. So that how to say no to these substances. So that is like our main objective under this. Apart from this, the Ministry of Education adopted the guidelines issued by Ministry of Health for tobacco-free educational institutions.
Right.
And we are working from this year, we are working on this very intensively, and we are conducting district level awareness and sensitization programs for education officials, district education officer, and the nodal officer of TOFI in districts, and that principles, so that we can integrate these issues in the ongoing in-service training programs. And further, they will do some, such interventions for the principals. So the 9 criteria which are like developed by health and education. So implement those, which also include activities on awareness and some of the legal aspects and implementation of 100 yards, no tobacco sale and everything, and the boundary. So we are working on this. We are also planning to integrate that the affiliation code of conduct. So whenever any institution got affiliation from state boards or CBSC, and similarly from, so there are some conditions that we need to follow. So we are planning that the TOFI implementation, all the 9 criteria of TOFI should be made part of that
Right.
affiliation process, so that there will be more seriousness towards this.
Right.
So these are some of the initiatives on which Ministry of Education
Right,
is
sir.
working.
So I think these initiative will go a long way, because if we can do something in the school settings, which is very, I think the students will learn these things and imbibe these things for longer. So I think that's really wonderful task by Ministry of Education. So now coming to our civil society, who has been driving tobacco control for so long. I think this is the only program where they are sole driver of the program for so long, along with the ministry. I think academia joined much later. So can you, sir, Mr. Sanjay Seth is here from civil society. I have been already talking to you about your innovative approaches, youth-driven approaches. So how do you think civil society should strengthen more linkages between the government programs and the community action?
Thank you, Dr. Sonu. I think I would like to reinforce what Dr. Swasti Charan pointed out. There is a need for our approach to shift from just awareness to behavior change, because that is really where the issue is. So what is our theory of change? How do we reduce the usage of tobacco, because we still have a very vast 28 crore people are still using tobacco, and it starts at a very young age. The behavior change pathway is from youth norms to household norms to community norms, and then it comes to the enforcement and finally cessation.
Right.
So that's the pathway, and I think that's where civil society really has to work with very closely with the government policies, because what Dr. Swasti Charan has now pointed out, the EYCCS approach, this is a implementation framework, not just a policy framework. So I think we really need to shift. He also made a call to action that we really now need to scale and look for outcomes.
Right.
And this is where I think civil society again needs to lend a very close hand to forcing that change. I can just share our example from Meghalaya, where we have been implementing
Sir Mike.
in all the
Sir Mike, please.
12,500 schools there. We have found, and this is where the convergence part comes in, where again civil society needs to play a role. We have found that toffee, that is tobacco, which now the ministry, I'm so happy that the Ministry of Education is also an NCERT are pushing that very hard also. That has changed students' attitudes. Now, those students have come home and they're telling their parents, and what we are finding is that in the households, homes, in Meghalaya, 40% of homes have now stopped smoking inside the house because
Excellent.
parents came and told them. Now, the same thing has happened with plastic. It has happened with firecrackers, that, starting from schools, it gets into homes. Now, that leads to a norm change in the homes, in the villages. And then you have the police, which is, it makes it socially more acceptable, because as Madam Selina said, ki unless you go to the community, you're not going to really get a behavior change. Right? So we are finding that once it becomes acceptable in the village, then when the police come and do the enforcement, and that is where the convergence part comes in, okay, it is more acceptable that
Right.
that enforcement is not resisted. The homes say yes, and the role which, of course, civil society plays is vital in this whole scenario. So
Right.
let me stop with that.
Yes, sir. So we'll come back to you, sir, for the last comment. So maybe we'll shift to this legal sector, basically. We have a prominent legal expert from Supreme Court of India, Mr. Ranjit Singh, who has been fighting a lot of cases for these issues, public health issues, including safe food and also for tobacco. So, Mr. Ranjit, I think just want to ask you that how we can involve more people like you in this particular initiative, because legal part is really very important in tobacco control. So how that judiciary and legal expert can support stronger accountability for tobacco industry violation and overall tobacco control.
Thank you, Dr. Sonu, and thank you for considering legal and governance as an important part of NTCP implementation. And yes, we need to break the silos and come together. Legal is basically integral to the implementation, etc. And judiciary has played a strong role. So judiciary has, through our intervention, whether on your own or through, or through public interest litigation, what they have taken is that we've had two, three kinds of litigation, and one is mostly on compliance. So there have been, there is a monetary litigation that has happened a lot, where they have constantly checking on the strict compliance of NTCP laws. And on COTPA, etc. And they've also identified certain gaps that are there in implementation. So that's also, they have pointed it out. They've also taken action, taken report. So judiciary has been taken action, taken report from enforcement agency that has done. Now to coming to your question of tobacco industry accountability, sadly we do not have any law in place which kind of puts them into accountability status, unlike you have in other countries, where you can have a class action suit where they can pay compensation. So in this existing circumstances, there are a couple of things that comes into mind. One is Latin term, legal term called res extra commercium, which means outside the commerce. There are several products like alcohol which are outside the count. The moment judiciary declares, which is an ongoing litigation, declares tobacco as an res extra commercium, you tend to get that cover, or I'll say the protection which you have of right to trade taken away. Then you have a lot of accountability that you can impose. There are several cases which comes to my mind where the judiciary has imposed extra cost on the industry for a tobacco control for breaking tobacco control laws. So these are certain things that have done. So what we have done successfully, I will just take one example, a voice of tobacco victim. So there was a considerable, kind of a campaign with the Bar Council, with the Judicial Academy, where the voice of victim went and sensitized it. And these lawyers and judges on their own
Right.
started taking up this litigation, implementation, etc. So this is one way of there
Right.
and making the this industry accountable.
Very good, very good. I think that's a very important point you have pointed out. But so I think we have got the views from everyone. So lastly, because of I think we have some lack of time. So what we'll do is we'll take just one point from each one of you before I hand over to chairs for the final comments. That what is one synergy which you would like to see from your department, from your perspective, that you would like to have in tobacco control? So we'll start with the same order, maybe from Dr. Madan Gopal.
Okay, thank you. Very quick. One of the important things for cessation activity is sharing of clinical data with the education department, enforcement agencies, as well as the civil societies, so that they can utilize it and reinforce the things which they are doing. I
Right.
will just take the voice of tobacco victims that can act as a model for pushing our cessation activities.
Very good. Wonderful. So Dr. Preetham.
I think while having such kind of taxation, like especially for the health taxation kind of thing, we may have people from the different sides, from tax expert, education expert, so as well as the doctors, so that we can educate each other about the nitty-gritty about the subject.
Okay.
I may not have the clear idea about the medical part.
Right.
Similarly, some doctors may not have the clear part about the grammar of the taxation thing.
Yeah. Yeah.
So sharing data among each other, sharing knowledge about each other, that may help to
Yeah.
design the proper taxation, health taxation for specifically for the product like tobacco.
Right. Right.
Or alcohol.
Thank you. Thank you, Dr. Preetham. Dr. Harish.
ये मेरा थोड़ा सा पर्सनल व्यू भी है। सिंस लास्ट 1 ईयर मैं देख रहा हूँ कि 4-5 मिनिस्ट्रीज एक साथ इस पे काफी एक्टिव हो रही हैं। एजुकेशन भी पहले इतनी एक्टिव नहीं थी, लेकिन कहीं ना कहीं मुझे पर्सनली फील होता है कि कोऑर्डिनेशन के कुछ इश्यूज हैं विद मिनिस्ट्रीज एंड डिपार्टमेंट। सो इश्यूज हैं, मतलब कुछ रिजॉल्व हो सकते, सो दैट वी कैन कवर द लार्जर एरिया एट ग्रास रूट लेवल। So this is
So we should sit more often. All ministries should sit more often to discuss about this. So I think that's a very important take from here. So maybe Ms. Sanjay. Yeah.
So I think the first thing we need, what I would want is a theory of change to be accepted for National Tobacco Control Program. And this focus needs to be on behavioral change. And see, while there are different departments are acting, the important part is to remember is that, each has their own separate role to play.
Right.
And then they need to coordinate, as Mr. Meena pointed out. So behavioral change, scale, and outcomes. In my mind, this is where the focus needs to be.
Right. Right. Wonderful. So lastly, Mr. Ranjit.
I can echo the point of the others also. The point is that though Ministry of Health is the nodal ministry, there's too much of burden that's put on them, and it's something as scale as reaching out to 28 crores users cannot be dealt there. Therefore, you have to have other ministry and department. No, you have consumers ministries, you have women and child development, you have education, you have skill development, agriculture. All of them have a role in there,
Right.
and it has to be taken up as a government agenda to come to a final. So each industry, and not only I would say the department, even the National Human Rights Commission, State Human Rights Commission. So these are also very important to involve. So until you have a multi-sectoral approach on implementation, that it's the government's program and not just one ministry.
Right. Thank you very much. And now last comments from the chairs.
Thank you so much. It has been a really interesting session, except one part I'll say, make extensive use of family adoption program where our students are going to the families so that they can bring about a change. And every time we talked about change makers, there are change makers in every sector, whether we talk of health, education or civil society. So कहते हैं ना, बड़े ध्यान से मिलना सबको, ना जाने किस रूप में आपको नारायण मिल जाए. So that is where we have to look at नारायण, जो कि हमारे अंदर से जागृति लाएंगे और चेंज लाएंगे. Thank you so much.
Wonderful. I think Dr. Swasti, last comments.
Thank you. And we had a very wonderful presentation and also panel discussion. And I must tell you that tobacco does not distinguish whether you are a lawyer or a primary health expert or a professor or a tax expert or a civil society or education. It affects every one of us. So we should know our why and work together on how do we do tobacco control in India.
So I think wonderful words by our chairs, and I think yes, we'll come. So with this, I think wonderful words that we should meet often. We should discuss these topics together, not only health but other ministries. So I close this session, but with I think we have our next version of Tobacco Free Times. I was saying about that it's a 38th edition of Tobacco Free Times, which is being released in this forum. So I will like to invite Dr. Umesh Kapil on the stage. आइए आगे सर, आइए डॉक्टर गोयल भी, आप भी आ जाइए. So please come forward for having, we can have here. So again, this edition I was talking about, that those who are sitting in the room, so you can go in our resource center website and access all these editions free of cost. And we have our stall outside. Please come over in the stall and see all these editions there in a physical forms.
Okay, welcome back. We have another very interesting panel discussion on tuberculosis. As all of us know that public health problem, one of the important public health problem is tuberculosis, and especially the multi-drug resistance and the social stigma which is attached to that. So for that, we have a very interesting panel discussion, and I will request Dr. Samir Kumta, who will be the moderator. Dr. Samir Kumta is a senior program officer of tuberculosis and infectious disease at the Gates Foundation for the last 20 years. And he's a qualified in the multiple specialty. He has the qualification. He is a public health expert, MPH. Then he has done his MD in microbiology and diploma in pathology. And for the last 10 years, he has been working in the area of tuberculosis, especially developing the tools for the assessment of patient care and other evaluation and assessment part. So I welcome Dr. Samir Kunta and I request him to kindly moderate this session. Thank you so much.
Thank you so much, sir. And a very good morning to all of you. My name is Dr. Samir Kumta. I'm Senior Program Officer at the Gates Foundation. And it's my privilege to welcome all of you to this session on TB elimination efforts in India. As you know, tuberculosis remains India's greatest infectious disease killer, with almost 3 lakh people dying of TB every year. And yet it is a disease that we know how to prevent, how to detect, and how to treat. The Prime Minister's call to TB elimination has resulted in significant and unprecedented momentum on TB elimination efforts, both on innovating with new tools to diagnose and treat TB, but also to scale up TB through new strategies and existing ones and forge new partnerships. I'd like to invite my fellow panelists to this session. I'll be requesting Dr. Madhumati from ICMR, Dr. Sangeeta Sharma, and Dr. Bharadwaj sir. We are expecting 2 other panelists who will arrive shortly. So before we start the panel, I just wanted to share some introductory thoughts. Over the past several years, the National TB Program has transformed the country's response to TB, from expanding molecular diagnostics to real-time digital surveillance, to deploying direct benefit payments for nutrition to patients and providers, to actually scaling up community-based screening through Nikshay Shivers, and also scaling up private provider engagement. These are not just programmatic achievements, they represent a shift in mindset from control to TB elimination. At the same time, India's research and innovation ecosystem, led by Indian Council for Medical Research, is driving discovery, developing new diagnostics, adherence tools, and candidate vaccines. Increasingly, the tools and ideas shaping the global TB landscape can be generated right here in India. But the road to TB elimination is also complex. Pediatric TB remains underdiagnosed, and achieving TB-free status will require sustained collaboration between medical colleges, public health programs, and communities. Therefore, today's panel bridges together leaders and stalwarts from the government, research, and academia, each representing a critical pillar of this collective effort. We will hear from them on how science, systems, and partnerships can converge to make TB elimination a lived reality for every Indian. To begin today's panel, I would like to request Dr. Madhumati Jayaprakasham, Scientist D at the Division of Communicable Diseases at ICMR, to talk about an overview of the research and innovation ecosystem for TB in India and how ICMR is working with the TB program on the same. Dr. Madhumati's work spans infectious disease surveillance, diagnostics, and antimicrobial research, with significant contributions to the National Surveillance Network for Antimicrobial Resistance in India. She's contributed to developing the ICMR TB validation network and in building the ecosystem for innovative TB diagnostics. Dr. Madhumati has more than 40 publications, 2 patents, and received several international awards. Requesting Dr. Madhumati.
Thank you for that wonderful introduction. And I would like to really thank the organizers, Dr. Umesh Kapil sir and other organizers for giving me this opportunity. And apologies that Dr. Nivedita Gupta, who's the head of the Division of Communicable Diseases, could not join today. But I hope you enjoyed her sessions yesterday. So you'll have to put up with me for another 10 minutes. So I would just take you through the ICMR's innovation ecosystem for TB. After the COVID pandemic, we saw that there were thousands of startups and innovations coming up with new technologies and tools. And not all tools are in the advanced stage of development, and they were in a different levels of development. So as we were receiving these applications, we were wondering how to go about it, because this needed to be validated even before taking up into the program. So the first thing ICMR started was to set up a validation network. So in 2022, we started establishing this network of 19 laboratories with 4 NRLs and 9 IRLs and 6 culture and DST laboratories across India. And ICMR funded 12 of these validation laboratories and some more laboratories who were willing to contribute to this network. We floated the expression of interest, and after several rounds of review, we selected these 19 laboratories. Once we established the laboratories and funded them, ICMR has been collaborating with multiple sectors, multiple ministries, multiple organizations, but particularly for TB, we have a very strong collaboration with the DCGI, and we keep inviting DCGI and CDSCO officials in our review meetings, as well as they invite us in their review meetings. And we conduct regular sensitization workshops so that not only the laboratories, but also the innovators are aware of the regulatory requirements for innovations. We also have a very strong collaboration with NABL and the Quality Council of India, QCI. So currently we have engaged around 60 laboratories across India, where the QCI is training the laboratories, and AIIMS Delhi is one of them. I'm happy to declare that the microbiology department of AIIMS Delhi is also part of this QCI training modules, where the QCI trains the labs so that they get the NABL accreditation, especially the ISO 17025 accreditation. We saw that there were major bottlenecks in validation of diagnostics. So one of the major bottleneck was the funding requirements and legal requirements. They were the processes that were very rigid. For example, when an innovator comes, an MOU is signed, but before signing the MOU, each time an innovator comes, the MOU goes through multiple rounds of approvals. So what we did was we developed a standard MOA and we used that standard MOA template, got it approved by the legal experts, and then we used the same template, and this reduced around 6 to 8 months of validation. Second major bottleneck was the ethical requirements. So we saw that ethics committees would take around 6 to 8 months in most of the cases. So we saw that there were some cases which can be exempted from ethical clearances. For example, if the laboratory already has a stored sample and if no additional sample is collected from the patient. So there were different scenarios. So these scenarios were made and we released this ethical guidance document for validation studies specifically. And then we saw that there were some laboratories that were following their own protocols, and for each innovation that comes, a different protocol is made, and from the beginning, we start making the protocols every time this validation takes place. So what we did was we wanted to make standard protocols so that across India, all labs follow the same protocol and all innovations go through the same robust protocol. We developed different protocols like protocols for NAT tests, for MTB detection, MDR-TB detection, concordance studies, and we developed protocols for screening studies, especially the handle X-rays, and recently we developed protocol for NGS-based studies. So these protocols are developed using a working group of clinical microbiologists who work in TB especially, and they are also vetted by experts working in TB diagnostics. These are available in the public domain, either in the way of published articles or in the ICMR website. So I'll just quickly take you through some of the validation processes that we follow. So we have simplified the validation process into a 3-step process where there is initial screening by ICMR for verification of documents like the test license, CDSCO license, etc. And then there is an internal review, scientific review by ICMR scientists. And then as a third step, we involve our CTD partners, and we review and give this prioritization to the technologies along with the experts from the Central TB Division. We categorize the technologies based on the technology readiness level as TRL 4, 5, 3, or 1 or 2. So we can see that if it is coming under TRL 4 or 5, which means that it is already in the advanced stage of development, and then it goes directly to the multicentric validation after signing of MOU. If it comes under technology readiness level 3 or lesser, it comes under lower priority levels. And so based on that, it can either go for single-centric validation or it can go for just analytical validation. Or if it is not feasible in the program, if the program recommends that we will not be able to take it up, and then it is not taken further. So this is just to show the technology readiness levels based on which we decide about taking the technologies forward. If it comes under the research category, it's around technology level 1, 2, 3, 4. It's still in the research. So our role comes after 3 or 4, where there is in-house validation studies available. They have enough data, analytical validation data, and then we take it for technology readiness level 5 to 6 to 7. Finally, it goes to deployment and delivery. I'll take you through some of the tools that have been recommended by ICMR, validated and recommended by ICMR. So here you can see some of the ultra-portable handheld X-ray devices. 4 of them were validated and approved by ICMR. Mine 2, IN Pro, RAD, Atlas, MyBeam, and E-Ray. And Deep CXR, which is an AI-based chest X-ray. And we had PathoDetect, which was a molecular-based NAT assay. open PCR, which was first in the world TB detection kit, and then sputum and tongue swab based point of care test. And ICMR had conducted validation of site-TB earlier, and also we had earlier conducted this phase 3 RCT of recombinant VPM. So finally, to wrap up, I would like to say that ICMR has been really engaged with the innovators. We conducted an innovation summit during March 19 and 18, along with our partners, Union and Gates Foundation, jointly along with Central TB Division. We received around 217 innovations, which was showcased in a unique experiential walkthrough, out of which 72 were selected. So you can see the segregation here. Almost 71 were under the detect, whereas 60 in treat and 15 under prevent and 71 under build. Out of this 71, ICMR had already approved around 10, or it is already in the market, and ICMR pipeline is currently handling 15 such innovations. So these are some of the types of innovations. With this, I'll just end my presentation. Thank you all.
Thank you, Dr. Madhumati, for that interesting presentation on the innovation ecosystem in India. No doubt, like I said earlier, I think the tools shaping the global landscape could be from India moving forward. I'll next request Dr. Urvashi Singh, Deputy Director General, National TB Elimination Program, Central TB Division, Ministry of Health and Family Welfare, Government of India, to share her perspectives on TB elimination. Madam needs no introduction. She's also Professor, Department of Microbiology at AIIMS, and serves as in charge of the TB division there. Her research spans the entire gamut of TB, including adult pediatric TB, drug-resistant TB, molecular epidemiology, and novel treatment regimens. She's published extensively and holds several patents, and her lab at AIIMS is NABL accredited for advanced TB diagnostics. She brings in a unique blend of academic rigor and operational leadership in the India TB program. And her insights on bridging the gap from diagnosis and innovation to implementation is unique. I'll request her to share the next presentation.
At the outset, I must thank the EFICON, my honorable seniors, Dr. Umesh Kapil, who's been a senior faculty at AIIMS. So what we believe at AIIMS is that, our seniors lay down the foundations which we carry forward. So big thank you to all the seniors. Thank you to Dr. Sameer and the Gates Foundation for this event. And like he said, bringing academic fervor or inputs from evidence to public health is what we are trying to do. So I'm joined by Dr. Mattu from the program, Dr. Bharadwaj sir, who's again a very senior, community medicine expert who's been guiding our national task force, Dr. Sangeeta, and of course, Dr. Madhumati, you just heard. I will quickly run through where the program is today and what new strategy based on scientific evidence, where it has taken us. So I, took over as the DDG last August, and over the last 1 year, we've made several transitions, which I'll quickly try to allude to. So here I bring to you the burden of, the incidence and mortality in the globe, as well as India. So you can appreciate we contribute to a good number, but then what the Global TB report last year summarized was the incidence reduction in India was twice the reduction of incidence globally when taken together. The mortality reduction in India was also ahead of the mortality reduction globally. So coming on to a few high burden countries, of course, this is no excuse, but then we all share the high burden, and what we can do to change this high burden is what we are trying to bring in. This is where the mortality and incidence in India has been over the past few years. And it is incessant efforts of the program experts, of the other experts who support the program from the outside. I mean, it is indeed a collective effort, and we really appreciate every drop, every person who contributes to the cause of TB elimination, because eventually they're all contributing to reducing incidence and mortality. Here, I would like to compliment the support from Gates Foundation, Global Fund, USAID, earlier USAID, now US Department. So everybody has contributed somewhat. But what is noteworthy is that the India program is primarily funded by the domestic funding. So this is again acknowledged in the Global TB report last year. And this year you will see a drastic change. It is the domestic funding which is primarily running the whole national TB elimination program, while we have the people like Dr. Samir, his seniors, Dr. Yogan, Puneet, who have all been actually contributing significantly, who are coming in and helping us bring in new research, new ideas which start very nascent, and we then develop them into big ideas and implement them under the program. ICMR again has a major role, and Madhumati probably just could share, the time that was given to her. She could share what in the diagnostic innovation field they're doing. But frankly, ICMR has been working, toe to toe with the program, whether it is diagnostics, whether it is treatment, whether it is new research. So every time we need anything new, any new idea, any new research we have in mind, we turn to them. And since they're just a sister department, we work very, very closely with them. Now, here is to the encouragement, if I may. Though the burden remains high, but then the efforts of the program are actually filling the gap of missing millions. So last year we reported 26.2 lakh cases, and the missing millions dropped to less than 1 lakh. And this year we hope to do better still, because like I said, we have improvised and modified the strategy drastically based on scientific evidence. Now, this is where I bring in the new strategy. So all along, active case finding and passive case finding were two things which would, while sometimes ACF would be praised more, or sometimes, PCF would be the way of the hour, if I may. What we did was, now this is based on some work which I did at my alma mater, the institute where I stand today, and I take a big, take pride in my 33 years at AIIMS and the learning that this institute did impart to me. Even as a faculty, I believe we keep learning every day. So what we did here was we switched our, again, global first. There are several global firsts. I'm trying to touch upon a few of them. Was that we started looking for subclinical TB. Now, how we did that? Again, the science came not only from our NICSHA data, which is a huge digital portal, again, we can boast of, which showed us that the vulnerable population contributes to 80% of a TB burden. Also, the the prevalence report, the National TB Prevalence Report published by Central TB Division along with ICMR in 2022, brought in these facts that the vulnerable groups contribute to 80% of active TB. So what we did was our experience I mentioned, I published about 10 years ago, that subclinical TB in patients with diabetes mellitus type 1 can actually be picked by culture. So if it can be picked by culture, these patients continue to be asymptomatic. So what we did was we started doing active case finding in our vulnerable population. We picked the top 8 vulnerable populations: the alcoholics, smokers, TB, the diabetics, PL-HIV, those who had TB in the past, those who are in contact with TB patients, geriatric population, and patients with BMI less than 18.5. The patients with BMI less than 18.5 contribute about 46% of our TB burden in the NICSHA portal. Now, when we tried to do this, we were again strengthened by our program team all across the country. we reached out to the vulnerable patients who were asymptomatic. So practically doing active case finding in all the vulnerable populations. Of course, we have additional vulnerable populations. The list is long, but to name a few additional ones, like the mining population, the congregate settings, those who are living in tribal areas, far-reaching areas. Another thing that the TB prevalence survey had pointed out was that the health-seeking behavior remains a little low in our country. So that was another reason we wanted to do active case finding, and we started doing X-rays for all these vulnerable groups, whether we had fixed X-rays or we could manage handled X-rays. Now, our efforts over the last 1 year, we've now procured 2,000 handled X-rays, which have very small radiation exposure. And as we speak, these X-rays are being made available. But till such time, the fixed X-rays available with our facilities, which count to about more than 25,000, were utilized. And now we are, enhancing our capacity. I'm already out of time, but there is so much I would like to share with you. This is, in addition, the OPDs where vulnerables are being followed. We offered screening, and we are again enhancing all these efforts. This was the strategy. And 10% of in-bed, the strategy was basically the ASHA workers who were actually our foot soldiers, mapped the vulnerable population. We're using an AI tool to find hotspots of transmission. So frankly, vulnerable areas, if we may. We did intensified case finding using X-rays for screening. Confirmation was done by NAT. And frankly, during our efforts, countrywide, our NAT offered as universal DSC or baseline UDST enhanced to about 70% across the country. Again, this was the fruit of several years of hard work. TrueNet, which is an Indian indigenous technology, can reach the periphery because it's a battery-operated system. I think Dr. Madhumati did mention it was validated by a multicentric project initiated at AIIMS by me, supported all through by ICMR, and that is when we had enough results. ICMR recommended it to the program, which adopted in 2018. Today, we have more than 9,000 such machines. Let me, before I move on, allude to the TB mortality reduction, which again is a major component of our efforts. Where you see, if we are doing active case finding, it contributes both to reducing incidence, because the earlier we diagnose a patient, the earlier the transmission in the community stops. So we break the chains of transmission. Not only that, when we are screening the vulnerable population, we identify them early so as to reduce mortality due to the diseases working together for worsening. A comorbid condition could lead to morbidity, mortality due to TB. So if we diagnose early, we obviously reduce that, possibility of a worsening disease. Differentiated TB care approach is another feather in our cap in the last 1 year. Of course, it was being followed in piecemeal in several of our states and districts. But then we laid down the guidelines, and we laid down red flag signs, which we trained our ASHA workers in, our CHOs in, where they could identify a person who would worsen soon and would need admission in a higher facility, or in, so on and so forth. Nutrition support is something which the program has been working for a long time. Again, evidence generated within the country, not one, but several studies. And I can not stop talking about the outcomes of those studies. The program had initiated direct benefit transfer, that is, transfer of money, which was 500 rupees per month since 2018 till last year. And we enhanced last year to about 1,000 rupees per month throughout the course of the treatment, which is 6 months to 9 months, whatever the course of treatment, the patient gets this benefit. We also give direct benefit transfers to those who are notifying patients, the ASHA workers, for account verification, and so on and so forth. So tribal area patients, when they travel, for travel costs, reimbursement is given, so as to encourage patients to come to a healthcare facility and get the diagnosis, which is, like I said, state-of-art, handled X-rays, state-of-art. We also expanded the symptoms to 10 symptoms. And frankly, when I proposed this, I was questioned that WHO doesn't recognize 10 symptoms. I apologize that WHO could follow us. India can be the first here as well. What we did was nothing out of the ordinary. We just included early signs and symptoms, and expanded the 4S, which were delayed signs, to 10 symptoms. And our ASHA workers, CHOs, our medical officers at the periphery got trained in this. And like I mentioned earlier, chest X-rays, which are handheld X-rays, and Dr. Madhu already shared a lot of X-rays, handheld X-rays that they have approved of. I was talking about TrueNat and a NAT network. We have more than 9391 NAT network. Another new thing we did was we roped in our sister ministries. We had MOUs with 23 of these ministries who joined us in our efforts towards reducing stigma, making our wonderful IC material. If there is time, I would love to show those videos and lot of IC material which reduces stigma, which encourages treatment adherence, vulnerable population, IC material on nutrition. So this is the achievement since the Abhiyan started in 7th December. And initial 100 days we had it in a few districts, but then it expanded across the country. And we have already notified close to 5 lakh patients, because this is the data of 9th November, of which you will appreciate the vulnerable population screened is close to 20 crore. And the asymptomatics, probably the number is not here, but close to 10 lakh of the notified patients were asymptomatic to begin with, which means they would have come to us, but may come to us very late. And, would have transmitted in the process, the community transmission would go on. This is, I would like to acknowledge the support of our TB Vijetas, our champions, and community influencers who continue to support us by actually helping patients reduce stigma, adhere to treatment completion, and good outcomes. Now, this is what we did in November last year, enhance the direct benefit transfer to 1,000 rupees per month. Energy dense nutrition support is again research done in this institute by me and my collaborators in the community medicine department. Dr. Rakesh, I'm not sure if he's here. At our Balabgarh center, supported by ICMR again, where we showed that giving the energy dense nutrition support brought in the same change as the outcome of ration study, which is very well known, which actually helped us in Anikshay Mitra basket to be expanded to the contacts of the TB patient. So these were the 3 initiatives. Energy dense nutrition support is now being given to patients with BMI less than 18.5 for the initial 2 months. These are the DO letters. Now, the Anikshay Mitra concept has actually been expanded to also offer psychosocial support to, in fact, the youth have been involved. My Bharat volunteers are offering psychosocial support and completion of treatment to our patients, which is again something we acknowledge freely. Now, these are the guidelines that have been rolled out. BPAL-M is again a first. No other country has rolled out such a comprehensive regimen. We have included 4 drugs. Even in pre-XDR, we include Moxi in FQ resistant based on the outcomes of the TB practical trials, which gave recurrence-free cure. And that was the essence of doing this. And let me share with you, close to 15,000 patients are now on this treatment across the country. Our last year's numbers were close to 55,000 MDR TB across the country, which were revalidated on the ground by us, not only in the Nikshay. The point being, the BPAL-M is doing very well. The treatment success rate is more than 90%, and we love the regimen, and we hope to do better by covering more patients and obviously reducing the mortality, improving the treatment outcomes in the MDR TB patients. We are using digital technologies for ensuring adherence, where we use not only 99 dots, but sometimes 99 dots light, which can be easily monitored on the Nikshay portal. Differentiated TB care, I mentioned earlier, we identify patients who can become worse. You can have worse outcomes if they need a referral or an admission is facilitated. Dr. Mattu, who's with me, takes care of the DRTB, the differentiated TB care, etc. with me. And again, briefly about, I've mentioned this is about the TB preventive treatment. I'll just allude to the numbers. We have the latest recommended very expensive regimen, 3HP, in surplus in the country. And we have covered a good number on 3HP, 1HP for PL-HIV. SCI-TB is an TB infection test, again validated by ICMR, but frankly, For our household contacts, we are recommending TPT to be covered in a big way. And again, there's a big push because there is evidence to show, at least in the household contacts and the vulnerable population, TPT can actually bring down. This is just to briefly share with you a huge supply chain which is monitored daily, digitally at the Central TB Division by our team. And the BCG vaccination study, I know I'm running out of time, so I'm rushing through, but I can take questions later. We have been able to immunize more than 1 crore population, 11.2 million beneficiaries who were in the vulnerable groups, as you can see. I'm fine. Briefly to share with you the AI, how to supporting the program, and let me also share with you the zeal with which we work. We are going to bring in more new strategies, and we are open to any suggestion, every observation any of you may have in your respective fields. Thank you. Questions now or later?
Thank you, ma'am, for that interesting peek into the stellar role being played by the National TB Elimination Program. I'd now like to invite Dr. Sangeeta Sharma, Consultant and Chief in Charge, Pediatric Center of Excellence and former Director of National Institute of Tuberculosis and Respiratory Diseases. Madam has contributed to national policy by serving as a member of the National Technical Expert Group, as well as a member of the WHO Technical Guidance Development Group. She has published extensively and has been a central figure in advancing India's pediatric TB response. She has received several awards and has served earlier as Vice President of IAP. Madam, may I request you to share more on the management of pediatric TB as a part of the National TB Elimination Program?
ये फोटो अच्छी आएगी मैडम यहाँ से अदरवाइज आप छुप जाते हो
चलो चल जाते हैं ऊपर
अच्छी
Thank you so much.
फोटो लेना भाई हाँ मैडम की बुलंद
So, I mean, thank you to the organizers, Professor Umesh Kapil, the Bill Melinda Gates Foundation, and the other organizers for inviting me. I'm so privileged to be standing here. That shows the commitment of the program, as regards to pediatric tuberculosis. In fact, when I started my journey at NITRD, I realized in 2003 that, pediatric TB is a problem and a burden. I went to my director that, sir, we need to have some guidelines, for the country. The answer which I got was so disheartening. He said, pediatric TB to koi problem hi nahi hai. So, but luckily he agreed and we came out with the first guidelines in 2003, which were implemented in 2004. The program has gone, I would say not inches, but miles ahead. And we are very lucky for the steering team, headed by our Honorable DDG TB, Dr. Urvashi. Whatever is the latest with the WHO, we are there to adopt it for pediatric tuberculosis. So without wasting time, I'll now just touch briefly about how we are managing the children to date. This is open and we are adopting the WHO guidelines. I've contributed to the WHO guidelines also in the pediatric part. So, but all what is there for WHO does not suit us. So, a brief outline of our program. So, this is Chalnga. Excuse me. Yeah. So I'll be just discussing about the management of pediatric tuberculosis under NTEP. So, we all need to understand that children, they behave a bit differently from adults. But the scenario which I've experienced over the years, 26 years working in my premier institute, NITRD, as the pediatrician and chief in charge, is that I hardly see now primary tuberculosis. So majority of children, they come either in the late stage with bilateral extensive disease, which behaves no differently from what you have in adults.
But mind you, still, the research, the high risk factors, they are different. We have TB more in less than 5 years. And even there, the diagnosis is more difficult regarding the microbiological confirmation than malnourished, HIV infected and exposed and contacts. The incidence, the true incidence, WHO says that the estimates are that we have, 10 to 12% of the caseload should be notified for children in our country, but we are still struggling at a figure of 6 to 7%. Now, disease presentation and manifestations, children, sometimes the presentations, they can be really vague. A child may just present with a cervical lymph node, which could be due to other common childhood illnesses. And obviously, then we have difficulties in the management as regards to diagnosis, treatment, and even monitoring of children, because as they improve on treatment, the specimen collection becomes all the more difficult. So this is the algorithm which we are following under the program as regards to diagnosis of pediatric tuberculosis. So whenever there is a child who presents, this is for a new patient. Whenever there is a child who presents with fever and a cough of more than 2 weeks duration, with or without weight loss or anorexia, which is unexplained, and there is a history of contact with active TB for last 2 years, the first thing which we do under the program is we get a chest X-ray. Now, depending upon the findings of the chest X-ray, if the findings are suggestive of tuberculosis, by that I mean that there is a fibrocavitary disease or miliary mottling, miliary shadows, or there is, hilar or paratracheal lymphadenopathy, we immediately go ahead with the microbiological confirmation. Send the most appropriate sample as per the age. Could be a sputum for an older child or a gastric aspirate for a younger child, or even an induced sputum for children who are giving saliva samples. And depending upon that report, we decide whether it is microbiologically confirmed or clinically diagnosed. And now coming to the non-specific shadows, which are very frequent in children, the first thing which is done is we give a course of antibiotics. And mind you, please don't prescribe the fluoroquinolones or linezolid. The safest option is amoxicillin or augmentin, that is coamoxiclav, because they are low under ATT activity as such. So after giving a course of antibiotics, then we repeat a chest X-ray, and if the symptoms and the chest X-ray, it still shows persistent shadows and symptoms, then we go ahead with the microbiological confirmation. For normal chest X-rays, if the patient is having symptoms, it could be extrapulmonary tuberculosis. And in all the cases, if the diagnosis cannot be made or there are some problems, then there is always an option to refer the child to a higher center. And for all notified cases, mind you, HIV needs to be done. And the child needs to be notified under the program, because as I discussed, our notification rate is very low. So presently, the sampling methods I was already discussed is the self-expectorated sputum, induced sputum, or a gastric aspirate. Now, this newer tests and the samples in the pipeline where the research is already taking place and we are in the process of validation is that is expert ultra for stool, urine, oral swabs, or a nasopharyngeal aspirate. Now, this is the integrated diagnostic and treatment algorithm, which we also follow for children. The same as is for adults. The basic, the most important thing is that, standing over here, if I'm able to convey a simple message that all who take care of children, please do try to send the samples for microbiological confirmation. Our mindset tells us कि यार ये बच्चा है, इसका तो sputum क्या आएगा, इसकी confirmation क्या होगी. So we do not even care to send this specimen. Rest, these, depending upon, as Madam has already said, if the child has MDR and the age is more than 14 years, under the program, we are giving BPAL-M at the same doses as for the adults. For children who are less than 14 years, then depending upon the severity, if it is non-severe, then we give the shorter MDR-TB regimen. Now, again, bedaquiline based, I'll be talking about that later. But if the sensitivity shows and the disease is severe, then there's no other option except the longer all oral regimen. For drug sensitive, we give the same 2 RSZE, 4 RHE. And for H monopoly, same regimen as is for given for adults. That is, we exclude INH, we add, the fluoroquinolone. Now, these are the treatment regimens which are available, the same as what you have for adults. Now we have the FDCs which are available for children for all for drug sensitive. That is 3-FDC, which is a dispersible tablet, 75 rifampicin, INH 50, and pyrazinamide 150. The non-dispersible 4-FDC for adults. So depending upon the weight band, we choose the stratified according to the weight band, and as the child increases in weight, we go to the next weight band. So and now we have all the formulations which are available for the MDR-TB drugs. The regimens which are there for children, as I've already highlighted, under the program, we are still awaiting approval for bedaquiline to be given for children less than 5 years and 15 kg. For Delaminate, we have got an approval that any age, but the weight needs to be more than 10 kg. So unluckily for our children who weigh less than 10 kg and we have to give a longer regimen, we are forced to use the injectables. And even to use injectables for children, who are less than 5 years, because bedaquiline cannot be given in them. So otherwise, we are doing quite well. Now, a word about the TB preventive. We again screen the 3 high-risk groups. That is the household context, the HIV positive and high-risk children. That is those children who have malnutrition, etc. And the regimens which are available, the program is using 6H. For all children, including HIV, 3-HP has been rolled out for children more than 2 years, and Levoflox for MDR-TB context, or Moxiflox, depending upon the resistance. For pre-XTR and XTR, it's only airway control and proper sputum disposal. And pyridoxine has to be given. So finally, to conclude, pediatric tuberculosis remains a hidden epidemic under NTP, primarily due to the diagnostic and reporting challenges. And however, with the recent advances in diagnosis, treatment, monitoring, and management, we are, I think, doing reasonably well in our country. Thank you so much for your patient hearing. Thank you.
Thank you, ma'am, for that deep dive on pediatric TB management. I'm now pleased to invite Dr. Sanjay Kumar Mattu to speak on pediatric TB and NTEP perspective. Dr. Mattu is Joint Commissioner and Additional Deputy Director General at the Central TB Division in the National TB Elimination Program, and has several years of experience as a senior public health professional. Dr. Mattu is nodal officer on point for public-private mix, management of drugs susceptible and resistant TB, pediatric extrapulmonary TB, TB with comorbidities, and on point for operations research under the TB program. He's also worked in emergency medicine for almost 10 years and on international health regulation for several years. Requesting Dr. Mattu to share broader perspectives on pediatric TB from the National TB Elimination Program.
Thank you, Dr. Samir, Gates Foundation, AIMS Institute, and Dr. Umesh Kapil sir and the organizers for having this workshop here and conference on the EFICON. Earlier speaker has already mentioned how the research has been done in the TB program and how the TB program is having the various activity which will lead us to a TB elimination or TB Mukt Bharat. And Dr. Sangeeta Sharma has already mentioned some details about the pediatric tuberculosis, how complicated it is. We already know that we are having a certain difficult situations where it is very difficult to diagnose and manage the pediatric tuberculosis. We all understand the pathophysiology is very different in the pediatric age group and the adolescent group as compared to the adults. The airways are very small, and when we are having the nature of the bacillary, it is posi-bacillary. Undernutrition, which is also a very prominent risk factor for development of tuberculosis, is very high in this children age group. So these parameters make us a critical situation, and we already know a sample collection for the pediatric tuberculosis is very difficult. Either we need some special procedures where you need gastric aspirate and some lavage is to be done, or bronchoalveolar lavage or induced sputum massage would to be taken to make the diagnosis, because we cannot make the small children to cup out the and break out the sputum. So these are the challenges which leads the complication of the pediatric tuberculosis. Now I will reflect how the programmatic data is there and how the TB is in the programmatic setting we are able to cover up and diagnose. So it is estimated globally that if you are saying that total country load of tuberculosis, almost 10 to 12% of TB is to be estimated from the pediatric age group. And it is global phenomena. We are seeing that almost 50% of the pediatric tuberculosis are missing globally. India is not different. You can understand this graph is showing year-wise from 2012 to 24, how we are able to diagnose the in absolute number. And you can see this absolute number is increasing over the years. And in 19 it was maximum. After that COVID effect came, and then further we again regained the momentum, and we were able to diagnose more and more tuberculosis cases. But if you want to see the percentage wise, it is hovering near about the 6%, 7%, or somewhere 5.5% every year. So still you can understand almost 50% of cases are being missed as per the estimate which we are estimating as a pediatric TB load in India. And this is what I was saying in the earlier slide, and it is reflected here also. Like if you want to say, if all age groups are to be compared, what is the proportion of the missing case? So you can see this yellow part is showing the missing case and of the total estimates, and blue part is showing that what we are able to notify. So it is estimated almost 33% of if we are seeing other age groups are the missed cases. In less than 15%, it is 54.3% cases are missed. When we are saying further breakup 5 to 14 age group, it is 46%, and in less than 5%, it is the highest number of the missed cases, which are the 63%. So you see that as we are having lesser age group, the pediatric TB cases are missed, and we understand the reason are very obvious. Pathophysiology is one thing. We need specialists, usually pediatricians are needed to diagnose the cases, and somehow we are not having appropriate behavior also, like if some person is failing to thrive and not able to gain weight, so we need to suspect that the person might be having TB. So those behavior change and over cautious attitude towards this diagnosing tuberculosis in the pediatric age group can decrease this missing gap. Now, when we are saying the pediatric TB notification gender-wise, so when we are saying all ages, we understand that male population, we are seeing more cases, almost near about 60% or more than 60% cases will be in the male. But when we are having in the pediatric age group gender-wise notification, if you will see, female is having more tuberculosis than the boys. Okay, so girls are having more cases. This is one contrasting feature when we are comparing all other age group, the data. Then if you want to see how the pediatric and adolescent TB notification has been doing over the years from the public and private. So in both the age group, in the 0 to 14 and adolescent age group, you can see almost similar number of cases are being notified in the public and private over the years. And if we can say it is almost near about 50 or 55 in government, and then 45 to 50% cases are in the private sector. Okay, so over the year, that is why it becomes very important point here. Like we need to have the collaboration and involvement of the private sector, and especially the pediatrician IAP who are associated with us, where they are having the regular training, and the CMEs of the pediatrician. So this is one factor where we need to focus, that we need to have the private sector engagement and the pediatrician involvement. If you want to see the pediatric and adolescent notification as was the site of the TB disease, so you can see that if we want to have pediatric notification, almost 45% of the TB in the extrapulmonary site of the total TB cases. It is a quite large number. We are in adult population. This extrapulmonary tuberculosis ranges somewhere between 30 to 40%, but in pediatric, extrapulmonary tuberculosis is more, which is near about 45 to near about the 48% over there. The percentage remaining same. In the adolescent population, it is reflecting in the similar nature when we are saying it is in the adult population, where we are seeing about 30 to 40% of the EPTB cases are found. So in adolescent, we are having the similar things. If you want to see the bacteriological confirmation of the tuberculosis, because as I suggested earlier, it is a possibility in the pediatric age group. Bacteriological confirmation is very difficult. We are not having adequate sample. These are the challenges. And we need many times the specialist only, the pediatrician, to do special procedures like gastric lavage and the gastric aspirate, bronchoalveolar lavage, or induced sputum are needed. And because of these a positive or the shortage of the skill sets, we are having a less bacteriological confirmation. In bacteriological confirmation, if you want to see a pediatric age group, it is near about 20% has been the bacteriological confirmation in the pediatric age group. Adolescent, it is somewhere higher. We are having 40%, and if you want to say the adult population, near about 60% of the bacteriological confirmation is there of total TB cases. So you can see that how the epidemiology is differing between these children and adolescent group as we compare to the adult population. This diagram was already explained by Dr. Sangeeta Sharma. It is similar here. We are having a chest X-ray at the first time when we want to diagnose the tuberculosis, and along with the chest X-ray, why we are doing it at the earliest stage, because we want to have the pediatric opinion, and chest X-ray reading is difficult by the general physicians. We need a pediatrician. So whenever the kids is going with the symptoms of the tuberculosis to the pediatrician, they have to have the X-ray with them, and they can do the procedure. And after X-ray and NAT test, we can diagnose. Whenever X-ray is showing shadow and NAT is not coming, as Dr. Sangeeta Madam suggested, we have to give the antibiotic course. Definitely, it's not to have to a fluoroquinolone, the linezolid, some general antibiotic like amoxicillin may be given. And if the person is not responding, then again we have to do gastric lavage or gastric aspirate to have the samples, and then we can again do this NAT testing to confirm the diagnosis. A probable clinical diagnosis on the basis of the radiology only to be done after ruling out all other possible causes of the symptoms. Already Madam has suggested how the program is doing. I just want to stress here on that along with the pediatricians and the private sector, we have to have the collaboration with other health programs also. Like we are having the RBSK program, which is the Rashtriya Bal Suraksha Karyakram, and the Rashtriya Kishori Suraksha Karyakram, where the these kids are going. So we have to have the active screening. Whosoever visitors are there in these sites, we are having good collaboration with the RBSK there, with the mobile health team. We are having the checklist and the TB symptoms are there in that. We are having NRC centers also, where the nutrition rehabilitation centers and active screening is to be done in all the visitors and the admitted patients in the NRC. And we are having a medical colleges support also, through which we are having the pediatric center of excellences, where they are discussing difficult to treat TB, pediatric TB cases, and then they are conducting respective different trainings also to have the capacity building of all the physicians. So this was some of the slides, and this is the last slide from my side, about I want to have some reflection, a programmatic reflection from the for the pediatric tuberculosis. Thank you very much.
Thank you, Dr. Mattu, for that rich and data-driven perspective from the TB program on pediatric TB. I'll now request Dr. Ashok Bharadwaj to speak on the role of medical colleges in TB elimination. Dr. Bharadwaj needs no introduction. He's Professor Emeritus at Medical College and Hospital Solan, Himachal Pradesh, with several faculty appointments earlier in medical colleges in Shimla, Kangra, and Hamirpur. He's been serving as the chairperson of the National Task Force for National TB Elimination Program, guiding policy and operational oversight at the medical college interface. He is also the national president of the Indian Association of Preventive and Social Medicine, and a recipient of several multiple orations and fellowships. So it's a pleasure to have you on this panel, and may I request you to speak on the role of medical colleges in TB elimination.
Thank you. EFICON, Dr. Umesh Kapil, and the GATE Foundation for giving chance for TB elimination program for having this important parallel discussion. So what is happening in the country for TB elimination efforts? So whatever time we have taken extra, so I will cover that. So I will not have any presentation. So I've just enumerate what activities we are doing in medical colleges and what we should do in medical colleges. So in medical colleges, I classify activities in under 4 heads. The one is the management of tuberculosis. The second is the capacity building in the medical college and outside medical college also for the field functionaries. Third is the advocacy for the program, and fourth is the operational research for the benefit of the program, so that certain aspects of the program can be modified accordingly. So I will devote much time on the management of tuberculosis in medical college and outside medical colleges. So first and foremost is the early diagnosis and treatment of all TB cases. So for early diagnosis, so we should not miss any chance to detect and confirm a case of tuberculosis. So in medical colleges, we have got outpatient department, we have got inpatient department. So in outpatient department, as Madam DDG has told that under the program, at least in tertiary institution which medical college belong, we should have at least 10% referral from OPD for TB screening from each medical college or other tertiary institution. But the situation is not good in this aspect. So not more than 3 to 4% patients are referred from medical college, and another, all vulnerable patients which are attending OPD in medical college, all should be referred or screened for TB at least once in a year. So this is OPD screening. Then second is, whenever we missed it, if the patient is admitted, we should mandatorily screen all indoor patients who have got 10 symptoms. We used to have 4 symptoms. Now the symptom has been expanded to more wider. It is 10. So we have to have X-ray for these patients. We have to screen them through molecular testing, and described and the diagnose them and put them on treatment. So outdoor as well as indoor. So I think we have to, because medical college have got special clinics, diabetic clinic, smoking cessation clinic, other clinic also. So we must try to screen as many cases as possible from these special clinics. So this is as a management and the treatment. So treatment should be initiated medical college. If the patient is referred outside medical college, then the patient should be given at least 7 days course so that the patient can take in between. So this is management. So DRTV, as Madam Rushi mentioned, the BPAL regimen, we have to promote in medical colleges. Those medical colleges are doing it. So we have to, but the number is not that much, which we should say from medical colleges. So we have to promote VPAL regimen in medical colleges so that the cure rate is more than 90%. This is when Madam talk about differentiated TB care. So those vulnerable patients, we should subject them and on priority basis, they should be treated, they should be managed, and we should have at least 2 to 5 beds in our medical college hospital for admission if it is required for any patient, for depending on the seriousness of the patient. So this is for differentiated TB care. Then we cannot think of eliminating TB from the country if we do not prevent new infection. So for preventing new infection, we have to have TB preventive treatment. So in medical colleges, whenever I visit medical college, they say that it's not our responsibility. Yes, they don't have time, but I always say that please advocate for DPT so that this is the patient is advocated and the patient go back and have the implementation of DPT in the field level. Then we have to have the capacity building. We have to have. I always say that the nearby community health officers in health and wellness center, Ayushman Arogya Mandir, we should, if we have the facility, if we have the time, we should try to motivate and sensitize these officers from time to time so that they take active part in the program. So with all efforts, we have to support the program. The medical colleges are reporting 50%, 15% of the cases, means about 4 lakh cases. We have got more than 800 medical colleges now as per NMC website, and more than 700 colleges are actively involved in the TB elimination efforts. More than 60% colleges which are involved, they have got net facility, and more than 10% each medical college, they have got first line LPA, second line LPA, and about CDST labs. So as per the program, these facilities have been upscaled. More and more NARD services are coming up, and more medical colleges are having these activity, this facility. And those who do not have this facility, they are linked to the nearest center. So we also, about 3 years back, we also participated in a large number for sub-national TB-free certification in 3 rounds, 2021 to 2023. In first round, 55 medical colleges were involved because number of districts were less. In second round, 198 medical colleges were involved, and in third round, around 300 medical colleges are involved, where the Department of Community Medicine, through IIPSM in each medical college, helped the system to verify secondary data verification, the monitoring of the field survey, as well as the drug data verification. So these are in short the activity of medical college, and we always promise Center TV division that we will continue sustain these activity, and we will try to
perform better as compared to we are doing it. Thank you very much.
Thank you so much, sir, for that interesting perspective on the role of medical colleges. I think we are short on time, so we'll not take questions today. But I just want to, on behalf of EFICON and the Gates Foundation, I want to once again thank all the panelists, Dr. Urvashi Singh, Dr. Madhumati, Dr. Sangeeta Sharma, Dr. Sanjay Mattu, and Dr. Ashok Bharadwaj for their thoughtful and inspiring insights. What we've heard today reinforces that India's path to TB elimination will rest on three pillars. First and foremost, the continued strength of the National TB Elimination Program in reaching every person with timely diagnosis and treatment. Secondly, the power of innovation and research to bring new tools to the field faster. And last but not the least, the partnerships that connect government, academia, and communities. I hope you found this panel session interesting, and I hope this will inspire you to also continue supporting TB elimination's efforts in the country. Thank you so much.
So since there is shortage of time, if there are questions, we'd appreciate if you can write to us, on our emails or something. Thank you.
Dr. Amit. Thank you, Dr. Samir, for conducting this session. Now, the next panel discussion is equally interesting, and it is on safe motherhood, what challenges and issues are there. And to conduct this session, I invite Dr. Amit Shah. Dr. Amit Shah is a country director, JIPIGO, and he has more than 20 decades of experience in public health. And he is responsible for all the programs which are being implemented in the country. Earlier, Dr. Shah was the executive director with Resolve, and he was looking after the cardiovascular program in the country. So over to Dr. Amit for conducting these sessions. Thank
you. So, good morning all. So, I hope everyone gets a chance to settle down. Yeah. So, it's definitely a privilege to welcome you all today for this important session, The Long Road to Safe Motherhood, Celebrating Success and Confronting Challenges. So, today morning as I was preparing to come to the venue for this EFICON workshop, I recollected a similar discussion held at this very same venue exactly 15 years ago. I was participating in a roundtable discussion on safe motherhood that was organized by the White Ribbon Alliance. The discussion was chaired by Dr. Vinod Paul Sir, member Niti Aayog, who was then serving as a faculty member at this prestigious institute. At that point of time, the discussion centered whether India will be able to achieve the MDGs. The MDG 5 target then was to reduce MMR by 3/4 between 1990 and 2015, which for India translated to reducing MMR from 560 in 1990 to 140 in 2015. I distinctly recall the deliberations on that day. What gave us all hope was the National Health Mission, which provided a unifying systems framework, the ASHA workforce, and several maternal health initiatives that were part of the national program. Today, I believe the results are there for all of us to see and to celebrate. Over the last 2 decades, India has rewritten its maternal health story. From a time when maternal deaths were considered inevitable, we now stand as one of the very few nations, large nations globally, to have more than halved its MMR in just a decade, from 130 to 88. Now, mind you, this is not just a number. It represents thousands of lives saved, countless families kept whole, and years of sustained efforts. It's a testimony to the efforts of all the healthcare workers, the policymakers, the program managers, the communities, and also public health experts. The national health programs such as JSY, JSSK, PMSME, Lakshya, Suman have all together transformed access and accountability in maternal health. The expansion of FRUs and the increased availability of skilled birth attendants has strengthened the backbone of safe delivery care in India. But while we celebrate this progress, we must also confront the reality that still for too many women, pregnancy still carries a huge amount of risk. In India, complications like PPH, preeclampsia and eclampsia, sepsis, and obstructed labor remain the leading culprits. Conditions, all of these are conditions that can be predicted, prevented, or managed when health systems function in harmony. So, for today's discussion, it's not only about what has worked, but what more needs to be done to accelerate the momentum for improving maternal health. As we look ahead for this August audience, I would like to highlight 3 questions that merit our collective reflection. First, how do we ensure that emerging evidence doesn't stay only in academic journals, but gets embedded into India's national health programs, protocols, and state level practices? Second, how do we build coordinated care pathways for high risk pregnancies, where the woman isn't just identified as high risk, but is tracked, followed, and supported across her journey from antenatal to postnatal care? Now, nearly half of all pregnancies in India today fall in this category. Identifying risk is only the beginning. What matters is continuity and timely quality care to ensure a successful outcome. Third, how do we measure progress more meaningfully? Our ability to measure maternal mortality has evolved, but we all know data alone cannot save lives. How do we use data to inform accountability, resource allocation, and action at all levels of the health system? Now, the panels that will follow today as a part of this plenary will deep dive into these 3 very dimensions. The first panel will explore evidence-based practices for managing PPH, preeclampsia, and obstructed labor, the 3 conditions responsible for most maternal deaths. The fireside chat will unpack how we measure MMR in India, the data systems behind the numbers, and how to interpret them for policy action and program enhancement. And the second panel will bring the conversation to the front line, examining how coordinated care for high-risk pregnancies can move from concept to practice. In closing, I would like to reiterate that safe motherhood is not the responsibility of one program, one cadre, or one level of care. It is the outcome of an interconnected health system, one that sees every woman as more than a case and firmly believes that no woman should die giving birth. I would like to thank the Health Ministry leadership who helped us in conceptualizing this session. Dr. Pawan Kumar sir was supposed to be here today to share with us India's remarkable progress in MMR reduction, but he had to go on official travel abroad at short notice. I would like to thank Dr. Umesh Kapil sir, who was gracious enough to accommodate our request for this session that has been jointly put together by close colleagues at the Gates Foundation, Shailendra and Anchita, our Japaigo team, and all partners represented here today. I hope all participants benefit from the rich insights from the distinguished speakers for this session. Thank you very much. Thank you.
Thank you, Amit. Thank you so much. As Amit said, we have tried to divide the session into three parts. And we were planning to start with the first panel, but one of our panelists was called in another meeting at the last minute. So he said, why not start with data? This is an epidemiology conference. So let's start with the measurement piece first. May I request the organizers to just have two chairs and two handheld mics here, please, instead of there, just right in the center. I'm calling my good friend, colleague from Pub Council, Dr. Abhishek Hazra, to join me for this conversation on measurement of maternal mortality. Abhishek, can you please join us? Sorry for making you wait, but if you're sitting on a side table, it doesn't really feel like I'm chatting to my colleague with my colleague. Abhishek, while they're setting it up, why don't you just give a short introduction to yourself and just your background so that people know where you're coming from, and then I'll take it over from there with my background.
Sure. Thank you. Thank you so much, Anchita. And good morning, all of you. My name is Abhishek Hazra. I have been working with Population Council in India for about 16, 17 years. I'm a trained statistician and then did my PhD in demography, particularly in the area of healthcare financing. And for that, so many years, about 2 decades, I have been working with data very closely because statisticians love data. So I'm not an exception. So I love data, but I got also the opportunity to interpret data from the program lens. And also the policy, integrating with policy. So that's how I come, and I have been working in this space for about 2 decades and currently working as the Director for Program and Policy Science at Population Council India office.
Thank you, Abhishek. And I think that's one thing we share in common, our love for data. I am Anchita. I presently work with the India Country Office of the Gate Foundation, and I lead the maternal newborn health work there. I am a public health professional by training. So as he said, statisticians love data. Most often doctors don't love data, but I was one of those people who loved data, who loved epidemiology, and that is what encouraged me to actually do my MD in public health. So he's moved from probably data to program. I've moved from program to data, and we worked closely together. So that is the connection we'll try to build through this chat. And Abhishek, let's just take our seats. Maybe it'll be easier for everyone. So it sounds great. Thank you, Suranjan. Oh, it's okay. Yeah. So when we are talking of maternal health, as an indicator, MMR is the one that we use often. And, we had our MDG targets, we have now our SDG targets. But what lies behind those numbers? We're just trying to unpack that. And I'm going to use your demographer lens, your statistics lens, and let's combine our sense of program and demography together, Abhishek, to unpack this. So let me just start by saying that very often I have heard people, say, okay, MMR, and then they go ahead and say maternal mortality rate. And then when we look at our SRS reports, there are kind of 3 indicators: maternal mortality ratio, maternal mortality rate, and a lifetime risk of death. Can you unpack these 3 for us, and what does it really mean? Because I mean,
I think I'm clear, but I'm not sure I'm clear.
No, thanks. I think that's a fantastic question. And at least I have also seen Anchita in my this last 2 decades of work, that many people get confused with the word MMR, whether it's a rate or it's a ratio. And there is a clear distinction between these two, the rates and ratios, right? I am assuming all of us know, but just to again clarify that rates, the very simple way, if we look at these rates and ratios, the rates are the numerator should be the subset or part of the denominator. That's the simple thing. While the ratio, it's a kind of division of two independent stuff. So, for example, sex ratio, it's male or females by males. While the death rate, it's kind of number of people dying divided by total population. So out of the population, people will die. So that's the kind of rate and ratio difference. And there are certain reasons why SRS provide these kind of 3 indicators of maternal mortality ratio, which is widely used, and then maternal mortality rate and the lifetime risk. So the maternal mortality ratio is kind of number of how many women are dying due to any pregnancy related or maternal causes as per the WHO definition during pregnancy or within 42 days of termination of pregnancy and all. So that's your numerator, and in the denominator you take the number of live births. So that's how it becomes a ratio. So it's in the denominator you have number of live births, and then you have number of maternal deaths or number of women dying due to maternal causes. And then you multiply by again 100,000. Again, sometimes people ask why 100,000? Why not unlike rates? It's per 100 because it's a rare event, very few. So it's easily interpretable if you multiply by a higher number. That's how 100,000 we multiply.
So we're basically trying to avoid a lot of decimals in it.
Decimals, exactly.
Okay.
While the rate, it's again how many women are there in the reproductive age span of say 15 to 49 years. Out of them, how many are dying due to again maternal causes? That's how it becomes rate, because the numerator is a subset of the denominator, which is the total number of women in that reproductive age cohort. And the third one is the lifetime risk. Although by name it may mean lifetime, throughout the lifetime, but again the chances of giving birth is typically 15 to 49 reproductive span. So it's kind of a relative thing again with respect to the fertility. So in a 15 to 49 years age span, what is the risk of death, which is your MMR, and then what is the number of children that, or the chances of pregnancy. So in a very simple word, lifetime risk can be interpreted as if a woman is of 15 to 49 years, what is the chance that she will die due to maternal causes?
So that's really interesting. So if I understood you correctly, and I'm just using a different analogy, let's say, there is always, when we are on the road, there is a risk for accident. So every time we are on the road, we run a certain risk for an accident, and let's assume that's standard for every time we are on the road. That's like, it could be a rate, but yeah, it's mostly something that akin to the ratio, that the MMR. So every time a woman is pregnant and gives birth, there is a certain risk that she runs for dying. But if you're on the road more frequently, you run that risk multiple times.
Absolutely.
Right?
Absolutely.
If you're getting pregnant more frequently, you run that risk multiple times.
Correct.
So from and I'm trying to link it back to the program. It's very interesting. When we are talking MMR, we generally talk of causes of mortality, and we are talking of prevention. Reducing MMR, we talk of managing complications. Somewhere in the big thing, we do talk of contraception and family planning, and in the picture that it does reduce. But actually, if we use the lifetime risk with reducing TFR and with less frequent births, we actually would reduce the lifetime risk. So I'm just thinking, while the global focus is on the MMR or the ratio, we should also start focusing on lifetime risk and tracking.
I couldn't agree more, because the main assumption in computation of the lifetime risk is the chances of dying during that 15 to 49 years is equal across the age groups,
Right.
which may not be, right?
So again, here it is, and again, using the road analogy, if I'm on an internal road, maybe I run a lesser risk, but if I'm on a highway, I might run a higher risk. So, the MMR assumes that with every pregnancy, irrespective of the factors associated with it, say whether it's the first or the second or the third, we run an equal risk. Whereas we know that with multigravida, the risk is higher, and we really don't compute it to the MMR like that. So, if we look at family planning, it kind of works in two ways. One, it reduces the total number of births. So the woman runs that risk less frequently in her lifetime, but also because subsequent pregnancies she may be at higher risk, so that risk also reduces, right?
Absolutely right. Yes.
And I'm just saying that while I work on maternal newborn health, I worked on family planning, but I feel this is an ignored area. And maybe, it's time, and I'm just throwing it out to the audience there, that when we are talking of MMR as an indicator, and when we're talking of maternal mortality, we should also talk of lifetime risk of death. And that should probably bring focus back, because there are other factors, the birth spacing, etc. We may have reduced TFR, but we know there are issues with family planning, which I'm not getting into.
And why we focus more on MMR and not the other two indicators? Again, because of the global comparisons, you don't have ready-made estimates or available for the lifetime risk or the maternal mortality rates. So, for India, that's why, we compute the MMR using the SRS data, but we also compute using, even MMIG methodology, EIG methodology, which again employs statistical methods of Bayesian analysis and all, for India to be comparable with other estimates, global estimates.
So you've just brought in a new term, MMIG. Is that some sort of a modeling technique?
Yes.
Okay. Okay. And that takes into account the number of births?
No.
It's like
again, it's similar to kind of MMR, but it's kind of more of a prospective modeling, Bayesian modeling.
So, because you talked of SRS, can you share, what is the methodology? Because we really rely on SRS, and we've recently had very interesting data. In fact, 2 or 3, what do you call them, reports or whatever, come out back, bulletins. Thank you. Bulletins come out back to back, and India seems to be doing pretty well on, and we do see some states performing much better. Something. I won't get into that right now. What is the methodology that SRS uses, and why do we rely on that? There are other sources.
Correct. Again, before I get into why we rely on SRS, I'll like to give an overview of what are the different data sources that are available for MMR estimates, right? Broadly, if we classify, I think there are, we can classify 4 types of data sources for MMR. One is this, civil registration and vital statistics, CRVS, or civil registration.
So birth and death registration, that
correct,
right? Yeah.
So that's number 1. Second is your sample registration system. The third is your the government program data, which is like HMIS and all. That's
and we also now have the MDSR portal,
right?
The maternal death registry or whatever. Yeah.
But again, I'll come to that. MDSR is not for MMR estimates.
Thank you.
Yes, it is not for MMR estimates. It's more for causes, why it's happening. I'll come to that. I'll come to that in a minute. So that's the third is the HMIS, and fourth is some special surveys, very state specific, or even you can think of the million death survey that happened, some time back. So some special surveys to estimate maternal mortality if something happens nationally or even subnationally, we can treat that as a fourth data source for MMR estimates. Among these 4, each has in its pros and cons. Starting with CRVS or CRS, it suffers extensively from the incompleteness.
Underreporting.
And I did make MPhil on that particular topic of enumeration.
We need to have a longer conversation after
that. And then comes the CRS. I'll come to that CRS. HMIS again, has its own limitation of non-availability of data periodically, not in the public domain all the time. Lots of issues, and special surveys again
studies has limitation of generalizability, again periodicity, everything. While in SRS, relatively the methodology is pretty robust. One, it's kind of it's representative. It's across the country. It has this, standard procedure of sampling, where it takes sample from rural, urban, rich, poor, everything, and almost equally. If I remember, about 8 out of 8,000 sample units, it has about 4,500 rural units and 44,000 urban units. So almost equal representation.
That's a huge.
And there the sampling methodology has the advantage that the units has almost equal certain chance of getting included, and it's a longitudinal. The sites are longitudinal.
So they are fixed sites. So they
Fixed
are
sites.
almost like in a kind of cohort kind of tracking. I mean, it's not the same cohort, but the sites are fixed.
Sites are fixed.
Great.
Yeah.
Okay.
So that's one address. Second, it's the dual record mechanism. What does this mean? The dual record mechanism. A local enumerator, he or she continuously enumerates the births and deaths happening in that particular community, in those select sites, 8,000, approx 8,000 sites that SRS has. And so he or she continuously does that, recording of births and deaths. And then every 6 months, a supervisor goes back and do independent survey of the households and try to collect the information around births and deaths. Then, those who are scrutinized as maternal deaths, all those deaths are kind of they go through this verbal autopsy method.
Oh,
yes.
okay.
And this, for that verbal autopsy, they again recruit medical professionals. They classify those causes of death as per the ICD-10. And then the beauty is these two lists by this local enumerator, and every 6 months this independent supervisor, they are matched, and any discrepancy again gets sorted. So it's a kind of, so that dual record mechanism helps in reducing, I'll not say nullifying, but reduce the error or non-reporting to a large extent. Yeah, so that's I think that.
Can I just ask? So, because these are fixed sites, does this also present a challenge? And I'm just saying that maybe I don't know how large that site is, but we also know, like in certain states, there are districts that are performing better in terms of services. So if that better district is somewhere captured, or a worse district is, one of those fixed sites, can it have like, an impact on the way we are measuring? Would it make sense to shift the sites, or because it's part of the methodology and the robustness, would it have additional challenges?
That's a good point, Anchita. And typically, these SRS sites get changed every 10 years, or why 10 years? After every census. So typically, that they take as the census frame as the for deciding the sites. Now, since we have not done the census, since 2011, so the same frame that was used, I think in 2014, the last sampling frame for SRS was in 2014. That's kind of still continuing. Yes, but that's a challenge. That's a possibility. I agree. I do agree with you, Anchita, on that. But while I'm also highlighting the strengths, it has also drawbacks. If you want me, I can just outline a couple of them.
Yes, please. Because, when we take SRS data at like face value. So I just want to, have a discussion on whether we should do that or whether we should be aware. And always, as data lovers, we should question data, not, so just please tell us the drawbacks so that we can keep it in mind.
To me, the major drawback or limitation, I'll not say drawback, the limitation is it's not available beyond state level estimates. And that, therefore, what you said, if a district is performing better, or if a particular block is performing better, we will not be able to kind of get that reflected in SRS estimates, because SRS unfortunately do not provide any estimate for MMR below district level, below state level. And even for smaller states, they combine it together.
Yeah.
So because again it's all because it's a rare event for, and that is why even if you look at the SRS bulletin for neonatal mortality, infant mortality, and crude death rate, crude birth rate, you will find it for every year. It's a point estimate, while for for MMR it's a period estimate. By that I mean it's a for 3-year period. It takes 3 years and gives a rolling estimate for 3 years. Why? Just to smoothen that infrequency, and also pool the number of days over a period of 3 years, and then divide by the total number of births. So that's why you'll not get MMR every year, and and also the below state level. I think these are the two main drawbacks, limitations rather.
Interesting. And one question that again I have to this, when we're reading reports, there is a confidence interval to that. And often we are, taking the point estimate saying, oh, isme to 1 point बढ़ गया, इसमें 2 point बढ़ गया, 4 point घट गया. Whereas if one looks at the CI, the confidence intervals, the estimates are within the same range. How do we interpret this? And should we take it up with the
I love this question. I oftentimes people ask me to interpret confidence interval and power, statistical power, and this and that. But it's so relevant and so important that when we interpret maternal and mortality ratio, we interpret it with some level of understanding about the confidence interval. If we don't do that, we often end up in misinterpretation, or wrong interpretation. As you very rightly said, and I really congratulate you, Anchita, for this one, that please don't treat MMR as a point estimate. It is heavily linked with the precision, and that precision is what the confidence interval tells. So if currently India's MMR is say 88, with a confidence interval of 79 lower bound and 96 is the upper bound. What does it mean? It means that I have I have fair confidence, or I'm certainly confident that my estimate will lie somewhere between 79 and 96. But it's not guaranteeing me that it is exactly 88.
Right.
In other words, the precision is better if you have a smaller interval, smaller confidence interval.
Got it. Yeah.
And if your confidence interval is wider, that means you are not too sure whether your estimate that you got is precise or not. That is why what you said, I'll just come to that point. If state A is having a MMR of 90 and state B is having a MMR of 95, it might happen that state B is performing better than state A. It's not because in state B MMR is 95, but if it is a very small confidence interval, and over time it maintained that lower confidence interval, we should look into. So what we should look keeping this confidence interval in mind, just look at the trend, not just one data point of say last 2021, 2023, what MMR report is, but now look at the trend, look at the confidence interval. If there is overlap, just look at that, and then compute whether, then come to some conclusion whether it's below average, below the national level, above the average level, that kind of a computation, rather than just 90 versus. Let's not focus on that.
I think that's a very important point. So how to interpret that, and time trend analysis is temporal analysis is super important when we are trying to interpret where we are headed. So if you're headed in the right direction, at least, I think we can be pretty sure. But states should be careful while rejoicing or being in despair.
Absolutely.
What is happening.
Yes.
I was just going back to a certain point that you said on SRS, that you use verbal autopsy. And, it takes me back to, I think in 2000, sometime before 2010, WHO had released a report called Beyond the Numbers. Basically, the focus was that while we are looking at MMR, etc., all these numbers, there is a life behind every death. So we need to take care of that. And its numbers tell a story, but there are different stories behind that. one of the way, so it's important when we are looking at that life that we look at pathways to improve our care and how to reduce those, not just those numbers, but save each and every life that is possible. But to be able to do that, we need to understand what was the cause of mortality. And we need to understand it both from the medical lens and from a program lens. So while, there are different ways, and I'm not getting into that because I just wanted to talk about measurement of, understanding it from the program lens, but just from a medical cause of mortality. How does SRS, does SRS actually give us the cause of mortality? To be very honest, I mean, the last official chart that I remember seeing is way back in 2003 or 2, I forget the number, the pie chart on the causes of mortality. I haven't seen an official chart after that, but if SRS does a cause of mortality or a verbal autopsy, how does it do it, how reliable it is, and how can we get hold of that data?
Fantastic. Yeah, we should not get carried by the numbers. We should definitely look at the storage, and here again I'll bring the point that you raised about this MDS, maternal death surveillance, and reporting. So there, I think the MDSR is one of the good initiatives where we are not looking at the purely the numbers or celebrating or th- something for just looking at the SRS number, but more of the. So what MDSR again gives us the flexibility of looking at those storage, why deaths are happening, and what can be done to fix those deaths. It underpins the system bottlenecks where intervention is needed, be it clinical, be it infrastructure related, be it behavioral, whatever. So as I said, MDSR, even if it's not it's not meant for providing MMR estimates. Rather, it's more for unpacking the storage and doing some forward-looking action. Again, I'll take your analogy of this road. If you are driving a car, you can think of SRS. It's a rear view mirror. You can look back what's happened in the past in terms of the numbers data, while this MDSR is kind of your headlights, where you can look at the road ahead and you can decide what action to be taken. So I'll put this this SRS estimates versus MDSR that way. That's the distinction. But the good part, as I was coming to this cause of death, yes, it SRS collects cause of death because they classify as per the ICD-10 categorization. But I agree, in the last few years we do not have that, and we should look at these causes of death more than ever because of the changing lifestyle, the increase in the non-communicable diseases, and many more risks
There
that
is an
women are.
obstetric transition, as we call it. So as the program starts dealing with the direct obstetric causes, so like we have, I think, made significant dent in postpartum hemorrhage mortality. So whatever, I have seen some graphs by researchers which would probably use the SRS cause of mortality data, where they're showing this transition. So as you rightly said, we are seeing more of, say, cardiac issues or things like that's coming up. But as we tackle PPH, even within the direct causes, the eclampsia, etc., is rising. So it's just a proportion. I'm just talking of the pie chart. Overall, it's reducing, but the pie chart seems to be changing, and we need to keep that in mind.
Yes, I think that's and I think for the program people, program implementers, that's more important than just the numbers of MMR.
I completely agree with you, Abhishek, and that's something, as a program supporter, I struggle with not having that data. So if there are researchers in the audience, I would suggest, if you have access to or can get access to the cause of mortality data from SRS, please publish papers on that, whether at the national level, just try and do some analysis, because that's because one of the things that I've seen in MDSR, and this is my, way back, I did some assessment just actually talk in 5 states about the process itself. And I realized that the cause of mortality, it does not follow the verbal autopsy standards. So, for example, if there is any report that says that the woman was anemic, even if she was at 9 gram%, the death was because of anemia. Whereas we know that anemia as a direct cause of death is highly unlikely, unless she's at 3-4 gram% and may go into cardiac failure. Anemia is an underlying cause.
Yes.
So we cannot really say that it's a direct cause. In fact, one of the thoughts that I was having, and I've been discussing with people, when we talked of child mortality, so UNICEF had this chart of, the pie chart of causes of child mortality, and they put undernutrition in the center because it was a contributing cause to a lot of other causes. So undernutrition per se causing death, it basically means bhuk se mar gaya koi, unfortunately. That's like unusual, I would say. So same thing with anemia. Anemia is an underlying cause, and I'm just wondering if with all the teams here who are like either into research or looking at this, we kind of pitch for a different representation of cause of maternal mortality with things like undernutrition and anemia in the center. So just as an idea, I'm just wanted to throw
That's
it out
very
there.
true, and there also I think SRS also suffers from that misclassification, the chances of misclassification, because you are doing the verbal autopsy with families or the people who are able to provide reliable information, but you don't know how reliable is that, and also the same problem of misclassification of early pregnancy or not directly related to the pregnancy related cause, or not 42 days, it's 50 days. So lots of misclassification related issues may arise there, but I can't agree more with you that the importance on looking at these causes of death more actively for the programmatic actions.
So let me just, we're kind of running out of time, and this is a very interesting conversation, Abhishek, because he and I work together closely. I intend to have this conversation, take it forward with him. But just, with your headlight analogy, just looking forward, one of the big headlights in the arena is artificial intelligence, AI. I'm just wondering, how do we use it for some of our work here and the questions that we seem to have?
I personally feel AI can't do miracle, but certainly it can help to a great extent. I'll give a couple of examples. So, for example, we are doing this. We are talking about this misclassification. The physician doing manual coding or classifying a particular cause to the ICD-10, right? So, and now we have enormous data of the previous so many years of SRS data. If we use this machine learning, large language modeling, and all these things, I think we'll have very rich data for the machine to be trained, and then AI, the machine learning can certainly classify or at least check whether those classification which happened is correct or not. So for this algorithms, for a better algorithms, I think AI can be certainly leveraged and utilized more effectively. Second is kind of as we see, we have say different data sources from on MMR from SRS, from CRS, even if incomplete, whatever we have from HMIS. We can again use AI for triangulation of information from various data sources and to kind of check the inconsistency, the reliability, and all those things. That will help in some level of validation. The third thing where again AI can be helpful is perhaps some below state level estimation, the small area estimation.
Right.
So with this again, the huge data pool of so many years versus so many states. And anyway, our GI has the raw data. So we can certainly use those data to kind of train again the AI, use AI for this small area estimation to get some below state level, like be district level or block level estimate, so that those are more important and useful for the program planners, program implementers, not the state level. It masks the inter-district or inter-block variation. So, yeah.
Thank you so much, Abhishek. And I mean, he's available and I'm throwing it out. So if anybody wants to have more conversations with him, I have the luxury of having that conversation kind of anytime I want. But he's available. So if anybody wants to have any conversations, please, you're most welcome. But thank you so much, Abhishek. And let's shake hands to partnership between demography, statistics, and programs. And
Thank you so much, Anchita. Okay.
So we wanted to start with the panel, and I'm still wondering if my panelist is here. Dr. Ashok, are you here? Oh, lovely. Thank you. Thank you. So we can start with panel 1. I would like to call upon stage my 3 panelists, Dr. Ashok, Dr. Aparna Hegre, and Dr. Deepa Prasad. Can you please join me on stage, please? Thank you. I hope it's okay with you if you don't have the table in front. So I think it's just a more pleasant environment when you're talking to people directly. So while Dr. Amit said we will be talking about 3 causes of mortality, given the paucity of time, I'm trying to restrict myself to just 2, and that is postpartum hemorrhage and obstructed/prolonged labor. And I am actually going to try and unpack what it means to move from evidence to policy to practice. So in 2018, WHO had a new guidance on quality intrapartum care and how to make it a good experience for women. And then very recently, and as recent as last month, WHO also released, in collaboration with FIGO and ICM, that's the International Confederation of Midwives and the Federation of International OBG Associations, a new guidance on postpartum hemorrhage. And it sees some changes in the way we are talking about or managing, identifying postpartum hemorrhage. So I'll start with PPH because despite its reduction, it still remains a main cause of maternal mortality. And we probably need to do more. There are areas, of course, that are doing better. There are states, even in India, that are not doing so well. So let's try and unpack this. Just to say that the way WHO has worded its recommendations, it's looking at interventions in the antenatal period to prevent postpartum hemorrhage. Then there are preventive interventions in the intrapartum period or while the woman is in labor. Should the woman have postpartum hemorrhage, is talking about diagnosis and then the management bit of it, and then there's a follow-on in the postpartum period. Out of these 4, I'm going to focus on 2 of these elements, or rather 3, I would say. So I'm restricting myself to the intrapartum period. What do we do to prevent postpartum hemorrhage? How do we diagnose postpartum hemorrhage, and what are we doing to manage postpartum hemorrhage? But before I do that, can I request the panelists to self-introduce themselves in 1 or 2 lines and just to give your background in short and your current affiliations, please. Do you have mics there? Oh, it's one. Ek aur de dijiye, please. Thank you.
I'm Ashok Kumar. I'm Director Professor at Department of OBGY at Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital. At the present, I'm holding the post of director also at the institute. I have basically interest in maternal health, and my interest area is for looking for high-risk factors in obstetrics.
Thank you, Dr. Ashok.
Morning, everyone. My name is Dr. Deepa Prasad. I've been in the public health field for about 25 years. I'm a trained obstetrician, but I had no choice. I had to do my master's in public health given the work that I've been doing. So I'm currently with UNFPA as the Chief of Programs. UNFPA is an organization within the UN which leads the sexual reproductive health. Before that, I worked with WHO and with UNDP. Happy to be here.
Hello, everyone. I am Dr. Aparna Hegde. I have two lives. I am a practicing urogynecologist. I'm a professor of urogynecology at Kama Hospital in Mumbai, where we built the Department of Urogynecology, first one in the country, actually. And I'm also the founder of an NGO called Arman that works in the space of maternal child health in 28 states of India. And my link to maternal health and high-risk pregnancies comes from the fact that Arman works extensively in the space.
Thank you, everyone. So let me start by, talking about the preventive aspects in intrapartum, the period, how to prevent postpartum hemorrhage. And for that, we have this whole practice of active management of third stage of labor. So after the baby is born and before the placenta is out, what are we supposed to do? Dr. Ashok, what are the kinds? So let me just begin by saying that the guidelines talk about giving a uterotonic or a drug that contracts the uterus. And I'm making it simple. I know everybody's a doctor here, but there may be demographers who may not understand these terms. So I'm just taking that liberty. So to keep the uterus contracted, that's the idea of giving a uterotonic. We had earlier the recommendations of, 3 parts to Amstel, as we call it, active management, which was the uterotonic, the control contraction to remove the placenta, as well as uterine massage. WHO now focuses only on the uterotonic and says CCT or control contraction only if a skilled birth attendance is available, and it does not recommend sustained uterine massage as for prevention of postpartum hemorrhage. So just wanted to put that out there as the latest evidence. Dr. Ashok, in your practice, what are the kinds of drugs that people are using in your practice, or, because obviously you have your fraternity and you would know, for prevention of postpartum hemorrhage as part of Amstel or active management of third stage of labor?
See, commonest is oxytocin, which is a very old drug and commonly used at most of the center, easily available, very cheap. So traditionally, you can say it is being used as a routine when we are doing active management of third stage of labor. We have other drugs also which can be used, but other uterotonics in terms of ergometrin, we have then symptometrin. Earlier we used to have combination of these, and misoprostol nowadays. There's so many drugs which are available with the name of uterotonics, but commonly for a long time oxytocin is the drug. Recently, then carbetocin has come into the picture. Only there are many studies which has come up about its efficacy, and it has been seen that it is more effective or efficacious as compared to oxytocin, with many advantages over oxytocin. But the disadvantage only is that the cost factor. But there are some processes where in the government setup, they are matching with the price also. So it depends on the availability now, whether heat stable carbetocin is available in that particular center or not. So otherwise, in the recommendations also, and being a traditional practice, most of the guidelines also say that we should stick with the oxytocin, and if that is not available, then carbetocin can be used. Other drugs, other uterotonics usually are used after oxytocin. Usually, we use oxytocin first, and if we feel that there is PPH, then we try to add on other uterotonics like methyl ergometrin. So this is the practice nowadays for oxytocin or uterotonics, which is given as 10 international units, or 5 to 10.
Ashok, if I could just add to that, the current WHO guidance talks of giving a single uterotonic for prevention, and I'm specifically restricting myself to prevention. We have some, from the foundation, some work we've done with the private sector, and we've not looked at it in the public sector, to be very honest, what are the kinds of practices. But what we realize is that, given the fear of postpartum hemorrhage, because it is a really, it can lead to death in like hours. So we have seen practitioners giving multiple uterotonics even for prevention. But WHO guidance says specifically only one for prevention. What do you think are the disadvantages if we give multiple drugs? From a scientific lens, what would happen?
See, as I told you earlier, that for prevention in active management of third stage of labor, we give oxytocin first. Then the different steps comes in that if your bleeding is not controlled with that, that means PPH is setting in or has set in, then you try to add on other drugs. Otherwise, as per the hospital policy, either they can use as a first line oxytocin, but as I told you, mainly oxytocin is used, but the other centers, some centers, they are using other drugs as a first line also. So that is a different story. But if there is a apprehension about PPH, then other uterotonics are added in that. But that is for the treatment, that once you have taken the response of one drug like oxytocin, then you see that bleeding is setting in or it is not controlled, then you try to add on ergometrin, then you try to add on misoprostol or something like that. So that is sequential steps of adding. But in some places also, some centers, they are using simultaneously 2 or 3 uterotonics. That should not be done, number one. That is not a healthy practice. But there are problems also. Number one, side effects will be more. Because each drug will have side effects, and mainly these drugs have side effects in terms of GI symptoms, nausea, vomiting, diarrhea. Those are commonest ones. And otherwise, they can have fever, shivering, like with misoprostol and all those things. One more important thing is that I think evidences are not there to say that if you add on the drugs, the efficacy will improve. So that is a question mark there, whether it is really increasing or improving the efficacy or improve or helping the patient or not. So there are issues with this type of practices. But I feel that when we are talking of prophylaxis, then only one drug should be used as a policy of that center. If that fails, that means PPH has set in. Then your medical management in different steps has to be initiated.
Thank you. So, Dr. Deepa, Dr. Ashok mentioned one very interesting point, and he mentioned the term heat-stable carbetocin. So the problem with oxytocin, while it's the drug of choice, is that it needs a cold chain, right? And that is why there was research done on what happens, and then we had this drug carbetocin, and then it was a heat-stable product which stays at room temperature, etc. Given there may be places, so we know that right now in our public sector system, at least we have refrigerators. We have no idea about what happens in the manufacturing space or while it's being transported, how good the cold chain is. But let us assume if we want to bring this new paradigm of Amstel into the system. Right now, all our trainings are SBA guidelines, etc., all talk of the 3 elements that I mentioned earlier. But if we have to change this and link ourselves to evidence, so, oxytocin, maybe carbetocin in certain areas, control contraction only with SBAs, and, what happens, and is it really helpful, and no sustained uterine massage. So that's like, that hit me when I read about it. What do you think it would take for the public sector system to do all this?
Thank you, Anchita. I'm really enjoying the session here, and also want to congratulate everyone who is in the maternal health space. We are all set to be achieving the SDG 3.1.
Congratulations.
So
Yes,
that's the exciting part. So now we have a huge challenge. Initially when the maternal mortality is very high, the reduction is also quite fast. But then we are at a juncture where we really need to strike hard to make sure the last mile at the last level of where the women are dying are affected. Now, coming to your question, when I got these questions, it made me go back and look at the Government of India's guidelines. So the last guidelines that we had was in 2015. And when I read it, I felt that it's not going to be a big issue, at least 3 of the 2 interventions that you spoke about. So the 3 were, bringing in carbetocin in addition to oxytocin. The other 2 are controlled contraction and uterine massage. So the Government of India clearly, the guidelines clearly says only an SBA trained person can do a controlled contraction. That's already there.
And over the last 25 years or 20 years since the National Health Mission, we have trained innumerable SBAs. So there won't be any facility where somebody hasn't been trained on skilled birth attendants. It's a different matter on how good they are with their skills. And given that India currently has about 85 or 89% institutional deliveries, that's something which we need not be bothered about. Now, coming to the second easy part is the uterine massage. On that, the challenge is how do we change behaviors? And the first one is bringing in heat stable carbetocin. So when in any public health system or in any large programs, if some new guidelines have to be introduced, there are a few criteria which are set. First and foremost is, are there global guidance and global evidences? Of course, it's very well established in this case. Second is the cost benefit analysis, or how the public health budget is going to be impacted. And again, on that, especially with carbetocin, where one of the issues or concerns raised was the cost. There have been studies across both in India and elsewhere, which has actually assessed what would be the impact on the budgets or on the finances. So one study says that, in India, I think this was a study conducted in India, which clearly brought out that over a period of 5 years, if heat stable carbetocin is brought in, it can actually save funds. About 84 crores was the estimate. And the reason was the incidence of severe PPH reduces if carbetocin is used compared to oxytocin or misoprostol. These are the two drugs which are there as part of the guidelines. And also there is a decrease in the number of deaths, not significant, but there is a slight decrease compared to the other two. And also, when we look at introduction, we can go in a phased manner. So in India, we are seeing climatic changes and extreme heat events. So if we could look at mapping out which are the districts which have high intensity of heat or extreme weather events, and then bring it there, and then slowly phase it out. So it's going to be a stepwise approach. It needs strong advocacy with the government, maybe trying out pilots. Pilots have been done, a lot have been done. But then we need to actually also look at how do we bring it into the system, not a blanket approach. The cost would be humongous. But if we can do a mapping where it is going to be really effective, where disasters are common, extreme heat events are there, and we are not very sure of the cold chain, and if we can bring it out, then I'm sure that we can bring this new package into the public health system.
Very interesting points. So do a cost benefit analysis, maybe pilot it and look at areas that may benefit from this. So I think maybe once I'm hoping the policy for India also changes, our guidelines also change with the newer evidence. Interestingly, Dr. Pavan, who couldn't be here, but he was there at FIGO, so he was part of, the dissemination. So maybe between, the partners, etc., that's something we need to push for. Thank you. So one of the things, again, now I'm moving from prevention to actual diagnosis, and I just wanted to ask my colleague, Suranjan, how are we doing on time? Okay, so probably I might have to skip the labor monitoring piece. Because I don't want to cut short the other panel. So I'm just going to, talk about the actual diagnosis of PPH. And the guidelines clearly say that we need to have an objective measure of blood loss. So Dr. Ashok, in your practice, how do you really measure blood loss, and how do you estimate whether it is PPH or not? The older guidelines, I know talked of pad soaked and all that, but what is really happening in practice? I wanted to understand that.
See, over the years, we have also evolved and graduated. But still, most of the places, it is the visual subjective assessment of the blood loss by seeing whatever is draining out from the vagina and what is there on the clothes, etc. So that is a subjective method, but slowly, new methods have come in, and now they are calibrated. And the other one is where you use or weigh your linen or pads, everything before patient is there on the delivery table, and then after that. So that is another method which some people are doing, but that is not a very practical and feasible method.
I agree. Yeah.
Then now calibrated drapes have come where everything is being collected. But I personally feel that there is some issue in that because you are not separating the amniotic fluid from that whatever is coming in the drapes. So that also may not be accurate, but yes, still it gives some information that how much is the blood loss, provided there is no spillage outside that drape over the floor or anywhere else. So that precaution has to take. Then beside these, now we are adding to the clinical symptoms also and signs.
Right.
So that indirect methods are also helping, whether there is a tachycardia or hypotension or something like that. Another method of laboratory use is there, but I feel that change in hemoglobin or hematocrit, but it gives, you have to do it over a period of time.
Yeah.
Maybe 6 hours or 12 hours. So it will not be instantly. The results are available. So, and interpretation cannot be done. But clinical features and clinical, obviously, when we as a clinician seeing the patient, clinical acumen comes into picture also.
Yeah.
So whether patient is deteriorating, pallor is increasing or not. So so there are many things by which now we are doing. And usually it is not one method, multiple methods or techniques are
Right.
used to assess the blood loss.
Thank you. So as Dr. Ashok mentioned, with clinical, just wanted to share that the latest guidelines, I mean, the definition of PPH was and kind of still remains 500 milliliters of blood loss after a normal vaginal delivery. The latest guidelines talk of another cutoff of 300 mils of blood loss, 300 milliliters of blood loss, if it is accompanied with signs of impending shock, changes or hemodynamic instability. That's not something we've ever really focused on. So that's a change. The second thing, you mentioned a very important point on the challenge with calibrated drapes. And we, at the foundation, we actually understood these challenges. And what we've done is design some specifications and some models of calibrated drapes where we have, so basically it is placed under the, woman while she's giving birth, and then it has a funnel to collect the blood loss. What Dr. Ashok rightly pointed out, if it collects amniotic fluid and it has markings in it because it's calibrated, so it gets all mixed up. So we tried to solve for that issue. One is you place the drape after the birth of the baby. That's uncomfortable for the woman and the provider. So what we've tried to do is create some sort of a seal with the funnel. So once the baby is out, that's when you open the funnel and collect. So by the time, the amniotic fluid, etc. comes out, we're not measuring that. But the baby is out, and when the bleeding happens, that's when you open the funnel. Plus, we have created some channels pathways so that there is no backflow of blood. And, some of the designs also have belts, etc., that you can tie to the woman so that even if she moves a bit, the drape continues to remain in place. Foxy actually has written down some specifications for these, and we hope to publish these shortly. And at many upcoming conferences for any obstetricians here, some of these drapes will be kind of available for display. We have tried and tested it with some OBGs, but it's waited to be seen. But coming to you, Dr. Aparna, and you also have a research background. So given these drapes are new, and this is one measurement of objective measurement of blood loss. And we really don't know, as Dr. Ashok was saying, there are apprehensions, there are challenges. If we want to bring it into the system, what kind of operational or implementation research do we need to do? And what are the questions we should ask to bring the drapes into the system and maybe, allow for more experimentation or improvement with the drapes?
Yeah, absolutely. It's a very important and valid question. So maybe we may not go into very detailed clinical efficacy studies as of now, except for the new modifications, right? Those need to be compared with the ones that have been approved by WHO, etc. I mean, all the, but when you look at it from the public sector perspective, you're going to look at it from, the point of feasibility at implementation level at scale. Yeah, at scale. Is it acceptable to the, providers? And also, how do you train for scale, right? I mean, at scale. And lastly, it's about system readiness to accept the drapes. So, you look at from the perspective of feasibility and usability, you would look at, is it practical to incorporate in the workflow of the, labor room? Because you've talked about modifications, but how easy is it to implement those modifications in a labor room when you have many practitioners? Secondly, it's very important to understand how consistently do the providers use it correctly, given those modifications that you're, asking for. Then also reliability, inter-observer reliability and inter-user reliability is very, very important. And again, accuracy studies may be needed to be done locally because it's been validated maybe internationally, but locally also you would need that, right? Those studies will need to get done, especially for the modifications. Then it is the provider attitudes, right? Because when you get in anything new, and I've worked in very busy, I've been an OBGYN before I became a urogynecologist. And I must say that in extremely busy labor rooms, it's very difficult to introduce new, you're so used to your, traditional methods, you may go for training programs, but come back and do the same. So it's very important to understand provider attitudes, and also, patient perceptions, of what has been done to them. And is it really leading to change that you want? Right. So is it what is the impact on it? Right. So using those drapes, are you able to really pick up PPH earlier and intervene earlier is something that you need to also study in busy labor rooms in India. Last point I want to make is, at scale, when you're, you need to actually look at the cost effectiveness of the entire process. You don't need, you need to look at supply chain, issues, right? And so these questions really come into play when you look at rural India. Right. Lastly, is the system ready to be trained at that level? Because you really need to have a mammoth training program at scale, right? And how do you do that, right? So all of these need to be studied using, operations research. So you might not do very large scale efficacy studies, but smaller, step wedge RCTs, etc. You might want to do studies. You might want to do to look at process outcomes.
Right.
Yeah, that is what I would think. And maybe in the emphasis in the private sector would be on the same issues, but more at the individual level, right? Quality assurance, patient experiences, and the impact on the outcomes.
Yeah, I think the difference also in the public is that maybe it's handled more by nursing staff, whereas in the private sector it is the provider, the OBG himself or herself.
Very important point.
So again, in the interest of time, I'm going to cut short some questions, but this operations research is a very interesting point, and I have my colleague Vidyut somewhere in the, hi Vidyut, maybe we should try and explore some of this in the state of UP and see if you want to introduce the drapes, what would it take? So a discussion for another day. So just now coming to the management of PPH, there was this huge trial that was published. It was called the Emotive Trial, which talks about a bundled approach for PPH management. Dr. Deepa, can you tell me how this bundled approach differs from what we have been doing erstwhile? And if we were to bring it into the system, again, what challenges would it take? And I'm just, because you and I have been discussing the emotive bundle.
Yeah, thanks, Anshita, for this question. So in terms of what does this emotive bundle entail, I think we need to enlighten the audience because I don't think many of them are sure about it.
Yes, please.
So emotive is an acronym. E stands for estimation of blood loss. So all what we spoke about, having drapes and estimating the blood loss, that's the first point. The others are MOTIV. E stands for M is for uterine massage. So they're saying, as per the new guidelines, no routine uterine massage during the third stage of labor, but if PPH is imminent or setting in, then uterine massage. O stands for oxytocin, and T stands for tranexamic acid, and IV either crystalloids plus IV saline.
Yeah.
And escalation. So that's the acronym it stands for. So in terms of if we have to introduce emotive in a country like India, we talked about implementation research, whether it's feasible in our setting, do we do more, pilots before we scale it up? UNFPA has also been discussing with some of the state governments. And interestingly, we found that there is a lot of interest and openness, especially in states where the maternal mortality is high. And in 2 states where we did a study on what are the causes of maternal mortality and what are the causal pathways, Madhya Pradesh and Rajasthan. And in these 2 states, again, PPH stands out as one of the most important obstetric causes for maternal deaths.
So if we have to introduce this, so what is the difference? First, let's understand what's the difference. So in the earlier your management of PPH, as Dr. Ashok was explaining, we follow a step-by-step approach. We try one utrotonic. If it's not working, then we bring in the other, and then it's a step-by-step approach. Whereas in emotive, it's a bundled approach. We kind of bring in all these components at the same time so that we are preventing that the blood loss doesn't become more severe. So that's the basic change. So it's a team approach. So you need to have a trained team to actually implement emotive in a facility. And one of the key components is the drapes. And we all discussed about the challenges with drapes. And interestingly, in our Government of India's 2015 guidelines, they're talking about having some standardized ways of measuring blood loss. Even drapes is mentioned there, which was like, very interesting and very encouraging. And I think when we're going by visual estimation, underestimation is as high as 33 to 50%. So definitely we need to have that. So we need to bring in that. And I'm really happy to know that you're looking at what could be the specifications are designed to avoid misinterpretation. So that's something which we really need to work together as partners with the government to see when we bring in something to India, it is truly effective. So, in terms of introduction, if we need to first introduce it in India on a large scale within the government system, we definitely need to work with the ministry to see that it's part of their guidelines. We might be successful in doing pilots in one state, working with them, maybe even scaling up there. But ultimately, if we want to scale it up for the entire country, we have to work with the ministry. But the positive part of it is like the ministry is also open. They want to see how the states are taking it up and if it's successful, and within a state, if it can be scaled up. And the funds may be available because if you look at the annual budgets or the project implementation plans of the states, they have flexibility of procurement of devices for the labor rooms. And some states are already looking at, can we bring it up? Can we put it in the next year's budget? So it's there. The other part, and what Aparna also mentioned, is how do we train the team? That's a big challenge. So we might be successful in a few districts, few facilities, but one thing for us to remember is it's a team approach. So we need to train the entire labor room team to implement interventions such as emotive. And we also need to bring in job aids protocols. If you walk into any labor room, we have so many protocols displayed. I think it's time that we go back and see how, wherever we are as partners working, conduct a real review, what is required, and if there is openness to bring in new interventions, and if Government of India is bringing out these guidelines, help them change these job aids and protocols that are displayed. And one training wouldn't suffice. That we've seen with SBA, EMOC, and several other trainings. So how do we build in a system where we are able to really build capacities and also bring about the change in how clients or pregnant women are approached? And I see that that's going to be a big challenge in medical college hospitals. For them to get into adapting to new evidences takes a longer time than in the peripheral institutions. So, we've been doing CMEs, continuing medical education, inviting faculty from medical college hospitals. And we see that's the challenge. They're still talking about what's in the textbook and not what the Government of India guidelines is. So one area for us to work is to work with the teaching facilities, high load caseload institutions, maybe try out as pilots, work with the state governments, and again, document our experiences. We may call it an implementation research or implementation process documentation, but we need to bring in evidences from India and then take it to other states maybe, and then to the national level, so that we are able to bring in interventions such as emotive, which can actually save more lives.
Yeah, thank you. Thank you. In the interest of time, I will end it here. I had very interesting questions. And I'm sorry, I know you read about a lot of stuff, but just to say that it's very, very important we keep ourselves abreast with the newer evidence. And because this is also a teaching place and the premier institute in the country, maybe this is the place where we bring the latest evidence in place. And as Deepa said, medical colleges are the right place. And we hope that there are other opportunities to share the latest evidence and to disseminate them. Thank you very much.
When you talked of bundle approach, when you talk of all these things, it is important that our young residents, because they're posted to various departments, it's not only Obs-Gynae will remain in Obs-Gynae, so it is important to send it over there.
Yes, ma'am. Thank you. Thank you so much.
Can I
Thank you,
add-
Dr.
can I
Sunita.
add one?
Yes, Dr.
See, it is easier said than done because of the wide variation in geography of our country. See, whatever we do at our center, but if patient comes late, if patient has problem, there is a delay in transportation or reaching the center, everything fails.
Absolutely.
So somehow we were discussing with Dr. Pawan also, and he also is of opinion that we should have some strategies to reach to the patient in these areas, rather than we expect that our centers are good enough and everyone should come to our center.
Completely agree. So one is we cannot have everyone there. Referral mechanisms are important, but that is why the primary treatment bundle at lower levels where births are happening is super important. And, referral facilities like yours do receive refractory cases, and we didn't discuss that, but that's a discussion for another day. Thank you so much. Dr. Suranjan, can I have you take over the next session? Dr. Sunita, are you moderating? Sorry. Yes, please. Sorry, I got that wrong. Thank you.
Sir.
यहाँ पे करेंगे ना presentation.
एक मिनट.
ये डॉक्टर विद्युत का होगा फिर वो लगा रहे हैं वो लगा।
इनको पहले ही पता है।
So good afternoon, everyone waiting for lunch, but let me assure you, I will not take too long, and hold you for lunch. So, and I would like that you all also going to talk. First of all, who am I? Sunita Singhal, and currently I'm working for JPIGO as a clinical country lead for clinical trainings and services for over 3 years. लेकिन उससे पहले, I love to put it, I worked all my life for over 20 years in the hospital, across your hospital. So this place is very dear and familiar to me. तो हम आमने सामने ही थे. So that's about me. Now, I will just continue with what Anchita had, done beautifully in the earlier 2 sessions. And I would love to repeat a couple of points that I really enjoyed listening to the session. And I'm sure you all must have done the same thing. So she explored some of the most promising innovations in maternal health. Lovely to hear about the PPH. These go a long way in reducing the maternal mortality. And because as science meets system readiness, it is really important that how we translate this into the field right at the last mile for the people to use. The other thing was about measurement. Without measurement, without knowing what is the impact of what we are doing, nothing can move forward. So as they say, that data gives you a direction, but let me tell you, it's the action which delivers the impact. Now, having said that, let me move forward a little bit. Again, I will have to go back and touch some data. The evidence you all may know has shown the maternal mortality trends coming down from, it was somewhere around more than 500 in 1990, and now it is 88. So I will just stay put stop there with this data. I will specifically look at why are we looking at this data, because behind these numbers lies the biggest challenge in maternal health, and that is the burden of high risk pregnancy. In the next few minutes that we will have, the expert panel here who will talk about how do we address this challenge, what this data tells us, how are we going to use it, take it to the facilities. So I would like to call upon the three panelists over this dais, please. I welcome Dr. Vidyut Sarkar from UP, and I will request Dr. Aparna Hegde to oblige us and be here again, a part of this panel. I also request Anunya Jain, who is also from Jaigo, to come here on the dais. So we have a fourth panelist, Dr. Radha. She was unable to join from Delhi from this dais, but she will join online. So these are my panelists, and while I will keep my talk very, very small. I will directly go to the basics, questions about high-risk pregnancy, how we are handling, and the panelists will share their experiences. And with that, I will request them to, give a couple of words about the place that they work currently, and maybe in a sentence or two, they go back to, their past, this thing. So coming back to how are we handling the high-risk pregnancy, the burden, we all know the burden. The high-risk pregnancies are supposed to be, at least every alternate patient has some high-risk factor, and some of them up to 16% may even have multiple high risks. Okay, so we have this list of high-risk pregnancies, which has been expanded from 10 to 25 currently by the government of India, and there are programs like PMSMA, that is Pradhan Mantri Yojana, and then we also have this EPMSMA, which means you have to track. Once you've identified, you've labeled, you are high risk, what do you do with her? Right? Is that labeling enough? No, it is not. So what is the problem with that? The problem is that this burden of high-risk pregnancies has multiple variations. When I say variations, what I mean to say is that there is a geographic variation. States like Sikkim and Orissa have lower high-risk pregnancy rate, but other than that, some of the states have a very high rate, like about 65%, as it is said. The burden, these are primarily the northeastern states, Meghalaya and Manipur, with a very high risk. Now, this variation is not just geographic, it is also socio-cultural, educational, etc., that we keep talking about. Now, with this burden and this variation in burden, how do we proceed further? So, what do we do? The high-risk pregnancies give you a signal only. That is, if you miss that signal, you've missed the opportunity of, saving that life. Why? Because it has been seen that the maternal mortalities, almost 70 to 75% women who die, 20 to 30% out of those are from this high-risk pregnancy cohort. So how do we reach them? What do we do? So I think it is time that we discuss what steps the government has taken. The government has made a lot of protocols. So, but we know protocols are only maps. It is the journey which is made by the people. So for the first, I'm sorry. Yes. So to talk about the first this thing, that once a high-risk pregnancy is labeled, she is referred, somehow overcoming those barriers of referral. Now she reaches the facility. So what happened at the facility? Is the facility ready to handle her? Have we made these facilities ready? There are, as I said, many protocols for that. So to answer this question, I request Dr. Vidyut Sarkar, who is a lead for the first referral units in UPTSU of India. And he has earlier worked with WHO for over a decade, and he provides strategic direction and the technical support to the government of UP for building the capacities, developing systems to address the maternal complications and reduce the maternal mortality. So over to you, Dr. Bidyut. Please, you may join here. Yeah, you can come here, definitely. Thank you. So here is your.
Yeah, I'll do that.
Yeah, thank you.
That's okay. Good afternoon. I'll quickly go on to, talking of the operational strategies and approaches which have worked in UP, Uttar Pradesh. That is, we are talking of strategies and approaches to improve access to emergency obstetric care and to improve the facility readiness of FRU health facilities in UP. So first, we use the word FRU activation. So what is FRU activation? All it means is we have three components. We need specialist doctors or doctors trained specialists for managing the complications of pregnancy. We need a functional maternal operation theater, and we need blood transfusion. When we say that these are strategies which have worked, the evidence that they have worked is this. This is the graph which is showing the number of functional FRU health facilities in each month, starting from April 2018 to right now, September 25. So in April 2018, you would see there were about just 65 health facilities in the entire state of UP, mostly district hospitals, which could conduct C-section deliveries. We use C-section deliveries as an indicator of the capacity of a health facility to manage complications. And that went down during the two COVID waves, but went on to about 154 facilities in April of 22, went on to 200 plus in April of 23, and now we are up at 329 functional FRU health facilities in UP. While most of the facilities which had facility for emergency obstetric care were district hospitals, we have moved the needle even in the CHC FRUs, which are the block level facilities. And this graph tells you the number of functional CHC FRUs in UP as per HMIS data. Again, each month data is there. Earlier we had less than 50 CHC FRUs at the block level, which had EMOG facilities. Now we are up at 243 CHC FRU facilities at the block level, which are functional as per GOI definition. This is just for the last 2 years, the increase in the number of functional FRU facilities. The overall numbers have gone up from 130 to 229 in the last 2 years. And again, CHC FRUs has gone up from 63 to 243. We have, of course, a functional definition of ministry, which is a DH conducting at least 10 C-sections in a month, and a CHC FRU containing just minimum 5 C-sections in a month. These are, of course, just indicators. So what has worked in Uttar Pradesh, to improve access to CMOG services, to improve FRU facility readiness, and to make FRUs functional? What has worked for us, the primary driver has been using an effective task shifting model. We know that this session is for talking of coordinated care model, but coordinated care model cannot be operationalized when you have huge gaps in facility readiness, for emergency readiness, for gaps in huge manpower. There are no gynecologists, there are no anesthetists. So how can you operationalize coordinated care? So what has worked in UP is task shifting. And what is task shifting? Task shifting primarily refers to a strategy of redistribution of tasks and responsibilities within the healthcare teams, allowing non-specialists to perform roles typically reserved for specialized healthcare providers. thus optimizing service delivery and improving health outcomes. This was a very relevant innovation in context of UP. In UP, we had adequate number of MBBS doctors in the government health system. Almost all the positions were filled, but we had a 70% vacancy of specialist doctors. 70% of the positions in the UP government services for specialists were vacant. And hence, it would be very difficult to fill in that group. So we brought in what is called as the buddy-buddy model. This was adopted in 2019, wherein we brought in the task shifting government order, which allows MBBS doctors to first get trained in EMOC and LSAS. These are the two accredited courses that we have from Government of India. And then we introduced a period of clinical mentoring. After their 6-month course, they undergo a period of clinical mentoring at the district hospitals under specialists, and then they go on to go and activate their chosen FRUs. So one of the things about task shifting is, just like, it's very easy to talk about RCT theoretically. What is a RCT? It is very simple. But if you want to do a RCT, that's very difficult. Similarly, task shifting as a concept is very simple, right? But it is not just, most people think that it is just the training. No, it is not just the training. It is the whole policy framework, enablers, which allow effective task shifting to happen. Otherwise, people get trained and they remain there, not doing what they were supposed to do or what they were trained for. So what we brought in as a GO in 2019 had very specific policy enablers. One, they were allowed to choose their place of posting or their FRU by an open counseling. In government service, your posting is a very important thing, where you get posted. And here we had an open counseling, just like you have for NEET PG, that you choose the facility you're going to be posted in, right? Second, we had a period of clinical mentoring in the district hospital under specialists for gaining clinical confidence and experience. Additionally, we had incentive for each cesarean section conducted at a CHC FRU. This incentive was only there for doing C-sections at a CHC FRU. This is above and beyond the salary that these government doctors are getting. Plus, since they are not having a degree course of specialization, either of OBG or of anesthesia, we also brought in an element of legal indemnity. In case any case goes wrong and there's an award or punishment by a court of law, the state would cover and give legal indemnity, any such penal charges. Third, they were exempted from inter-district transfer for a period of 5 years, which again, for a government medical officer working in the government service is a big thing. Their transfer and the place of posting is a big motivation for most doctors. And so this is, in a sense, what happens in a buddy-buddy model. You choose medical officers and they undergo a 6-month training at accredited medical colleges, either on emergency obstetric care or on life-saving anesthesia skills. You would have come across a lot of literature as to what ails emergency obstetric care, and usually all of them mention anesthetists. Anesthetists are not there, not available, right? So this LSAS has been a boon, just 6-month training. Earlier, we had another 6 months of district mentoring, and then they're on the field and they're doing a fine job. So they do this clinical mentoring at the district hospital, and then they go ahead and manage the complications of pregnancy. And this buddy-buddy model was selected as a best practice at the National Summit of Best Replicable Practices by Government of India in 2019. So the learning from this is, how do you implement task shifting? That is the thing. A lot of people are doing trainings. You would have a lot of states. And I remember Dr. Rajni Vaid also saying, you say you've done task shifting. I'm asking other states, but they're not struggling. How do you implement task shifting? So the main thing is not just the training. The main thing is to be able to build robust policy framework. You need a government order which clearly tells the roles and responsibilities. You need allocation of funds and resources. It's a 6-month training. A doctor has to go to a different city, stay there, undergo the training. It requires funds. When we are trying to motivate them to do something more than their normal work as an MBBS doctor, they are given incentives for each cesarean section they are conducting at the CHCFRU. And all this was through the state PIP ROP route. So we proposed this in the state PIP, we got it approved in our ROP, and then we have implemented this incentives as well as this training in government of UP. Of course, you need very strict standardized training protocols. We are very happy to have the GOI standardized protocols for CMOC and LSAS. And then you have operational protocols of government orders and MD NHM's fund allocation for incentives as well as for the training. You also need implementation support, and you also need monitoring and feedback. And we have regular reviews of the DG Family Welfare, doing reviews, facility-wise, district-wise reviews of these performance of these facilities, and similarly the DG Training doing reviews. So these are the different batches, buddy 1, 2, 3, 4, 5, 6. We have 6 batches whom we have trained, and they've done the mentoring, and now they're out there in the field managing complications of pregnancy and conducting C-section deliveries. The 7th batch is started the training now. And the other important piece is the functional maternal OT. And for a functional maternal OT, you need essential OT equipment. Even simple things like a Boyle's trolley, a multi-para monitor, which you need in a maternal OT. And for this, we could get the districts to buy from the GEM portal these these essential OT equipments, not through we do have a UP Medical Supplies Corporation, but we did not do that. The MD NHM decentralized the funding for procurement. You have a GO that any equipment less than 2 lakhs can be procured directly by the districts. And that is how we now today, out of the 426 designated FRU facilities, we have essential OT equipments in 98% of them, which is 417 of them. So, and we have also now extended this task shifting to create radiologists. Ultrasound, antenatal ultrasound is such an essential facility that every pregnant woman needs. And now we have also started the task shifting ultrasonography course of 6 months for MBBS medical officers to close the gap of radiologists. Again, a very difficult sector to get on in the public sector. So I think I'm running out of time, but just to mention, is it all good? No, there are gaps. When we talk of emergency obstetric care, we talk of 24/7, right? And when we look at 24/7 emergency obstetric care in these, we have about 70% of the designated FRUs functional. But are they functional at night? No. The number drops down distinctly. It was 329 functional FRUs. When we see functional FRUs at night, it drops down to 159. That's about 50%. Only 50% are functional at night. And that's an area we definitely need to work on. And again, if you map these different FRUs which are doing C-sections at night, we come out with about 7 districts which do not have a single facility which is functional at night. So then again, these districts are our priority districts on which we are trying to work on for the night C-section. So I think I'll stop here because my time is up.
Thank you. Thank you very much, Dr. Bidyut. That was really wonderful, and I must congratulate UP under your leadership, how you've implemented this program and made it successful. I'm sure you will take it forward, and in the next
maybe a couple of years or so, you will see cesareans happening in the night as well. So you see, we've all seen that the fragmented, care, the fragmented pathways are really one of our biggest challenges. So this is one of the models which Dr. Vidyut just shared, how we can have a coordinated care. Now, I will now request the next speaker, Dr. Aparna Hegde. So thank you for joining once again here for this panel. So Dr. Aparna is, she has already been introduced. So she is the founder of a trust called Arman, and she's got some very nice care models which she's implemented in some of the states. So over to you, Dr. Aparna, that if you can say that you have taken the problem-solving initiative.
Yes.
So if you can share your experiences, how you are handling, how your programs can support the coordinated care models, how it can be, expedited, taken to the, scaled up to the other places. So over to you.
Yes. Thank you so much for this opportunity. I'm going to kind of go faster because of time limitations. But we all know why we need to look at high-risk pregnancies. We've spoken a lot in the last 1 hour. But there's one issue I would really want to talk about, which we at Arman have really focused on, and that is the fact that if you look at high-risk pregnancy management, in urban context, it's an obstetrician who would manage you end to end because they know the guidelines really, really well. When you look at rural India, unfortunately, what happens is that because you have a referral pathway, each cadre does not know their part of the role, right? So the A&M, the medical officer, and the specialist, they're not really aware of what is their part of the role, what treatment to give, what counseling to give, when to refer, what to do when the woman comes back to them, right? How to ensure, coordinated care in a manner that is closure to a group of care before it's too late. And that ends up, in delayed, complicated, and irrational referrals to tertiary hospitals, leading to mortality and morbidity. And we really focused on that issue. So I was a part of the Antenatal Care Guidelines Committee of Government of India in 2019, and we brought it to the notice of Government of India that in addition to technical guidelines, operational guidelines, sorry, you also need to have technical guidelines for each cadre so that everything is laid out in a detailed manner so that nothing is left to chance. And that really led on to a very important program for our a nonprofit called Integrated High-Risk Pregnancy Management and Tracking Program. So what do we do, right? So in 2019, with the permission of Government of India, for 35 high-risk conditions, possibly any high-risk factor woman can face, we had created algorithmic color-coded last detailed protocols for the nurse, the A&M, the medical officer, and the specialist. And we had gone through the vetting process for the same, for the 5 of the most important ones with the Government of India and multilateral agencies and doctors from all over the country in a big workshop, and then COVID struck. In the meantime, Telangana government accepted the entire thing. And so it's a 5-year program there, and we spread to other states. And let me tell you what we do there, right? So we've created these protocols, but when we go to every state, what we do is that we prioritize the conditions responsible for mortality in that state. So in Telangana, we've got 20 conditions, and we modified the protocols to suit those that state for those conditions, and now it's become policy. But so it's so important that you don't really you don't even only create policy, but so important train, handhold, and track. And that's what we do. And it's the entire circular approach that leads to improved, care for high-risk pregnancy and through the whole chain of antenatal care. And we provided training to around 12,000 A&Ms in Telangana, Andhra Pradesh, Maharashtra, some districts, Uttar Pradesh, Madhya Pradesh, and Assam Bodoland. And we've actually trained A&Ms, medical officers, around 4,000, and around 778 specialists of OBGYN. And what we do is that once we created the protocols, we assess the facilities. So in Andhra Pradesh, we did the entire, VD assessment, vital, essential, desirable assessment, where we looked at each facility to understand if they can implement the protocols. And we actually had this, assessment done for medical equipment, drugs, and documentation.
And in Uttar Pradesh, actually in 3 districts that we work, the facilities actually been upgraded to be able to implement the protocols. These are the 3 worst districts of Uttar Pradesh, and you can see the improvement over time, right? From August 24 to November 24, how the improvement has happened in these essential, equipment and drugs, so that we can actually implement the protocols in those districts. And then if you look at the protocols, right? So these protocols are color coded, right? So if nothing is left to chance. So the ANM knows exactly the last detailed needs of the woman, including, things that, it's very difficult to kind of objectify for every little condition what needs to be done. We've gone through that details with the doctors of the state. And once we do the training first face to face through the master trainers of the state. But the training is not just once. We also have a learning management system, and we're agnostic of the platform. So every state we use a state sanctioned learning management tool, and the protocols have been converted into live action videos, simulations, interactive quizzes, and notifications. So you learn face to face, and then you go back home. You have everything on your smartphone or tablet, so you can learn when you have time to do so. And then we have a whole tracking mechanism, right? So it's not only important to actually train, but also assess outcomes and has it led to change in the field. So in Telangana, what we've done is that we actually collaborated with the government of Telangana to actually layer these protocols on the KCR portal, which is the RCS database of the state. So we started off with 9 points where we actually kind of layered it on the RCS portal, and we're actually going on to do layering of all the protocols that we created for Telangana. And we have got around 24 pop-up messages in the portal itself that tells the ANM what to do when a particular high-risk factor is being picked up. And because the tracking word is often abused, it's not enough to track hemoglobin is 777 through pregnancy and then death. You need to actually understand where the issue has happened, and you can go back and then iteratively train the ANMs and the medical officers and where they've gone wrong. So we have this whole closed loop approach. And because of that approach, we've actually seen that the identification of high-risk factors in Telangana has increased. If you can look at, the graph from, April 2023 to 24 to, 3 successive years, the identification of high-risk factors actually increased. Look at the, almost, it's increased by double, literally in the last 3 years. But what we do is that the ANMs, when they're in the field and they have any query, so we've actually got the protocols, we've trained them on it, they've got the protocols on their phone. But when they go into the field and they have any query, then we have a chatbot. So it's a multilingual, multimodal chatbot that's been trained in the protocols. And the ANM can ask any query. So it's like a push or pull, modality. She can ask queries, but we also send suggested questions, and we want to go on to become an assistant for her in a manner that we can actually send her training also through the chatbot based upon her performance on the field. So in Uttar Pradesh, in 3 districts, Shravasti, Sambal, and Kosambi, which are the worst districts of Uttar Pradesh, we actually have this, chatbot, implemented in Hindi. And we are very surprised and pleasantly surprised and happy with the acceptance of the chatbot. It's got 70% activation. 597 ANMs have actually queried the chatbot at least once. Average 92 messages are received every day. And there's a great deal of satisfaction with the chatbot, in answering the questions. And what we do is that we escalate it to a medical officer if the chatbot can't answer appropriately, so that we have this step-by-step approach in, ensuring that the ANMs are handheld in the field. And now the chatbot has gone into Telangana, and shortly it will go to Maharashtra. And like I said, we have a pull mode right now. The ANMs can query us, but going forward, we want to be able to send information in a text manner or multimedia manner. We also want to have push mode where we can have personalized bite-sized lessons based upon what we find is her performance on the field. So if we find that after training, the ANM still does not know, something about hypertension, we can actually go back to the particular ANM and train her through the chatbot. And there is a continuous learning process built in. And we've really done a lot of studies to study the impact of this program. So in addition to situational analysis in the field in Telangana, we've done a maternal death review. We've done cross-sectional baseline surveys. We've done mixed method surveys to understand how well this program is doing in the field. So just briefly, because of lack of time, I'm going to go through some of the results, right? So let me just skip to the results. So the findings of the pre-post training. So what we do is that we train, we assess, we go back again and train, right? It's like a continuous loop. So training has really showed impact. So if you can look at the training in various conditions, both the ANMs and the medical officers have shown gain of knowledge in a pre-post test. We've done a maternal death review where we actually understood why the mortality often happens, because if you can see, the high-risk factor not being identified is one of the most important reasons for the maternal death. Secondly, is the quality of care. It's not just the access, right? It's the quality of care that is an issue in these areas. And we've done this, we're currently doing a prospective referral tracking of high-risk pregnancies in Telangana. So what we've done is that we got a stratified randomized sampling technique, and we got three broad regions we picked up: tribal, rural, and mixed population of urban and rural. And we're looking at 7 facilities in these areas, and we're actually tracking pregnant women throughout with high-risk factors to see how the program is working. And when we did a prevalence study in these hospitals, we found that moderate anemia and previous LSA are the most common HRPs, and most women tend to have only one high-risk pregnancy. And obviously, the women with multiple high-risk pregnancies form the highest risk group, and they need higher priority follow-up. And what we found that after we implemented the protocols, look at the increase in identification, right? Anemia went up from 58 to 215 cases in just that 1 month when you compare to, last year and this year. 174 high-risk cases picked up in the same month last year, and same April to October 24. And if you look at November to June 25, we picked up 540. So it's like increased in these facilities. And for each condition, what we've done is that we've looked at everything, like moderate anemia. So we picked up 5 high-risk conditions: moderate anemia, severe anemia, hypertension, diabetes, and one more condition, but I'll focus on anemia, hypertension, diabetes. What we did is that in all of these facilities, we looked at when the hemoglobin levels were picked up as being in anemia range, what was done, who identified, was the management according to the protocols, was the referral done in time, when was it picked up temporally, right? So what we found was, very quickly, what we found is that for moderate anemia and severe anemia, the diagnosis of anemia is occurring earlier. Secondly, ANMs are doing really, really well in correct referral and management, right? So the increase is from 11% to almost 52%. Unfortunately, MOs are not doing very well, the medical officers, because they keep changing, right? The medical officers are students who come in for their internship, and then they get changed every year. So it's very difficult to go back and do continuous medical education of these medical officers. But the ANMs are really showing improved management of these conditions. So this is for moderate anemia. If you look at severe anemia, again, the current management has improved from 80% to 100%, and referral has increased to almost improved by 38.5% in these hospitals. If you look at hypertension, the correct diagnosis and management referral has improved substantially among ANMs from 67% to 85%, and referrals increased from 33% to 77%. When I say referral, it means referral on time. And that's really critical in ensuring that, they do well, the women do well. And look at diabetes, what we found that ANMs did very well in diagnosis and management, but referral is still not there. So what we are doing now is to go back and train again. So this is like the whole program is that, like, we train, we handhold, we track, and then we go back and train again, So that's what, because in high-risk pregnancy, you can't even have, it's not enough to have 38% improvement, right? You have to have 100% improvement. That's when you will have mortality reducing. Thank you.
Thank you, Dr. Aparna. That was an excellent presentation. And, as we see these innovative models, the 2 innovations and the lessons that we've seen from UP and from Aparna, we heard, these are from the field. Now, how do we translate this or take it, to the larger
areas, larger scale it, sustain it. And so we need donor investment. So our next speaker we'll take it from online, and that's Dr. Radha. If we can have her bio, it is already there. She's been working in the space of NCDs, and she's currently leading the World Diabetes Foundation. So, Dr. Radha, I'm sorry to say that we are really short of time, and so I would we all will request you that if you can restrict your conversation for about 5 minutes, and of course we'll have a lot of interactive question and answer session. What all those who are present here, please keep your questions ready. We will have time for one or two burning questions here. So over to Radha, and the question that she's going to address is that how the complex coordinated care systems require sustained investments and patience. And from her being a donor, from her perspective, what you see is the strongest return on investment in the maternal health space, and what areas give you confidence that resources are making a real difference. So over to you, Dr. Radha. Yeah.
Thank you so much. Thank you to EFICON and the organizers for having me here and letting me be a part of this conference virtually. A little bit about me. I've been working in the NCD space for about a decade now in different states. And presently, I work with the World Diabetes Foundation. For those of you who are not aware, WDF is a Denmark-based organization, which is one of the key funders in the NCD space, as the name suggests, in the diabetes space. And in India, WDF has so far funded more than 100 projects in the last 20 years across 22 states and has contributed to more than 25 million euros. So when it comes to health systems, I feel integration and equity must be at the heart of health systems. WDF has advocated for the same everywhere, even at the recent United Nations General Assembly. When it comes to women and expectant mothers, we believe that they have to be looked at holistically and not as not as a center point of different health conditions approached through a fragmented manner. So to answer the question, from a donor perspective, I feel the greatest return of investment for us is when we place our bets on prevention. So while at one end we are working on strengthening the health systems, addressing issues around secondary prevention, screening, diagnosis, management, complication management also of diabetes, our strategy as donors in the NCD space has evolved in the recent years to also look at NCD prevention. NCD prevention is a way to reduce healthcare costs for families as well as for the health system in the long run. So in the context of maternal health, it has been well established. We have theories like Doha, the developmental origin of health and disease, and the Barker's theory, which well establish that origin of NCDs in an individual actually begins at the intrauterine stage. Not just the intrauterine environment, but exposures in the first 1,000 days of life, including nutrition in the first 1,000 days of life, can be a key determinant to the child developing non-communicable diseases along the course of their lives. And this is also what we call as the life course approach. So we have moved from funding diabetes care projects which focus on screening, diagnosis, and management to also placing our bets in the maternal health space, which focus at pregnancy care and also on infant and young child nutrition. Yet another point that I would like to make here is in the high risk pregnancy context, one condition which is often overlooked is hyperglycemia in pregnancy. Now we know that from the Indian statistics, about 13 to 15% of antenatal women are going to present with hyperglycemia in pregnancy. While our systems can easily detect HIP using oral glucose tolerance test, it is not being done in a universal fashion in most states of India. So WDF has been supporting JAPIGO in this endeavor. We have our project, which has just concluded in 2 states of India, Maharashtra and Madhya Pradesh, and is now being scaled across to 5 states in India, Madhya Pradesh, Maharashtra, Rajasthan, Punjab, and Karnataka, which focuses on making universal OGTT testing as a part of the antenatal care package. It's not just the testing, but the care that follows, including the medical nutrition therapy, treatment, referral linkages, and so on. Yet another piece here, which I would like to draw your attention to, is the postpartum screening using OGTT for women that have hyperglycemia in pregnancy. Now, we know that women who develop diabetes during pregnancy tend to go back to normoglycemia once the baby is delivered. But in a large proportion of women, the normoglycemia is not seen postpartum, which is also why it is essential that we track women up to 6 weeks postpartum and have them test for diabetes again using oral glucose tolerance test. Literature tells us that 5 to 10% of women are going to remain diabetic postpartum within 6 weeks postpartum. 20 to 30% will will develop type 2 diabetes within 5 years of giving birth, and up to 50% within 10 years. A lot of the women that we are talking about are in their 20s, and a lot of them are within 30 years, less than 30 years lifespan. And unfortunately, our NCD programs under Ayushman Bharat and the population based screening program that we have is not designed to pick these women, because it focuses on individuals that are above 30 years of age. It is also not designed to pick women that have hyperglycemia in pregnancy and link them to NCD for continuum of care. So I feel this is also one of the low hanging fruits when it comes to maternal health. So apart from the life course approach that I spoke about, focusing on health of mothers, health of babies, nutrition in children, and hyperglycemia in pregnancy, integration is key at different levels, and integration is in fact a predictor of how good the quality of care is going to be. A key point here, which I would like to mention, is regarding lack of interoperability within the existing data systems. So we have the RCH portal and the UNMOL, which looks at maternal health data. Then we have the NCD portal, which looks at NCD data, but these softwares do not communicate with one another, which leads to lack of tracking of cases across programs. So therein also comes the component of interprogrammatic coordination, and having a common identifier such as ABHA ID for these women, and ensuring that not just at data level, but also at program level, at the district, state, and national level, this is taken up as a priority area, not just by the maternal health division, but also by the NCD division at that level. Capacity building initiative, we have heard a lot since morning about variety of capacity building initiatives. I think we strongly advocate for integration also at capacity building level for all levels of healthcare providers, to also have NCD care component within the maternal health component, and look at it in a very coordinated and integrated manner. And last but not the least, I would like to mention a little bit about public-private partnership and give an example. In our upcoming partnership with JAPIGO, WDF is supporting JAPIGO in scaling up the hyperglycemia in pregnancy care initiative, standardizing care across 25 private health facilities which are listed under the Manyata program. So I feel we need not stop only at the public health facilities or having guidelines that are applicable only for public health institutions, but also think beyond this. An example I would like to give and conclude my input here in the interest of time. So through the WDF and JAPIGO partnership in two states, Madhya Pradesh and Maharashtra, more than 2.5 lakh women were screened, 25,000 were diagnosed to have hyperglycemia in pregnancy, and 20,000 were initiated on treatment, which includes medical management as well as medical nutrition therapy. In two states, efforts were made to universalize OGTT testing in the antenatal care package. And in two districts, it was demonstrated up to VHSND level, not just at the facility level. A win for us is that both states, Madhya Pradesh and Maharashtra, have dedicated budget to scaling up initiatives on hyperglycemia and pregnancy care in their upcoming PIPs. And Maharashtra has proposed that this be scaled up to 11 new districts over and above the 11 existing that we intervened in. So I would like to conclude by saying that we must focus on life course approach. We must focus on NCD prevention through the maternal health pathway, which is a win-win for both the maternal health interventions and the NCD interventions. And last but not the least, we must learn to analyze data not just from maternal mortality sense, not make that as the endpoint, but also develop capabilities of health system to measure NCD prevention through maternal and child health interventions in public health programs. Thank you so much.
Thank you. Thank you so much, Dr. Radha, for that, very lovely talk. And now we move on to the next segment, which is on the digital platforms and the coordinated care. But before I call Dr. Anunaya Jain from JPIGO, I would like to request Dr. Seema Prakash, who is a professor, UCMS and GTV, sitting amongst the audience. My apologies that we could not invite you earlier on the dais, so please come. So she will be speaking after Dr. Anunaya Jain on the field evidence from labor room decision making. What is the role of community and facility linkages there? So I now invite Dr. Anunaya Jain. So Anunaya, we've talked about the systems and the investments, but the technology is changing how we deliver care. Platforms like RCH 2.0 give us an opportunity to connect these dots across the continuum. So help us explore the digital innovations that can be scaled to make a coordinated care a reality.
Sure. So thank you very much. Thank you, Dr. Sunita, for asking that question. And thanks to the organizers for having me here. Thanks to the Gates Foundation for organizing this interesting session. For paucity of time, instead of going through a presentation or talking about a lot of possibilities, I'll tell a story. Right. And so this is in Madhya Pradesh. I clearly remember this is an auxiliary nurse midwife called Mumtaz. And I was speaking to Mumtaz, and we were talking about, hey, how do you really want to coordinate care for your high-risk pregnant women, right? I mean, what ails you? What would you rather have? And she said three very interesting things, right? And which is possibly my cue to saying that the possibilities that exist, given the digital platforms that we already have, given the foundation basis that has already been laid by the Ministry of Health and Family Welfare, by the state ministries themselves, with these digital platforms as well, right? So the first thing, one thing she said is, what happens is, the woman comes admitted to the labor room, and she's having a PPH after she's had a PPH, right? And she said, is it possible that we can use technology to perhaps even predict before the delivery that this woman is going to have a PPH? If that would happen, then I could make sure that there is blood, I could make sure that the OT is ready, I could make sure that all the preparations are done. And so that is the realm of possibility, right? It is very, very possible today. So we've been developing algorithms to understand which mother is going to have an adverse outcome, which newborn is going to have an adverse outcome, whether it's PPH, whether it's stillbirth, whether it's low birth weight, whether it's the need for admission to a newborn care unit. We've also done algorithms that essentially predict whether this mother will come back for her next and make a care visit or not, right? And so in early experiments that we've done, we've got a year-long implementation in parallel places as well. We've seen very good reduction in interruptions in treatment and in the preparation for management of these adverse events if you know these things in advance, right? The concept of lead time statisticians essentially is very important. That's the same thing that fits in here, right? So he said, okay, this can be done. We can of course give this to you. This is possible, right? What else do you want? And she said, "Ke, you know, kabhi kabhi kya hota hai, what happens sometimes is I'm recording hemoglobin and then I'm recording it in my diary first and then I have to enter it into my and then sometimes I'll pay a data entry operator to do this data entry. I have to do it, etc. And when you look at the data entry, all blood pressure is 120/80, 120/80, 110/70, 110/70, and so there is no variability in the data at all. There is no accuracy in the data at all. And so one of the things that we've done or that we've advocated for is to use point of care diagnostics. We all have these wonderful diagnostics equipment that can actually connect to the digital platforms directly and transfer the data directly to the digital platforms without having the need for a human to actually enter the data, right? What that resulted was that simple things like when we connected a digital hemoglobin meter that sent the hemoglobin readings directly to the digital platform itself, our identification went up from 22% to 32%. Just a connection, right? No change in training, nothing, no investment whatsoever on any of the large side of the business, but usually on making sure that the data can be sent from the device into the platform itself, right? Same thing with blood pressure. The most amazing thing was in weight, right? If you look at digital records that exist today, 40, 45, 48, right? 45, 50, 52, right? That's standard patterns, right? If you look at what happened after we integrated these technologies, the recording of weight around these measures went down from 51% to 2%, right? Massive change, right? So that's the second pitch, that having point of care diagnostics included that can actually connect will happen, right? And so when we did this, Mumtaz was really happy, and Mumtaz said, like, this makes life so much easier. I don't have to wait to do the data entry, the data automatically goes. So this reduces my burden as well. And then she said a third thing. She said that, how cool would it be that, that I know all of this stuff, but you expect me to look at the guidelines every time? That is not going to happen, right? What if some of these prompts were there in my system itself, right? My system would tell me what to do, and if I had a question, I would like there to be a supervisor to be there with me. And he said, you can't have a supervisor, right? We're short of nurses, we're short of doctors. Now you're telling us to give you a supervisor who's present with you all through, like a real personal coach. That's not going to happen. But you can actually do that, and you can actually do that with tech, right? And so what we've done is we've taken all of the maternal newborn care guidelines and what Dr. Abdul was also talking about, but train the bot on it. And now suddenly the guideline is a person that you can talk to, right? That you can have a conversation with, that you can ask them a question, that you can ask them to be your coach. Right. So we followed the Khan Academy model where the bot doesn't directly give you the answers when you want it to coach you. It keeps asking you questions and helps you develop your thought process. At the same point in time, it's also an assistant. And so when you need the urgent answers, when you need those calculations, etc., those are also available to you. Right. So we have a fair amount of maturity in the tech side of it, right? That we can bring into the system in order for the system to function better and for it to be more effective, for sure. And I think the opportunity is to quantify the effect of each one of these innovations, to understand what is the magnitude of outcome change that happens, what is the investment that can be calculated, what is the cost effectiveness of any of these interventions within the, and then to effectively scale them with the integration as well. But thank you very much.
Thank you, Ananya. That was really wonderful. You have really clearly shown that the RCS 2.0 and platforms like that are not just the data systems, they are the enablers for the coordinated, accountable care and learning. Thank you. So last but not the least, one of our guests, Dr. Aparna, Dr. Seema Prakash is here. Over to you, ma'am. Please come here. And in the meantime, if I may request all the panelists to be ready with your one recommendation, key takeaway from this entire panel discussion that we have.
So good afternoon, everyone. I think it's
we are running quite late for your lunch and you are all waiting for lunch. I'll not take much time because we have been talking a lot about evidences and the data from labor room and the maternity data from census from various districts, from various states. So I'll be talking more about the practical aspects because I, being a gynecologist, as a gynecologist and obstetrician, we face a lot of challenges managing high risk pregnancies which are referred or which are not properly referred, and some cases which could have been timely detected, high risk, and timely referred to a better center for proper care and to reduce the maternal mortality. So, without wasting much time, first of all, I like to thank the organizer for inviting me to this esteemed gathering. Basically, the healthy woman forms the cornerstone of a healthy, dynamic, and progressive nation. Safe pregnancy, childbirth, and postpartum period are most important milestones in continuum of care for women to achieve optimal maternal and neonatal outcome. So when we talk about field evidence, what we have been since morning we have been talking about, basically these evidences guide the policies maker and for their interventions and to implement them on state and district level so that there is improvement in overall maternal and child health. And it also identifies the disparities because there is a lot of disparity and inequalities across different regions, religions, states, and different, like we earlier also called in urban and rural areas, there is a lot of disparity. Then according to socioeconomic data, a lot of religions and regional disparities are there. So that has to be taken into consideration. So taking into consideration targeted intervention and resource allocation is made possible on the basis of field analysis. So as we all have learned since morning that some states in India have successfully reduced their MMR to level below the SDG target of 70 per 100,000 live births. Others still struggle with high maternal deaths. So a lot of South Indian states have achieved the target. So we need to improve the program effectiveness in other states by revealing what works at ground level, by understanding real world challenges women face, and policymaker can design and implement relevant programs accordingly. So at the national level, there is increase from 51% in previous 10 years to 59%. The women who are receiving 4 or more ANCs, because that is very important for identification of high risk cases, as well as there is increase in institutional births. So that has significantly increased from 79% to 89% at national level. In rural areas, it is 87%, and in urban areas, institutional delivery rate is quite good, that is 94%. So that all leads to improved maternal outcomes. Institutional delivery is very in the Kerala and Goa, Lakshadweep, Puducherry, Tamil Nadu are already doing very good with 100% institutional delivery rate, and other states there is around 90% institutional delivery. So there are various programs which have been launched. There should be shared decision making when we talk about labor room decision making. So there are 6 C's we must understand when we take the decision in the labor room. One is construct a clear picture of precisely what must be decided about the patient's diagnosis, the risk factor, the complication. Then compile a list of requirements that must be met. Like if we need to have a cesarean section or a vaginal delivery, what are the requirements? Collect information on alternatives that meet the requirements. Compare alternatives that meet the requirement. Consider what might go wrong. Suppose we are saying that we want to conduct a breech vaginal delivery. So when we explain to the patient that what are the complications, there may be head entrapment. So we have to take the data, and it should be evidence-based. We should not try to make the patient and their attendant afraid of what can be the outcome of this. So on the basis of evidence, we need to decide on that. Then commit a decision and follow through with it. Then my talk was basically on decision making in labor room. So there are 4 aspects of decision making in labor room. Women and caregiver relationship. There should be a respectful communication, empathy, trust, personal values, knowledge-based communication, involvement in the decision maker of the women as well as her attendants, emotional response by clinicians, women-centered care, continuity of care, and human right-based approach should be there. And there should be no authoritative communication like if we say that I need to do this or we will have to do this. It should not, like these kind of words should not be used when we make a decision in the labor room. Then consent and legal issues. The consent should be clear in the patient's own language. There should be respectful maternity care model. Personal autonomy should be provided to the patient and their attendants. We should not hide any information like whatever data or whatever evidence is there for that particular situation. We should not be hiding that, and obstetric violence should be avoided. On organization level also, same kind of good work atmosphere should be there. There should be a lot of training of the staff, and there should be medicalized approach to the birth. Then what is decision making tools and models? There is shared decision making. Communication tools are there. Then there is mother's autonomy decision in making a choice should be there. Then there should be free talk between the caregiver and the patient, and there should be timed out a procedure during the prolonged labor, and there should be team birth model should be applied. Here I will not go into much detail, but I will be taking these cases which were referred to us. This first case was referred on second day with a multi-gravida patient, para 3, L3, gravida 4. At term, she had abdominal pain, was being seen at a PSC level, but she was referred when she became, her pulse was tachycardia, low volume, and BP just fell, and she was referred to our center. And here we delivered the patient, but the baby was no more as there was rupture of uterus and we could not even save the uterus. And it was an adherent placenta because of previous cesarean section. So these kind of cases need to be dealt with, and we need to make everyone aware that what can be the complication. Like in previous cesarean section, we must rule out accreta, we must rule out percreta, which are very life-threatening situation. Second patient was para 3, L3, gravida 4. She had again scar tenderness, but she was referred with scar tenderness, and thankfully her uterus could be saved and the patient could be saved. This patient, another one, she had placenta percreta, which was undiagnosed previous to cesarean, and she was referred, although she was referred to us timely, but she was bleeding a lot, so she has to be taken up in the OT without any imaging. So it came to us as a surprise that she was a placenta percreta. And as we all know that with percreta, there can be bowel and bladder injury, ureter injury, and we have to remove the uterus, and it becomes a very critical condition. The fourth patient came to us in sepsis. There was severe peritonitis. The TLC counts were very raised. We could do hysterectomy of the patient. Patient had a prolonged ICU stay. Although this patient could also be saved, but with much difficulty after 62 days of ICU stay. So these all cases are just an example to give you a brief outline that how all these complications can be reverted and can be taken care on time if we make the ANMs, ASHA workers, and the nurses aware of the various diagnoses and their outcomes and their complications. So in conclusion, the importance of relationship between women and caregivers to enable shared decision making, and then communicating in an understandable way with the women using evidence-based knowledge while listening, being open, respectful, empathetic, and supportive towards her values and preferences. Barriers related to working situation for HCPs as well as legal and societal circumstances need to be addressed. Then balancing expertise of caregivers with evidence-based practices is crucial. Community plays important role to reduce maternal and neonatal morbidity and mortality. A trusting relationship between mother, partner, and healthcare provider is of utmost importance. Then strengthening healthcare infrastructure, expanding maternal health programs, and addressing socio-economic barriers will be critical in further reducing maternal mortality. And community participation and awareness is also very important. Thank you so much.
Thank you very much, Dr. Seema, for bringing out those lovely slides. It just shows that you are working in a tertiary care hospital. Your facility is always ready with all, gadgets. Whatever you need is, just at the but immediately. So when we are talking about operationalizations of FRU, how the referrals from the remote areas right up to this area, I think we need to have proper strategies. So if while we wrap up, so I would like to every speaker here to give at least one recommendation briefly, just one recommendation. If you have any, otherwise I will wrap up. Yes, Dr. Vidyut, any one recommendation for the system for scaling up the coordinated care?
Well, my recommendation would be, for scaling up coordinated care, we definitely need to close the gap of human resources. And for that, we need to, of course, task shifting has worked to some extent, but then we still see that there are gaps when we're coming to 24-hour service. So we need to also work on retention of the specialists in the system.
Very well stated. Very well stated. Thank you.
Both financial as well as non-financial.
Thank you.
We need to work more on that.
Dr. Aparna, any single
just one
recommendation?
Tracking. I think it's really, really important to track the outcomes of the program so that you can go and do iterative program improvement. That's an extreme, and tracking to the granular level. It's not just enough to know, half the time it's like when you see
Simply
it's like
labeling.
Yeah.
Agree.
Digital tracking. Exactly. We are tech plus touch, so whatever I say is always tech.
So please be close to the mic, yeah?
Without taking too much time, don't just collect data, don't just create data, use it.
Very well said.
And it should be started early, like in adolescent period, we should start counseling, education, so that the reserve in the patient is good
So
for
what I
managing
understand,
complications.
the making the women and the children ready to bear this, it could be a part of the preconception care model then.
Actually.
Thank you very much.
Thank you so much.
Question. Any question from the audience for staying back so long? Any burning question to any of the panelists? Please, this is time to ask the same. No question? So, okay, thank you very much. Please come here. Thank you for your patience, all of you.
Just checking if I'm seen online.
Thank you.
Yes. Thank you for the wonderful moderation.
Okay.
Okay. Very well. You were very good actually.
Yeah, because I got engrossed in listening to everyone. So कभी-कभी लगता है कि अरे time है रोको भी तो.
Yes. Believe.
18 years old. I'm a professor of urogynecology.
But you are still
I have a private practice and it's the Department of Urogynecology, Address, Mumbai. So it's a government hospital. I signed the MOU with Government of Maharashtra. It's the first department. I'm an honorary professor there. I'm a fellowship program. I've got private practice in urogynecology. hardcore application और नहीं तो मैं तो निर्माण भवन मिनिस्ट्री से ऑफ प्रोग्राम रिक्वेस्ट used to come to Samvidhan and वो सब मेरे ऊपर डाल दी जाती थी all the other people know me very well so मैं दिल्ली में भी एक सेंटर है करिश्मा थरानी हैंडल्स it
Right, meeting you.
yeah
And apologies again.
no
How the
don't repeat that
trend changed,
No,
and
yeah.
I would have should have called you earlier. अरे तुम तो अपने पड़ोसी हो.
I you know I'm
My
from
husband is
Samvidhan.
from here.
Ames
Good afternoon. We are starting the session. Please be seated. This session again is going to be very, very interesting session where you're going to have exposure to the practical experiences, how this continuum of medical MCH care and quality of care has been integrated at the different level. And may I invite the coordinators for this session. Major General Atul Kotwal, sir, please come to the dais. Professor Sunila Garg, ma'am, please come to the dais. Okay, sir, I hand over to you.
Thank you, Dr. Sood, sir. Must thank the organizers for giving us the opportunity to organize this session on a very important topic, maternal health. There are going to be three speakers, one talking about the study which NHRC and University of Manitoba did in collaboration. And they look at the exemplars in maternal and neonatal health, what works where. And it also covered, of course, what doesn't work and what needs to improve. And those, what is working where, how they can be further, upscaled and replicated in other places. Then advisor community process will talk about the role of comprehensive primary health care in maternal health. And advisor healthcare technology will talk about the leveraging technology for maternal health. As we know that, the tremendous progress has been made in maternal mortality ratio all over the world. And India has done the maximum actually in last few decades. The steepest decline in the entire world has been of our country. But then much more needs to be done. The preventable maternal mortality, to bring it to zero, we need a continuum of care approach, a life cycle approach. Easier said than done. They're very easy in theory, but then on ground, and all of you, those of you who were there yesterday talking about the implementation research, looking at how policies are implemented and how we need to understand what are the enablers and what are the barriers and how we need to integrate and improve the entire health system and also involve the community in all our activities. So instead of the 15 minutes allotted to us chairs, we'll just take 2 minutes each and give more time to the speakers and probably add something later on after each speaker's talk and give some time for question answer session in the end instead of only us talking from the podium. So the importance of MMR, maternal mortality, everyone knows all of those, even the sparse audience which is there, you all are fully aware of that. So I don't need to dwell upon that. But let me just here flag one important thing that, the need for maternal mortality, it's not only we should not look at only the antenatal care and intrapartum care and postpartum care. It is much more beyond starting from basically the womb and then continues adolescence and then of course the further age as the girls grow. It is also linked very closely with what kind of infrastructure we have, what kind of governance mechanism we have, how good our human resources of health are, the numbers, adequate numbers, and also the technical skills which they have, and the drugs, diagnostics availability, the referral mechanism, the availability of all equipment which is required, and of course, the respectful care, the quality care, and safe care, and follow-up. And technology, not only the digital, but also new technology, how we can leverage to prevent the mortality, to reduce the mortality further and make the preventable mortality as zero. That's, I think, should be the aim which our country is now looking at. So with that, I'll request all three speakers to join us on the stage. And then instead of coming one by one, Dr. Madan Gopal, Dr. Giri Singh, Dr. Ranjan Chaudhary, please come and join us here. From here on, they can go to lectern subsequently. Over to Dr. Sunila Garg, ma'am.
Thank you so much. And I think this is a very, very important session. And earlier, before the importance of the session lies in the fact that before lunch also, for 1.5 hours, we discussed about this whole issue of maternal health, maternal mortality, what are the enabling factors and all that. And plus, we also talked about task shifting. And this is a very, very appropriate time from NHRC's perspective when you are upgrading, FRUs, not only in terms of, the maternal health, but increasing burden of NCDs, road traffic accidents and all in an overall perspective manner, I think in a comprehensive manner, our FRUs are being upgraded so that, we can address most of the issues at FRU level itself. So as I said, that will not take much of time and we'll listen to this very important, all the three presentations by three eminent speakers. And then we can take, some questions towards the end, which are there, because these studies will provide a further roadmap for how we can go from now when we are talking of 77 per thousand to further reduction of maternal mortality. Plus, it's not only mortality and morbidity part, but overall health of the women, which will empower them. Thank you so much. Thank you.
So with that, I'll request Dr. K. Madan Gopal, who's an MD Community Medicine, a very senior public health specialist, renowned. I think all of you sitting here must be knowing about him by now. His earlier stellar contribution to health system when he was in SHSRC in Chhattisgarh, subsequently in Niti Aayog, and then the last 2.5 years plus in the NHSRC as advisor, public health administration. The public health administration division looks after all the disease programs and also maternal and child health and all also, and also the secondary care, legal aspects, including emergency trauma care and all also. So with that, Dr. Madan Gopal, stage is yours. Reimagining maternal health from exemplars to evidence-based systems for continuum and quality of care. Over to you.
Okay, thank you, sir. It's a great honor to present to my ex-boss and my friend and philosopher, Professor Sunila Garg, and some of my colleagues who are sitting here, and esteemed guests. We all talk about what has worked, what has not worked. We always try to find gaps in the system. The system, this is not working, that is not working, these are the gaps, you should be doing these things. But what has worked over the years, we should be celebrating that. And this MNH exemplar studies across the world is an example, setting an example what has worked, how the learnings of one country can influence and tell the other countries that if you are able to do things in that way, things will move in that particular direction. I will just sharing the celebrations and the things which we have achieved in the last 2 decades, what has happened, what has worked in the field of mother and child health, and how we are moving in that direction. You see the global trend, as Professor Kotwal has mentioned, that as compared to the global maternal mortality ratio, our maternal mortality ratio has, the decline has been tremendous as compared to this. In the subsequent slide, you will appreciate why I am saying this. The global maternal mortality ratio, when the reference period which we are taking is 2000, and we are trying to cover what has happened till now. The global maternity mortality ratio decreased from 339 to 197 in 2023. But if you look at the way in which we have progressed, it is 80 and not 80. So you see that how steep decline India has happened. Between 1990 and 23, you see 86% decline is there in the Indian context as compared to the global MMR, which has declined by 48%. Our SDG target of 3.1 point is less than 70 per 1 lakh live births by 2030. And we will be very happy to report that more than 8 states have already attained this SDG targets, and many are more or less near this SDG target. If you look at the neonatal mortality rates also, between 1990 and 23, India has shown a decline of 70%, whereas the global NMR declined by 54%. That means the efforts which we are putting in, the country and the state governments which are putting in this effort, that is yielding result. If you talk about in the terms of SDG target 3.2, we are aiming at less than or equal to 12 deaths per 1,000 live births by 2030. And 6 states have already achieved it. That means the efforts, the schemes, the programs which we are putting in they are yielding results. Now, this is an exemplar study. It is for providing evidence-based recommendation for other countries for planning future strategies to further reduce maternal and neonatal mortality. Nothing that is a cross-learning between the states, cross-learning between the districts, what has worked, what are the best practices. Usually in a common parlor, we say that is the best practice which is there, which can be replicated in the given scenario. These are the countries which were chosen by the exemplar group for these studies. North Africa, Middle East, Morocco was true. In the South Asia, India was chosen. And why India was chosen? Because we have presented at that time when in 2000, it was 23% of the global maternal deaths were contributed by our country. And 31% of the neonatal deaths equally was contributed from here. But between this, India MMR decrease from theta, the decrease was also there. That means from 2000 to 2021, the decrease has been there. MMR also fall. That's why it was agreed that we should be seeing that for this sharp decline, what are the factors which have influenced? That's why this study was carried out. The 6 exemplar states were selected for carrying out an in-depth study. Selecting this criteria was based on the higher mortality cluster and the lower mortality cluster. It is the clusters were decided based on the average annual rates of change of NMR and MMR, which were summed up and ranked to find out the top performing states in the state cluster. And accordingly, in the higher mortality state cluster, Rajasthan, Odisha, Uttar Pradesh, Madhya Pradesh were there. They were selected. In the lower mortality state cluster, Maharashtra and Tamil Nadu was selected. One of the interesting observations in this both the clusters, which has contributed to the declines, has been the fertility declines. The fertility decline has been very steadily because the national population policy, which we have pushed in the early 2000s, it talked about reducing the mortality so that you can achieve the fertility and other trends. And that results are quite visible. The fertility has steadily declined in both the state clusters in 1970s. Although fertility declined in both the cluster, population momentum was different. In the lower cluster states, the momentum was low, whereas in the higher cluster states, the momentum was high. The number of births in the higher mortality states increased from 14.6 to 15.8 million between 2000 and 2019, while it reduced from 10.5 to 9.8 million. The reference period has been, we did this study in between 21 and 23. That's why increasingly we'll be finding the reference of 2019 and 2020, 21. If you talk about the critical periods of policy change were also analyzed in this study, you see that how things have happened. Initially, we used to talk about mother and child survival. It started with UIP, then the child survival saved motherhood, then RCH1, RCH2, and ultimately when we become signatory to the Millennium Development Goals, a vehicle was required in a mission board. That's why this National Rural Health Mission was launched and it started. We see that this is a period wherein a lot of changes have happened. In 2005 to 2012, we have emphasized on the institutional birth, increased attention to neonatal care and community engagement. This was first of the things which have added, because since 78, when we have agreed on the definition of health, wherein one of the strategy included for primary healthcare approach was community engagement. But it got translated when the NHM was launched, when formally and with the institutional structure, we started engaging with the community. Then these are the health policy periods, which has, and the activities which become a game-changing moment for the country. In RCH1, the MTP Act was there, LSCS training for medical officers to provide CMOP training, it was also there. Because we were fighting with the dearth of vacancies for the specialists, especially for the obs and gynae and the anesthesia. So these two programs, they have contributed a lot. We did a study also. It has also collaborated with the findings and other things. The creation of FRU guidelines started because the previous session they were talking about the FRUs. That first referral unit concept came in 2004. Besides that, when NRHM was started, we started with IPHS guideline. It at least mentioned about the minimum standards required for starting an institution. The other thing, integrated 24/7 ambulances, SNCU, then the SBA training guideline, JSSK launched, HBNC guidelines, NQAS certification for providing quality of services. Then subsequently, between the next cycle after 2013, when both the programs, the NRHM and the NUHM, they were merged and the NHM was formed. Here the focus was that the JSSK was extended to cover the ANC, PNC children up to 1 year of age. Then Daksha skill labs were introduced for providing a labor room qualities and other things. HBNC guidelines, Dakshata program, PMMVY program, then Lakshya program, Poshan Abhiyan and Suman program. These are all started during this time. But these are the measures taken to improve the maternal and child health in India. As I mentioned, just a repetition of the previous slide in a pictorial form. That was Janani Suraksha Yojana in 2005, Janani Suraksha Shishu Suraksha कार्यक्रम, NQA certification, Pradhan Mantri Surakshit Abhiyan, Matratva Abhiyan, which is still going on. The Lakshya certification, Poshan Abhiyan, Surakshit Matratva Ashwasan, Suman. These are assurance that the government is giving to all the pregnant women. Then the Muskan for the children. Then these are the following major trajectories of the health system. They have helped us in shifting and improving the service delivery. The increasing comprehensive healthcare with the pro-poor focus. Then after 2017 onwards, based on the recommendations of the high-level expert group and the 11 finance cycles, at the end of the 11 finance commission cycle, this report was that this formed the basis for comprehensive primary healthcare in the country, and increasingly comprehensive primary healthcare with pro-poor focus has been pushed. The community engagement, as I mentioned, that's another systemic trajectory which has resulted in this decline. The shifting childbirth from home and the traditional birth attendance to facilities and the skilled birth attendance. That's what the major shift to policy shift which has happened, improving the availability of facilities and frontline health worker services. These are the systemic changes which has happened. Expanded access to evidence-based life-saving technical services, even at lower levels. Now, you see that how we have been able to leverage the digital technologies also for providing a good quality advanced care at the lower level facilities also. Apart from that, there are other administrative changes and policy reforms. We have been able to provide increased amount of funds and flexibility of funding. Decentralized planning, increased state ownership, accountability, data use for monitoring. We have been increasingly moving from just input-based monitoring to a data-driven governance aspect. You will be seeing a lot of use of data in the coming years and trying to see that how, because that thought process is there, that's why they are trying to see that how you can have integration of all the portals so that that can be analyzed and triangulation can happen and some policy level insights and inputs can be received from that. The strengthened policies for supplies and logistics, the emergency transport system, these are all the systemic level trajectories which has influenced the outcome of all these things. So they are all state specific thing. The state has achieved the target. This is the from the low mortality clusters. This is about the summary, major progress in reducing neonatal mortality. The major causes have been reduced. Greater mortality reduction were in the first 2 years of life. And if you talk about the gains in the intervention coverage, ANC and other things have happened, it has continued progress in reaching near universality of the intervention among the disadvantaged population. Now most of the women they are delivering in the hospitals. But if you talk about the Tamil Nadu, these are again low mortality state cluster. The fastest decline in MMR was during the period 2000 to 2005, and the NMR during 2005 to 2012. It consistently lower than the other state clusters and all India, while the NMR was consistently lower than this. It is one of the best performing states in this cluster. Then these are the major things which has happened, which has resulted in this. They are having a high production for doctors, nurses, and this, and they have been able to deploy these doctors in their places. The state was first to introduce a benefit scheme, that is Muthu Lakshmi Reddy maternity. We encourage the healthcare use among the poor before our national level schemes. If you talk about the Odisha NMR levels, this is the situation. All the states, even the low performing in the high mortality clusters, they have shown a decline. These are the major, all causes of the neonatal deaths have been reduced. The gains of the intervention coverages were greatest during NHM and HM period. That means after the scheme change from RCH1 and we entered into a mission mode, the gains were more high in the high mortality cluster states. Then you talk about the other things in Odisha, it was a public sector driven scheme which accounted for all the institutions. In fact, 90% of the institution delivery happened in the healthcare, public health facilities. If you talk about the Rajasthan, the decline is also the same. But these are the major things which have happened. All the causes have been affected, the reinfection, birth asphyxia, and prematurity. They were all at risk. They are all declining. The public sector has driven this increase. Then if you talk about the Madhya Pradesh MMR levels, the trend also continues compared to the state cluster and all India. It's all the declining. But these are the major gains which have happened. All the causes have been addressed. Greater than most of the high mortality states, the public sector has driven this. That means all the high mortality cluster states, it's the public sector which has helped, and our schemes which are linked to bringing the people to the institution that has worked. If you talk about the other state, this is what which state is there? Talk about the chalo theek hai, bhul gaya. So if you talk about this is about the Uttar Pradesh, sorry. Uttar Pradesh also, a lot of things have happened. They have focused on the establishment of the newborn care corners, newborn stabilization units, and special newborn cares. But they have focused on partnership and collaboration in the state, and that has resulted in declining of the other things. Way forward is mortality. NMR among home deliveries have been stagnant, that is about 35, indicating a need for near universal coverage of facilities. That means if you want to reduce the NMR further, you have to bring all the deliveries to the, there should not be any home-based delivery. Coverage and equity, increased access to healthcare, mainly hospital delivery, C-section, other life. ANC must improve alongside increase in facilities to advance to later stages of transition and reach high coverage and quality levels. They continued focus on expanding intervention coverage to the poorest in this. Fertility declines possible, the declines are possible, especially among the poorest, but improvements in mortality reduction likely to be modest. Because if you remember the national population policy, which talks about reduction in mortality, reduction in infant mortality, which can directly impact the fertility things, that we have to move in that. Cause of that is also the further decline in the infectious disease and peripartum conditions, such as will increase the importance of neonatal survival. For maternal mortality, complex care for indirect cases will increasingly important. So for coverage and equity, delivery care in healthcare facilities should be nearly universal. C-section among poorest 12 quintile indicates sufficient access. It's not that they don't have access, but the study indicates that they do have access to the C-section rates. Despite major reduction in inequities, NMR poor-rich gap still continues. Stage 5 fertility levels achieved, but no further gains from fertility decline can be expected and are unlikely. So thank you very much. Thanks for patient. Thank you.
Thank you, Dr. Madan, for that excellent talk and also sharing the exemplar study findings. And as mentioned by him to the beginning, that we must know what is actually working rather than always saying this is not working and that is not working. But FRUs, I think that's what comes to my mind again and again. I think we have reached a stage where every CSC has to be an FRU. We should stop having distinction of non or FRUs, non-FRU CHC or FRU CHC. It's time that we need to have every CHC as fully functional FRU. So with that, we come to the next presentation. Yes.
I have the pleasure of inviting Dr. G.B. Singh, who is advisor CPHC division at NHSRC, and very, very important topic, Dr. Strengthening the continuum of maternal health through comprehensive primary health care. So this is something which we all talk about, and we were discussing, Professor Kotwal and myself, that when we talk about the, from the system perspective, it's where the ops, gynae, and people who are really there should also be present. Thank you so much.
And just 2 words about Dr. G.B. Singh, a very stellar career. He retired at the pinnacle of the Health Services of Punjab as Director of Health Services 2 years ago and joined NHSRC since then as advisor, community process and comprehensive primary health care. Over to you, Dr. G.B. Singh.
Thank you very much, sir. Thanks to the organizers for giving us an opportunity to be here, and thanks to the chairs for this opportunity. Dr. Madan Gopal has just now talked about the secondary healthcare, that FRUs, what we need to do in the hospitals, where are the issues. So talking about the primary healthcare, what are the issues, what we are looking at? We have been providing the maternal health services since the times immemorial. We talked about MCH, we talked about RCH, then we came to NRHM, then NHM. Where the maternal health has always been a priority because of the very high rates of high numbers of maternal deaths. Why it's still important? Because it's the maternal health that indicates or shows or reflects the overall effectiveness of the health system. What is the excess of the services at the grassroots level? What's the quality of services that we're providing, the equity, and of course, the responsiveness of a system towards the maternal health care services. Then, of course, we are also looking at these maternal health is also depends upon or it indicates the improving, looks at the improving the maternal health outcome, maternal outcomes. There has been a reduction in maternal mortality over the last almost 3 decades, from 556 to 88. We all know that, but there are a lot of disparities among states. Even today, we find there are states which are almost less than 50, and there are still states which are more than 100. So these issues are still there across country. Then, of course, the major causes we all know, and they are still persisting. So what to do? Millennium Development Goals, of course, we looked at, again, the maternal health was the topmost agenda for the Millennium Health Goals, but still we look at there are disparities, there have been issues that we have not been able to cover completely, and we have not been able to achieve the results that we had wanted to. Although we have achieved a lot, but still where there is a long way to go to the final goals. Health policy 2017 again laid a lot of stress on the maternal health services, shifting from primary to comprehensive primary health, from selective to comprehensive primary health care, in the sense that we have included all the other aspects of primary health care into our comprehensive healthcare services. But how far we are successful in achieving the targets of maternal health, yes, we all know. And the Ayushman Arogya Mandir initiative by the government of India under Ayushman Bharat, it is contributing a lot towards improving the all aspects of healthcare services, including the maternal health. With more than 1.8 lakh subsidiary health center or the sub health centers and the primary health centers being converted into Ayushman Arogya Mandirs. The services are definitely improving. We have seen that the inclusion of larger manpower, inclusion of the CHOs at the Ayushman Arogya Mandirs, that has made a lot of difference in improving the healthcare services. Addressing the maternal health through the continuum, right from the childhood and more specifically from adolescent health to the motherhood. So this is an important and very definitive approach that is going to help us in improving the maternal health outcomes as we progress further. Then, of course, the healthcare system, the primary healthcare system constituting of, as I said, almost 1.8 lakh Ayushman Arogya Mandirs, and with the first point of contact being slightly higher than the ANM, that is the CHO or the community health officers who are able to provide the healthcare services, and of course, providing a continuum of care from primary to secondary to tertiary, which is giving us a lot of impact as far as the referral services both ways are concerned. So referral upwards and downwards, that is the cornerstone of the of our healthcare system as of today under the comprehensive primary healthcare. Of course, we have always tried to align our goals with the international goals. So aligning with the Sustainable Development Goals at the international level with the universal health coverage, and not to leave behind the Alma-Ata and the Sahara declarations. The national health policy definitely aligns with the state sustainable development goals, and of course, along with that, the elimination of diseases and the digital health mission, which is supporting us in data management and in looking at the the availability of services at different levels. So some of the key reforms that we have undertaken, there is a huge improvement in the infrastructure. There is a huge improvement on changes in the HR at the grassroots level, with the labor room complexes coming up at the primary health center levels, both in the rural as well as in the urban areas. Newborn corners at the primary health centers, which are helping us improve the health outcomes for both for the mother as well as for the child. As I said, for the human, as far as the human resources are concerned, the introduction of CHO, a very important cadre for the improvement of and provision of the comprehensive primary healthcare services at the grassroots level, has made a lot of difference in providing these services at the village level. And similarly, the continuum of care through the primary health centers, through the CHCs, whether it is through the IT applications, that is e-Sanjeevani, that is teleconsultation, or it is through the maintenance of data through regular checkups, regular monitoring, apart from that, regular follow-ups of all the patients and mothers. So that has made a lot of difference in improving the quality of services that are being provided through our sub-health centers and the primary health centers, now the Ayushman Roga Bandhas. So what is this improved continuum through CPHC? So we see that pre-pregnancy and reproductive health, of course, what I would like to point out here is that the family planning always considered as a mode of or methods to reduce the number of children. We never looked at it as a method for improving the maternal health. So when we talked about 3 years of gap between two pregnancies, the people were always thinking about that contraception is probably only about reducing the number of children. We never promoted family planning as an important method for improving the maternal as well as child health. So we need to have a more focus towards that particular aspect of family planning, and if required, maybe we might think of changing the name of the program as such, or not the program alone. I would say that the intervention needs to be rephrased. That it's not about family planning, but it is about improving the maternal and child health outcomes. Then, of course, improving the antenatal care, risk assessment at the grassroots level, village level, with the support of ASHAs. Again, a very important and a very huge component of the comprehensive primary health care at the village level, who are helping us in identifying the high-risk pregnancies, who are helping us in identifying other diseases at the village level, and creating a very good continuum or referral system from village to the sub-center. So they are the facilitators who are helping the village people to come to the health facilities for proper and adequate and appropriate health care. Then skilled delivery and intrapartum care. Of course, we have been all through these years, we have been advocating about the institutional deliveries, but the repercussion of that turned out to be increase the number of cesareans. Recently, we had this common review mission, where we found that there are states where the people are now reverting back to the normal deliveries, but and they are actually going in for normal deliveries, and they are advocates for going back to the normal vaginal delivery, so that there is a reduction in the number of cesarean sections, and that is also going to reduce the maternal, have some impact on this as well. Then, of course, the postnatal care through the field level workers with the support of ANMs and ASHAs at the field level, and recently we are also currently we are also changing in the process of revising the HbNc, HbYc guidelines, wherein we are trying to increase the number of visits. We are trying to increase the contact with the lactating mother over a period of time, so that there are more follow-ups with the ANMs and the ASHAs, so that any problem that they can be taken care of very quickly and easily. And at the same time, the integration with the other packages, like the nutrition, the NCDs, so that the mothers who are suffering from these other diseases, the non-communicable diseases, they are also taken care of in time. Then, of course, the convergence of all major schemes for the maternal health at the Ayushman Arogya Mandir, so that there is timely disbursal of all the benefits to the pregnant and lactating mother, so that they are able to take benefit of those schemes at that level. And then, of course, as I said, at the community level, the ASHAs and the ANMs forming the basic first step of the ladder to provide the preventive and promotive care services at the village level, and provide taking care of the pregnant women before pregnancy as well as during pregnancy, and timely referral of all the beneficiaries to the appropriate places for the continuum of care. Similarly, at the VHSNDs, where we have been providing these services for the last more than 30-40 years, but then increasing the effectiveness of VHSNDs and making efforts that they are able to reach the VHSND, and we are expanding the scope of VHSNDs so as to include the non-communicable diseases and other problems as well, so that there are more comprehensive approaches is taken, and we are able to provide good services and additional services at the VHSND as well, to take care of the maternal health services in addition. Then at the sub-health centers or the Ayushman Arogya Mandirs, the community health officers are there to take care of the cases referred from the field, and of course the availability of teleconsultation services at the sub-health centers or the Ayushman Arogya Mandirs sub-health centers, providing direct access to the services of medical officers through the teleconsultation at the primary health center, and there are different mechanisms reaching up to the specialists also through teleconsultation at the district level or at the state level hubs as well, and they are able to avail the services without any actual physical travel from one place to the other, with the result that this also helps in reducing the out-of-pocket expenditures for the pregnant women, as well as it reduces their problems also, and it improves the access to services as well. Then, of course, referral linkages, we have already talked about. Of course, the PMSMA, the 1 day per month having access to services to all pregnant women through a gynecologist or a medical officer at the block level and at the higher levels. So that is again important for improving the maternal health care outcomes. Then, of course, the secondary healthcare, easy referrals through 102, 108 to the CHCs, to the sub-divisional and district hospitals and tertiary level institutions as and when required. And at the same time, availability of advanced diagnostics and complication assessment at those levels as per the requirement. And then what is most important is the back referral from these institutions from secondary level to the primary level, so that the continuation of treatment and continuation of care that is maintained and ensured at the grassroots level as well. Then, as we have already talked about, the teleconsultation, a very important intervention and very important activity, or we can say an important method for the continuum of care from primary to secondary to tertiary. And of course, the referral, back referral is one of the most important mainstays in teleconsultation services. So upward and downward referrals are very important from all levels. And then, of course, we have been talking about taking care of 3 delays. Not a new thing, but yes, how we can reduce these delays. Well, identification of danger signs right at the field level through the training and retraining of our ASHA and ANMs. And then, of course, their timely treatment, referral and treatment at the secondary and tertiary levels as required, and how the best we can take care of those mothers who have been referred to those secondary and tertiary levels and providing them care there. So that is how the health outcomes have improved over the years. There's a very huge reduction in the maternal mortality. We have seen that when that is associated with the with the reduction in the infant and child mortality as well, and there is a great reduction in the unmet need for family planning as well. And of course, the delivery care is now more and more deliveries are being conducted in the institutions, as has been shown earlier also. So an improvement in the in maternal care available at all the different levels, and that has shown up in the reduction of out-of-pocket expenditures as well. And as you can see, a reduction of 43% reduction in the out-of-pocket expenditures over the years. So what are we looking ahead? So institutionalizing the community engagement at all levels. With the different community platforms being in place at right from the community or from the village level, in the urban areas, at the facility level. So all these platforms are there to support the families, to support the community in availing the healthcare services at the primary as well as the secondary level. Of course, if I can say that the medical colleges, they can play a very important role in providing the primary healthcare services through the adoption of Ayushman Arogya Mandirs at in their areas, in their field practice areas. If all medical colleges can adopt up to 10 Ayushman Arogya Mandirs, their students they can provide along with the family adoption program, they can provide very good services at the grassroots level, and the referral of the pregnant women to the secondary and tertiary level would become much more effective and much more easier, and we would definitely be able to reduce the maternal mortality and child mortality in a big way in the times to come. So with that, building a healthier future for mothers through the comprehensive primary healthcare is the need of the hour, and we need to work on that. Thank you very much.
Thank you, Dr. GB Singh, for a very excellent presentation. And CPHC has been really close to, all our hearts. And here I'm reminded of a film. I don't know how many of you have seen that film. Why Did Mrs. X Die? Please, if you have not seen, it's a 2 minutes film. Please go and watch it on your YouTubes, because whenever we teach maternal mortality, it is very important that there are many factors beyond, which are beyond our control. And you really put a continuum of care when you talked about comprehensive primary health care, because we do not have a strict referral system. Whosoever goes where must be able to receive all components of primary health care. That is very, very important. And we have come out, with over a period of time with Ayushman Arogya Mandirs going from, 2 only actions to 12 task forces, and all that part is important, and where we are focusing right from, and Professor Kotwal had mentioned about continuum of care. And for the first time, ICMR, approved projects worth, I think, few crores, which were talking of preconceptional care. And we reached on to the tribal population as well, because tribal norms are little different. So that part also we need to keep into account. But most important part, Professor Kochal, I'd like to stress over here is, we always talk about medical colleges, but whether they're actually doing the work is very, very important. So we need to design that. So thank you.
And that's why then arm adoption, which Dr. JB also mentioned in the second last slide. So we can have a discussion further with all the medical colleges. How wherever you are adopting the families, the nearby arm can be adopted by the medical colleges. And that will give you a lot of, the field practice area also to all the students, and also for the faculty to go there, and also innovate and all. So coming to that, next talk is on innovations for addressing the maternal mortality, maternal health. Dr. Ranjan Chaudhary is Air Commodore Ranjan Chaudhary, served in the armed forces as a doctor, and with various appointments, including commanding large hospitals also. And he is advisor in healthcare technology since last 4.5+ years. We joined together I joined in March 21, he joined in May 2021. And we'll be talking about innovations in not only digital, also diagnostics, and also the quality. Instead of quality and patient safety division, which we have in NHRC, which manages the endpoints. So I request Dr. Ranjan also to put some light on the quality aspects also. Over to you, Dr.
Okay. Thank you, sir. Good afternoon, respected chair and the learned audience. It gives me great pleasure to be among you and share my, thoughts on this subject. As you all know, innovations are very, very important. And India's ranking is constantly going up. We are now 38th in the Global Innovation Index. And we don't have a dearth of brains, young minds, and startups and coming up. So you must be wondering, how does the government, seek good innovations? So there is an institutional mechanism, and how we do it, I'm going to explain in our slides and shows few. There are plenty, but few of the good innovations which are related to safe maternal, care and its improved health outcomes in this result. So you all know that maternal health issues remain a very critical challenge worldwide. And this integration of digital health technologies in the form of remote monitoring to telehealth consultations. This can bridge the gaps in care, enhance patient engagement, and provide timely interventions. Technology like telemedicine, which we saw post-COVID, during the COVID also, we maintained and we understood the advantage of having a system like e-Sanjeevani telemedicine, where CHO, community health, officer at the Ayushman Arogya Mandir can consult a medical officer in the PSC, even a specialist, and the medical officer at the PSC also can have specialist consultation. So this has directly contributed to a reduction of out-of-pocket expenditure, saving a patient to go there, stand in a queue, and all that. Now, it is a debatable thing how effective, but if we do a survey and find out, you find that many cases which would have spent 2 days coming in a issue like AIMS, and if you have a teleconsultation and get it solved at your home, nothing like it. So technology is an enabler. I firmly believe that. And now with the AIs coming into it, and you have predictive models also. So the communication between the caregivers has improved tremendously. So you are aware that ABDM, Ayushman Bharat Digital Mission, this is maintaining, and it's 4 bedrocks to have a digital health record of everybody. Like we have a UPI system, to Unified Health Initiative UHI, with a consent manager, the medical records, once it's done ABDM compliant with the ABHA unique ID, it can be exchanged, and the doctors can come to know at any place and know your past details and record. You don't have to carry bulky files with you, right? Now, this has been talked about, and 86% decline in the maternal mortality ratio, similarly in the infant and neonatal under 5. So India is progressing well as far as the SRS 21213. So there are initiatives and programs many of the slides also, and we in our BSK also, we are doing a screening programs for detecting the 4Ds, defects at these development delays. So in the DIC, every district hospital has got a district early intervention cell, and they're a beautiful setup, and we try to catch as young as possible. Now, these are all possible with improved diagnostics, innovative diagnostics. I'll discuss about that. So these are the program objectives, which is known to everybody, to reduce the maternal and perinatal infant and child mortality and all, early diagnosis and treatment, and promote healthy birth outcomes, ensure physical and mental development of the child, promoting reproductive health and safe motherhood, and prevent malnutrition. So as you are aware, the National Health Policy, in that it's mentioned that health technology assessment is required to ensure that technology choice is participatory and is guided by considerations of scientific evidence, safety, consideration on cost effectiveness, and social values. So this evidence-based decision making, which is called as HTA only, has made a lot of difference. This is the process of identifying, appraising, and using the best available research evidence alongside the practitioner expertise and community preferences to inform the decisions about program, policies, or practices in the health sector. So its ultimate end objective is to formulate a safe and effective health policy for that are user friendly, focused, community focused, and seek to achieve the best value of the money. So a very cost effective solution for improved health outcomes. So this I need not say, as you are aware, the ICMR, Department of Health Research, DHR, they conduct the HTA studies, and based on their HTA studies, the policy adoption takes place in the Ministry of Health and Family Welfare. So a few of the examples like maternal and child health Janani Suraksha Yojana, and this was done after the HTA, evidence driven conditional cash transfer DBT. This has improved a lot, getting all the women as for the institutional deliveries. Similarly, you see the digital platforms of EWIN and the UWIN, the food fortification, but there are many. I've just cited few. Latest is the National Sickle Cell Anemia Mission, where the HTA has done tremendous, has brought down the cost of these rapid detection kits. This is one more digital intervention which I saw in the on the ground while visiting the CRM and all. Techo Plus, you must be aware, for the Gujarat, UP has taken it as eKavach. So there's a mobile health program, and this has enabled the ASHA workers, the ANMs, and all tracking the all the ladies with the coverage of full antenatal care, whether they're going for the 4 or 5 visits, consumption of iron folic acid tablets, early initiation of breastfeeding, home visits, everything it tracks. And this, after implementing on ground these type of digital intervention, they found there is a jump in the coverage. Routine maternal health indicators, measure of data accuracy improved from 69 to 80.5%. It's quite a bit. Similarly, the child health indicators improved from 86.6% to 92.1%. So this, after the HTA was done, it was felt that this intervention is a very cost effective and good intervention, and states have adopted it. UP, I said, like Gujarat, and there are another 1 or 2 states. So the HTA has proved, again, few example, like for the POCT technology for the sickle cell disease. Earlier, when the National Sickle Cell Elimination Mission started, it was 300 rupees per kit. Now the cost has come down to 28 rupees per test kit. See the impact of HTA when you do a cost effectiveness study and you make some cost thresholds. Similarly, for the hemoglobin devices, measurement devices, True HB and the another one, we have found that a POCT device in the field may not be very, very accurate and reliable, but yes, and a good indicator for assessing the anemia. And we are working on it because to get an ideal hemoglobinometer is also difficult, like to get an ideal glucometer. But yes, there are ways and means. It is a screening device. It can't be very accurate, but yes, near about you can screen and get to it. These are the few healthcare innovations in the pipeline which we are going to process. For this Niramay thermal latex, there's iBreast, this for the breast cancer screening, Cerebro. This is a very fantastic innovation where you can have for the stroke program, any bleed, cerebral bleed, it can detect, a very portable device. You have the portable ECG recording system, tele-reporting of the ECGs are happening in the country. 8 states have adopted this. AI-based X-ray handheld devices have been used extensively in the TB Mukt Abhiyan, TB Mukt Bharat Abhiyan campaign, and with wonderful results. Then AI-based modules in the fixed X-ray have enhanced the image, and we could detect some more, diagnose some more conditions. We're using this AI. Newborn respiratory cares. So it's every field we have innovations. So this one example, like the sea bubble PAP, which has been adopted by Assam state and then Jharkhand, it is a battery operated portable device and self-contained unit with external oxygen, can be used for transporting this critical sick neonates, preterm babies and all. Till now, there was a problem in transporting them in a, you have to have an advanced neonatal care ambulance and then, but this is a self-contained module which, multiple therapy you can provide. So it's a very good, and we are working and trying to adopt it in large scale. Similarly, the inborn metabolic disorders, Victor, you have device where you can detect at least out of the 12, which are recommended for the screening, 6 or 7 diseases you can easily recommend using these. Similarly, about the intracranial bleed, which I mentioned, this is going to be a very, very useful tool and innovative tool for the stroke program. So what do we do and the steps? So first we do in the HTA is define the policy question. We frame a protocol, systematic review of all the available evidence. Then we do some mathematical modeling and evaluation, and then we do then analysis known to all our research scientists here. So what we do is basically to find out the clinical efficacy and the cost effectiveness. These two are the important domain which we do through HTA. Now, you must have heard about the Niti Aayog and ICMR initiative. They have got a MedTech Mitra platform as an IT platform where all stakeholders are helping the innovation right from the TRL, from the proof of concept to the maturing stage. So there is a BIS also, AMITS, and everything is there in this. And the NHSRC is coming here at the last stage when we get a mature technology like TRL 8 and 9. And then we want to do field trial and for the adoption. So we got a National Health Innovation Portal and we invite the best practices and the health product in it. And every year there is a exercise where we shortlist these innovations and we put up to the technical appraisal committee at the ministry and we deliberate on which all innovations to be taken. The criteria is simple. It should be new, substantial benefit, and demonstrable and distinctive condition. It should fulfill these three criteria, then only it will be accepted in that portal. So this TAC is chaired by the Joint Secretary, and ED-NHS-RC is the co-chair, and I am the member secretary, and we invite all the experts from all various fields, as you have seen here. So the convergence is required. There are many innovations like this in the Office of Principal Scientific Advisor. They have innovation, some other innovation. So from anywhere the innovations come, they are converging here in the National Health Innovation Portal. We submit it to the Technical Appraisal Committee. There is the committee shortlist the important innovations which can make an effect on the healthcare settings. Then we do a pilot study for field user trial, and then with the HTA report plus the field trial report, we put it up again to the TAC for final approval and then adoption. So I'll not discuss on this. Adoption and diffusion is a big subject, and there are barriers because people don't want to adopt it very right. When you say something, until unless there is an extreme demand and a need in the community, like in the COVID times, we had to use something to record our pulse oximeter, oxygen saturation. So the pulse oximeter came, finger pulse oximeter, and it's now so popular. So the need dictates adoption. And adoption, it says, as the Rogers curve also says, the innovators, there you have to spend your time and energy and the fund. Then only you will get good innovations. Just canvassing it to the mass will not give you the desired results. So these are the factors like TRL funding and all, which are important for the adoption and diffusion. But this model here, what we do is after the field validation, we try to tell the innovators, put it up in the government e-market, GEM. So if it is available in the GEM, it will be a rate parity as well as available to all the states. So this is very important. Second, we conduct the state program, National Summit on Good and Replicable Practices annual, and there it is showcased. And a DO letter from JSP also goes, and as well as the state can ask this through their program implementation plan every year for any innovation which they want to pilot. That's all from my side. Thank you for the patient hearing. Thank you.
Thank you, Dr. Ranjan, for giving an overview of the innovations also. Great, not only for maternal, but for the entire health systems. So house is open. Any questions, any comments, any concerns, any additions to whatever the speakers have said?
At least time is over. We can take 2 questions at least if they're there.
Question to the last presenter. So when any innovation goes into the HTA cycle, is there a need for already regulatory approvals which are available with that innovation for it to enter the cycle, or that is something that should happen at the end? And my question is for a particular experience that I'm engaged in right now with an innovative product for newborn health, where we are required to actually showcase what regulatory approvals the product already has.
Sir, thank you for the question. Yes, regulatory, you must have seen in the MedTech Mitra, that pipeline, they are very important. They come at TRL 5 or 7, where the CDSO has to give you a manufacturing license or a marketing license. Now, what we are talking is after you get manufacturing and marketing, we have to get a field study report. That means the innovation, whether it's giving the desired yield or not, or reports, that comes from the post-market surveillance data, which is little weak in this country. The periodic safety updates as well as post-surveillance, this we are not getting, neither the CDSO gets it. So what we have devised to for adoption, that's why that lag is there. We want to do a field pilot again, because HTA also does with a sample population size and all. But then until unless you know about the acceptability, I'll give an example like a glass which can capture images. Heavy glass was given to us for doing a user trial. We tried it in 2 states, Meghalaya and Mysore. So there the ANMs and Ashas, they rejected. They said, "नहीं sir, ये सर दर्द होता है, हम तो इतनी भारी चीज नहीं लेंगे." So the acceptability, whether the desired result is going to compound with our e-Sanjeevani, can it be integrated? There are a lot of issues. Handling. So like AI enabled such a costly, handheld X-ray. Some in PSC, if you give, they will be so afraid to use it कि गिर जाएगा कल टूट जाएगा तो कौन देगा इसका पैसा. So there are so many systematic issues. So CDSO is required license, that is much before that. And once there are, there is a monitoring system like MVPI, the Meteo Vigilance, and if some adverse events come, they are reported there, and the CDSO has the power to recall the item also and cancel the license also. So this is there.
So, एक second. So in this particular situation, CDSCO is asking whether you've got an HTA clearance, and HTA is asking whether you have a marketing license.
No, after the marketing license only it comes for the HTA.
I mean,
Sir.
so there is a little bit of a gray area on this one.
No, the CDSO are much tightening their policies. They have come up online portal and all. There are gaps in it. We agree for that. Yes.
Thank you so much. And I think we close the session with, after these three wonderful presentations, one was basically talking about the exemplar study. And what we learned was whether it was a state with high mortality or low mortality. Over a period of time, the need of the hour is that we are progressive, we focus on standards, we focus on quality, and the maternal mortality declines from our learning experiences. That is important part. So system learning and system strengthening is the need of the hour. The second presentation focused on comprehensive primary healthcare, and no doubt that over a period of time, we don't have to look only at maternal and child, but besides this, there are so many factors which are associated with that. So we need to look at that part. And health technology assessment, we have already discussed in depth. But then again, there are some challenging questions, and which, before the product comes to the market, because one, we are already looking at role of AI in detection of cancers. So primarily, we have to see that what is available and where it is available, whether we are talking of pap smears, whether we are talking of liquid-based cytology. So ultimately, software is to be according to that. And we have to see that how, necessary approvals are there in time. Thank you so much. And very, very interesting presentations. As far as I'm concerned, I really enjoyed the session.
Thank you. So just 30 seconds more. I must again thank the organizers, Umesh Kapil sir and the entire team for giving this opportunity. I must mention here, I am here because the current ED and HSRC who joined in the month of October asked me to continue with this, me being chair of the session. Otherwise, she was supposed to be here for the chairing the session. I must thank all the three advisors, my ex-colleagues, for these presentations. Just to end that, maternal health is not only about saving lives, it's about affirming dignity, equity, and the right of every woman to thrive before, during, and beyond motherhood. Let us build systems that make that right and a lived reality everywhere and for everyone. But I would like to end not only on this, I would like to say that now we have reached a time where we don't talk only about maternal health, we talk of woman health. And that's what the entire life cycle approach, which we have been talking about it since ages. We need to look at that. If we really need to reduce the maternal mortality further, because the entire life cycle approach has to be given, then only we'll see better results. Thank you very much for all for patient listening, and thank you for the speakers for this, and must thank my co-chair also. Thank you.
Thank you so much for a very, very interesting and informative session. And another session, next session is also going to be equally interesting. It is on the future need for vaccine development in our country, maybe in the next 20, 30 years, what type of new vaccine we require. And for this session, we have Dr. Sridhar. He is the Vice President Research and Development in Indian Immunological Limited. And sir has more than 30 years of experience working with vaccine and biologics. Earlier, he had been the Vice President of Laurus Bio, and also he served as a head of department in biological at Lupin Limited. So over to you, sir, for your experience and what are the future requirement of vaccine in our country. Thank you.
Good afternoon. It's very difficult session for me, like post lunch. Already we had 1 hour session. And thank you very much for the nice introduction. Probably this is very much in a commercial kind of presentation, what I'm going to present than any data driven. I represent Indian Immunologicals Limited. We are a One Health company. Okay. In this current presentation, we would like to present on the future needs of the vaccine development in the next 20 years. So we have a very generic version of this presentation because there is no more data will be available for the future. So whatever I have, I'm just compiling and presenting here. The outline here, like, this is a background we have for the vaccine and the vision what we have for this next 20 years, the key objectives, the technologies currently is present and what are going to be the newer technologies and the manufacturing capabilities also. And I want to talk about the take home message. As you know that, like now, vaccinology is basically one of the very important aspect of One Health. Basically, it's not only human as well as the other living beings on the earth, Mother Earth. Okay, so currently you have a very evolved and advanced system is present in the globe, and we have very big market for the vaccines, both for human as well as veterinary vaccines. I have here almost like 450 to 500 $1 billion market, and also with annual growth rate of 7 to 8% CAGR for human as well as 6 to 8% for the veterinary. And combinedly, it's growing very well. And what we are looking for that we must invest in the speed, platform, flexibility, thermostability, and One Health integration. This is very, very important for all of us after the post-COVID. And also this should be the data driven so that everybody can access it. So here, as part of this particular forum, like now, what is our vision for the in terms of the vaccines for the next 20 years? Like it should be a responsive, globally connected vaccine ecosystem, and AI driven, because AI is the one which is playing major role in the current in science. Okay. Sustainable and decentralized manufacturing so that it is available for all, and affordable access for all population, all types of countries. With that, I'm going to the next point is like now key objectives what we should have for the next 20 years of the vaccinology and vaccine development. So we have to identify future priorities in vaccine research so that in the next coming 2 decades it is available for the coming generations. Okay, and we have to have a good forecast for the coming diseases which are emerging, and also we have to have technologies and which can deliver these products for the community. And we should also have a good recommendation policies and partnerships so that it's all available for the community. If you look at the current platforms, what we have, more than 150 vaccines are currently available in the market, and also many of them are like currently on the classic platform, and also there are many new generation platforms. If you look at these current technologies, we have like inactivated vaccine, live attenuated vaccine, recombinant proteins, bacterial vaccines, synthetic peptides, RNA, DNA, viral vector, as well as viral-like particles. These are all some of those vaccines we consider as a classic platforms, as well as some of them are coming at as a next generation vaccines. What's happening in development of vaccinology? Like, there is there is a big shift in that's called as a new generation vaccinology is coming up. So majorly the center point of is basically mRNA and the next generation platforms. Like, this is the one area where a lot of research is happening. Here, if you look at it, this what with the focus is like broadly protective vaccine, because there are multiple serotypes, or there are a lot of genotypes available for each type of disease occurring. So we have to have broad protection, and also it should be like coming with various technology and platforms like DNA and RNA viral vectors, and also the design of the vaccines needs to be something like AI driven, which is a currently progressing technology parallel to the science. And the combined vaccines, which basically covers more than one disease. And the mucosal vaccines, there are more, other than systemic, there are other ways we can try with, that is called a mucosal vaccine. And also kind of delivery systems, nanoparticles, and mosaic vaccines. Some of these things are basically advancing in next generation vaccinology. So what happens here is the key challenges for this platform technology is basically the stability as well as the scalability of these vaccines. Because whenever the new technology comes, the evolving of the industry also very important parallel to the knowledge and the science. So current the landscape, what we have in the vaccinology, and there are few gaps have been identified. These gaps are something like the achieving sterilizing immunity, means the immunity doesn't last long, and also rapid pandemic response. If you have a vaccine, it should give immunity as quickly as possible so that this can sustain. Limitations including slow development, like any science, like in vaccinology also takes a lot of time, like sometimes 3 to 5 years, sometimes even more than that. So it should be short. And also when the technology is available, it should be readily available to the people. So you should have a platform technology for the scale up, like manufacturing. And yes, some people they're sometimes having a hesitancy of taking, and we have to think about the public perception. And that is basically creating awareness for the people. And sustainability, environmental impact, and also animal welfare, biosecurity, and regulatory compliances around with this. Certainly that stakeholders' expectations needs to be also met. So some of these gaps are there. And when you look at the particular picture, it looks like very complicated. So what is basically what drives, like drivers basically for the different type of vaccine? It's all depends upon the interactions between humans, animals, natural environment, and also the built environment and microbes. And at the end, it's wildlife and global biodiversity. How these are all interacting, based on that, the diseases will be evolving. And according to those interactions, the specific diseases will be coming up. And we have to have a focus on that particular type of diseases that can be genetic. So that what are the strategic drivers? What I was talking in the previous picture, the genetic risk and One Health imperative, like the diseases which are genetic, that needs to be basically looked at a holistic way, like both humans and animals and environment. All these three together only we have to have a strategy, and also the growing economy, growing social mobility, as well as the globalization and climate change, also having a lot of dependency on the human health as well as animal health. So we have to have a proper understanding on the outbreaks and infectious diseases. Okay, and food security and the livestock and animal welfare, like the previous slide I was presenting. So in this context, like what are the diseases that basically are coming up fresh? Like recently we had this COVID pandemic, like that we have. There are certain diseases. There are like pandemic-prone diseases like influenza, coronavirus, kind of variants. They're all very much like now under control. Like also genetic vector-borne diseases like a dengue, Nipah, KFDV, which we are working currently on RVF, and AMR pathogen-based diseases, that is basically human lifestyle-based diseases, and the non-infectious targeting like cancer and autoimmune disease and allergies and vaccines. All these are all the areas where vaccinology should grow. So how we can design? So then the next presentation, which I just wanted to understand and tell the disease when it is coming, and I have to have a kind of a tool to design. So for that, so sorry for this. This slide is a little busy, and I have a lot of text here. So AI driven, basically the antigen, if you know, then you can design an it's kind of a vaccine for this particular disease. So for that purpose, we have to have a tool which is basically AI driven tool, which is like, we have multiple platforms like, antigen as well as the epitope mapping and the formulations. In fact, that also plays a major role for the presentation of antigen for the system. And also the new coming up technology, certainly like mRNA and predictive toxicology studies. When you develop a vaccine, toxicology plays a major role, whether this product is basically having any effects on the immune system or it is getting into the human body. So many of these things are kind of an integrated, like, clinical trials, which basically reflects on the product quality. And then that once you complete the clinical trials, you will exactly know that whether this product is efficacious. So for that purpose, you can also use the AI model to generate a model and do and study the efficacy of the product. Some of those, once you completed, then we can also have the data analysis. For that, we have a lot of advanced statistical designs and models and softwares are there. And also, you can design futuristic models in case if you have a longer, clinical trials are that can be shortened by doing a proper designing. So there is another way of looking at addressing new and persistent threats. Like, when you have any pandemic, like response needs to be very rapid and quick. So for that, we should have a proper technology platform should be available for something like AMR, pandemic and neglected diseases, where you can see that we have to identify the threats and I'll shorten the life cycle for the development, and we have to do the bridging the gaps between the science and regulators. So one of that example I'm just telling that in the recently what we have done, usually whenever you do the vaccine development, usually it undergoes several tests as such, preclinical and clinical development. In that, it's basically going to take it not less than 5 to 7 years. But if you have a parallel study plans and proper design, we can cut short the clinical development cycle. This is one of the example like recent past what we have had it during the COVID. When you have a vaccine developed, also you have to have like the delivery system. Once the vaccine is efficacious, but still we have to have like a lot of applications. It goes to various population like child, mother, and also the old people. So at various stages, the requirement will be different, and also we should have a proper delivery systems. For child, one type of delivery system. For adult, there should be different delivery system, and also presenting the antigen is also plays a major role. So for that, like we should have a kind of thermostable and needle-free vaccines for child, and also for the very good logistics purpose. And mucosal and oral, like if there are certain diseases like which are airborne based or like respiratory based, in such kind of things, mucosal plays a major role. It will give a better protection. Multivalent and combination vaccines, this also plays a major role. If you have multiple antigens, you can do a good formulation and you can present it one time, so that number of visits for the hospital or doctor will be limited, and also you can have economy control on that. And smart packers and cold chain innovations, like a lot of people when they take the vaccine vial, they need to know whether it is expired or not, whether it can be stored or not, it can be taken it further when it is a single dose to multiple dose. So such an platforms also need to be evolved in the coming years. So when I was talking about the delivery systems like the formulations, there are many challenges are there, like oral, nasal, microneedle, and combination vaccines. So the acceptance and logistics plays a major role in this kind of vaccinology. And one of the example what I'm giving here is a oral delivery system. We have for the nanoparticle, for the live attenuated, the delivery system is nanoparticle. And for the recombinant vaccines, the liposomal is the one delivery system. And virus-like particles, again, you can have it like subunit peptide vaccines and the carbohydrate vaccine, particularly pneumococcal. and adenoviral based vector vaccines. So there are different kind of platforms available for the different type of delivery systems. One of that is a oral delivery system. When it comes to the microneedle patch technology, if you look at this kind of all the population cannot have the needle. Like sometimes if you have an alternative way of doing the vaccine delivery, so one of the most advanced and evolving technology, microarray patch technology, wherein you can have intramuscular, subcutaneous, intradermal, and microneedle based patch based technology, where this technology is basically indirectly delivers the antigen of interest to the system. And in the current research, there are a lot of kind of formulations and platform technologies already has been evolved. So this is going to play a major role in the coming years. When you look at that primary vaccination, and when the kid come out of hospital, and it should have a plan one time vaccination is a better, you can have a combination of multiple vaccines. In that we have various kind of aspects that we can look at it, the adjuvant toolbox and the system vaccinology, which are the vaccines to be given to the child, and the reverse vaccinology, look at what can be the right time and when can it be delivered, and also immunoengineering and delivery systems, those can be looked at. Apart of this, in the vaccinology, we have various other aspects, when you develop a vaccine, it's also the body or the system which plays a major role. So if you engineer the body itself, so it will help the system to identify or to get the immunization, got the memory of the particular against the vaccine. So it will be better by doing the engineering your own cells or doing some kind of modification in some of the cells so that we can have a better immune system, immune response from the both humans as well as vaccine, humans as well as the animals. So for that purpose, there are different new concepts are coming and evolving. Some of them are dendritic cell based maturation. That is basically what we call it as genetic vaccine adjuvants. Modifying the system or the vaccine can lead to better immune response. So now looking at the kind of clinical development requirement of the vaccine, there are several stages that we need to meet, preclinical and clinical in entire product developmental cycle. So we have to have several animal models, both small and large animals, also humans, both men and women, children, and as well as adult. So for that purpose, we use a lot of subjects. To avoid that, there are different areas, you can have a kind of ex vivo translational models to bring the clinical trials in a different platform and complete the kind of clinical trials, which is basically called as a ex vivo or translational models. This is very much catching up technology. You can have a lot of cell and 3D cell culture based models in this. They are almost similar to the humans, but they are basically representing as a laboratory model. So once you have the product or the vaccine is developed, the proof of concept is established and clinical trials are happening, are completed, and the product is efficacious, then the next thing is how to have this vaccine in the market. Then you have to have a very good manufacturing setup so that whatever the proof of concept is there, that needs to be translated into the large volumes, and also it should be accessible to the individuals. For that purpose, we have to have a lot of things in place. So that needs to be evolved. Distribution, basically, we should have multiple units of bioreactors or manufacturing setups. So there are two ways of this. One is the scale up, otherwise scale out. So the scale up is the thing in a massive way, in a single unit, we can produce the vaccine in the large volumes. Otherwise, without changing the scale, we can make or triplicate the same volume in multiple locations. So there are two ways of looking at it. Some of them are scale-up models, some of them are scale-out models. We have the right kind of model to make the vaccine. Sometimes the cost of goods are not like small, low value, high volume products basically can be taken further in the large scale manufacturing. And then there is a high value, low volume products that can be taken as a kind of scale down model or a scale out model. And also you should have GMP facilities, there are a lot of regulatory requirements if you want to do your manufacturing. For that, GMP plays a major role to get a right kind of license for the making the right kind of suitable high quality product. And nowadays, traceability plays a major role. So people now moving on to the manual mode to the digital mode. So it's really makes very easy for the data mining and traceability. So if you have digital traceability systems, documentation should be manual to and kind of instead of paper based, you can go to the electronic base. And also, if you have more and more demand is there, you have to have more supply, and based on the demand, the supply needs to be grown. So we have to have a lot of public and private partnership for equitable distribution for the vaccine. Whenever we are talking about any vaccine, basically based on the geography and the socio-economical aspects of the country or the region, or the equity access and the local manufacturing, the transportation of the vaccine from one place to one place, they sometimes far location, the transportation may not be kind of feasible. So we have to have the manufacturing centers at the location where they in location means in geography. So for that purpose, we should have investment in place so that manufacturing will happen in the same location. If something is happening in the US, they should come to Asia. If something is happening Europe, it should come to say Africa. So like that, there is a people understanding about the equity and investment in their location, so that vaccine can be available in those geographies. So here we need to have total financing as well as a workforce and regulations. People need to understand exactly what is the regulation, and also trained people availability in that location. So since this any vaccine, any human medicine, it's very important that we have to follow policy and regulation, and the regulation needs to be very user friendly, adaptive and accelerated regulatory pathways. People needs, the entrepreneurs, when they want to do a business in vaccinology, they should know very clear pathway for developing a molecule. So for that, you should have an adaptive and accelerated regulatory pathways, and it should be always a data driven safety monitoring. The product, when it has been reached to the individual, that needs to have all the traceability of the product, and global alignment and knowledge sharing. Advanced country, if they does something, it should be reachable to the developing countries. So they should have an alignment, networking should be there, and investment in human capital and infrastructure. So as such, this needs to be networked and framework, so that the needy location will have the opportunity to have this vaccine or the access to this vaccine. Of course, there are a lot of efforts are taken by Indian government. We in the collaborative landscape is evolving in India. And as such, we have All Indian Institute of AIMS and TSTI and ICMR, DBT, industry partners. All together, they are networking and developing various molecules. And also, similarly, there are a lot of organizations are working for this. And the new model of sharing R&D platforms and open data systems and joint trials. So this basically reduce the kind of delays, and it can reach to the market sooner. So these are the certain things which needs to look at in the coming decades. The public trust and communication, when you look at this particular slide, when the COVID vaccine came, there is a lot of misunderstanding of the technology, whether this vaccine can be taken or not. So we should look at that, how to address this. Like, so there are various ways that we have to address, like, the vaccine misinformation can lead to increased vaccine hesitancy. To avoid that, we have to take certain measures like monitoring the manufacturers, monitoring of the what's called as a misinformation on social network, and connecting with people, and also telling people and educating people about the technology what you have developed. So this is very crucial role when the vaccine is evolved and it has been developed with high quality and safety, that needs to reach the people in right time, so that the vaccine kind of usage can be better. So what is the new or future requirements, like in the vaccinology when you develop the vaccine? Like, the vaccine should be available on demand. Okay, whenever there is an outbreak is there, it should be available. Then universal immunization, and like we should have, of course, there are a lot of immunization policies as well as strategies are there. So we need to have more network on the immunization, integration of precision. I mean, animal, both the human and animal and health needs to be looked at genomic level, and global collaboration networking. Some of these things are very, very important for the future generation. So with this, I just want to wrap up. So in conclusion, the vaccine development landscape by 2045 will be characterized by an agile and technology-driven, innovative, integrated with adaptable global manufacturing and distribution. Okay, balancing speed, safety, sustainability, and public trust is very important. And we should have a strategic forecast in the upcoming vaccine development. Okay. So what is that, like, impact us, like in our country or people or community or the government? Like, they have to strengthen pandemic preparedness. So wherever the investment is required, whatever the system needs to be understood, and what is the investment to be taken in that particular area, and the vaccine to avoid any kind of delay in the pandemic time, the vaccine availability. So you should have a faster vaccine turnout, like, and greater equality in access and affordability. Like, every person on the globe should be able to get the vaccine, and also it should be affordable. And India is a global hub for the next generation vaccine innovation. Just like in my previous session, like, now somebody told that now India is growing. Now earlier the number is the top 100. Now in the top 50. Now we are 34 in the rank in the development index. Okay. So at the end, I just want to say, like, the vaccine of tomorrow will be data-driven, rapidly adaptable, and globally inclusive. Okay, invest today to protect the next generation. By saying this, I just wanted to conclude my presentation. Thank you for your attention.
Can we take some questions?
Sure, sure.
Thank you, Dr. Sridhar, for telling us the various steps for new vaccine development, and also the challenges and difficulty which we have. We have some time for questions. If we have one or two remarks or question, you're welcome. Please.
Thank you, Dr. Sridhar.
Thank you, ma'am.
I think I have got very important observations sitting in CDSO for all your vaccine trials. Number one is that we all talk of faster vaccine development. Now we are 146 crore people, right? And how, vaccine companies want to develop vaccine faster, they'll say we have tested on 40,000 individuals in America or in Africa, but we will want to test only on 2,000 individuals in India. Vaccine companies have to realize India is very big. We are east, west, north, south, northeast, right? So that is one thing which is very important. And second part is that at all stages, we have to be concerned about safety and efficacy of the vaccine. That is important. Another thing is that when you start going for manufacturing of the vaccine, conveniently मेरे को अच्छा लगेगा कि दिल्ली में मैं 5 साइट चूज कर लूं और मैं कर दूं. मैं बैंगलोर जाती हूँ 5 साइट चूज कर लेती हूँ, वहां पे कर लेती. This is not the way to do. So I think quality should not be compromised while we are making the vaccines. It has got to be adequately representative, and all stages, safety and efficacy has got to be point of concern. Another thing is that suppose Dr. Umesh Kapil is the senior most person organizing our conference. He is also very senior most in terms of his experience, but he has no time, right? He will say, okay, I'll take this vaccine site for manufacturing, but knowing Dr. Umesh Kapil, he will deploy many people, but he will monitor them also, which I have seen in last 2 months. He will monitor them also. But people will take sites, but people will not monitor them. I will tell you a recent example of one of the vaccines, which was talking about RSV vaccine. They were following that for 2 years. Okay. They said that there are no adverse effects. Then जब हम देखते हैं तो इसको डॉक्सीसाइक्लिन भी मिला है, इसको ये भी मिला है, इसको वो भी मिला है. मैंने कहा ये कैसे हुआ? आप तो लिख रहे हो कोई एडवर्स इफेक्ट हुआ ही नहीं, तो ये कहाँ से आया? तो कहते मैडम वो तो उन्होंने प्राइवेट सेक्टर से लगवा लिया होगा. मैंने कहा इसका मतलब ये आपके इसमें आया ही नहीं. दिस इज पार्ट ऑफ योर ट्रायल. So that is where we have to see how efficient your PI may be, but is he or she able to do the job or not? That is very important. So these are some of the important concerns when I observe, and vaccine companies will say कि मैम ये हमारा अप्रूव नहीं हुआ, ये नहीं हुआ, वो नहीं हुआ. It's not that people are against that, but people have to see that whatever we get is a quality vaccine, which is really representative of our country, because we are not small. Thank you.
Thank you so much, ma'am. I think I need not to answer any question. You gave me the entire explanation. But one thing I want to say that we have to grow together, whether the company or the regulators. So whatever we do, if you wanted to have a better quality product, we have to invest during the research. And the most of the like we said question explanation what you are given. The first part is how to make a vaccine quickly. It all depends upon how do you design your clinical trial. Okay, during the COVID, there are multiple vaccines who were here in the market, but many of them have done parallel trials. When you are doing the parallel trials, there is of course risk is there, but that risk is going to help in saving a lot of lives in the society. So that is first part. Second thing is people, company as well as the systems are accountable for anything. Of course, any company, they are launching a product, they are very much concerned about the quality. Without a good quality, they will never sustain. So it is always like an industry partner will always give 100% priority on the quality, efficacy, and also at the same time I wanted to tell you to sustain you have to come with good quality products. So I mean to say that we always go hand in hand with the regulators. There is no shortcut for the regulation. So we always consider regulation is the high priority for us.
Excellent presentation, sir.
Thank you, sir.
Thank you very much for your support. And we really enjoyed your presentation.
Thank you, sir.
Madam has a lot of experience and expertise. You can discuss with her
Certainly.
over a cup of tea. Thank
Sure,
you.
ma'am. Thank you, sir.
Thank you, sir. Thank you so much.
Okay, the next session again is very interesting. Public health strategies for maternal risk management in RH negative mothers. And for that, we have our eminent speaker, Mr. Nitin Nagarkar. Mr. Nagarkar is president in Bharat Serum and Vaccine Limited. He has more than 25 years of experience in public health. And out of this, for the last 15 years, he is extensively working on anemia, especially among the women. And he was involved in the development of guidelines for Anemia Mukt Bharat, and also in the implementation in several states. Nitin, to please come and share his experiences.
A very good afternoon, rather good evening to all of you. Thank you for all the ones who have been able to make up and be there with your august presence for the session. Thank you, Dr. Umesh Kapil, for giving us an opportunity to share our thoughts on public health. And Congratulations to entire EFICON team for making this as a fantastic event and a very successful EFICON 2025. So with this, I represent actually BSV Mankind Group. We at Bharat Serums and Vaccines, as the name Bharat is there in that. So we are very passionate about the causes and in the value addition what we can make to the healthcare development of the country, right? So the topic will be awareness to actions. There are a number of initiatives which we as a responsible player are undertaking to ensure what best we can do to contribute to the cause of public health. So, BSV has a legacy of more than 50 years, and in these years, gradually we have seen that there is so much of progression which has happened in maternal health. So when we talk of simple basic ratios like MMR, which was at one point of time was 140, 150, has now come down to less than 100. And that is where is the SDG goal of achieving, 70 by 2030. And same is the case of the neonatal mortality, where it was somewhere around 50 and now we have reached 25, right? So a fantastic work done by all the stakeholders. I know it's a long journey, we have a long way to go, but we can definitely say that India is committed to the UN target of achieving SDG. And I'm sure that with all the stakeholders, whether it is the public policy administrators or whether it is the corporates, or whether it is the NGOs and all of us who are actually playing a role come together, then it can be a good collaborative effort to achieve this important sustainable development goals by the GOI. We already have, some of the high risk areas which the government has identified and listed, right, in their various guidelines. And I would like to just focus upon the last one, which is the negative blood group, or we can say the RH negative high risk pregnancies, because we have expertise of years together in RH negative pregnancy management. Just a quick overview of RH negative. So out of around 2 to 2.5 crores institutional deliveries happening in India, we have around 12 lakh RH negative mothers, right? Friends, it's not a disease. It is just a blood group. We all know that, we don't have any control on RH negative or positive, but what is very important is that the blood group that gets identified on time, and especially, it's a preventable cause of RH incompatibility, which should be addressed if the RH negative mother gives, the birth to a RH positive baby, right? We are driving various programs, and in fact, the good part is that ministry is already having focus on this, and we have schemes like GSSK or PMSMA, wherein the RH negative pregnancy management has been highlighted. Now, what does BSV does in RH negative, right? So you may be wondering that we are a corporate player, sort of private company and more interested in business, but I can say that, business comes secondary, but it's a one cause which is very BSV is passionate about and very much dear to us. We are doing number of initiatives to drive policy changes, policy making and advocacies, right? We have done various policy shaping initiatives with states and GOI stakeholders. We had our flagship program called Arogya Shiksha, which I will be just talking about what all we are doing into that. Various Asha Connect programs to do the capacity building to the level of PSC and CSC. And of course, there are a number of social media campaigns or the digital initiatives with the help of celebrities, that whatever the best knowledge or awareness we can create as a responsible player for RH negative management. The good part is that, over the last 3 years, we have been able to generate a lot of awareness, and we have been able to bring changes to almost 10 states straight away by introducing or by facilitating the policy or advocacy guidelines across those states. You can see the list of those states which are there on the right hand side, wherein the states or the respective maternal health team have issued the guideline to the state that first of all the blood grouping is very important, that has to be done without fail. Number two, if the mother is RH negative, then a due importance and sensitivity to be given to those mothers, and they have to be sent to the respective correct center to be dealt with.
So all these states have issued the advisory, including the recent revised CMON guidelines issued by GAAC. Coming to Arogya Shiksha, which is our flagship project we started last year with the pilot being done in the state of Tamil Nadu. This is one thing which we have now further scaled up to 4 or 5, further more states. And there's a clear-cut, difference in the outcome which we have been able to see or visualize out of this project. The project was basically we have acted like a technical partner to the government of Tamil Nadu, wherein we did 2 batches of training, and those master trainers again went to their respective districts and have do a cascade training programs across the 38 districts of Tamil Nadu. Right, the same has been repeated now, as I said, in various other states, and we are very, very sure that with this kind of initiatives, up to the level of PSC and CSC, they would be empowered to know about RH negative and how the RH negative pregnancy is to be treated. Right. In terms of Asha Connects, I can proudly say that we have a team of 54 task force field workers. Right now, their work is to go and reach out to these CSCs and generate awareness on the RH negative factor. Right. Till now, this year from April to October, we have done more than 400 Asha Connects, wherein, like in the photograph, you can see all Ashas and ANMs, they come together and we give them the awareness and the training so that whenever they come across any RH negative mother, they should be able to counsel not just the mother, but also the family involved with her. And they should, enable the mother to take them to the respective CMOG center or the center where RH negative treatment happens, right? So across various states, we have been able to drive these programs and we are getting fantastic response. And we really feel privileged, to be a part of this awareness generation up to CSC and PSCs across the rural areas. This is on the initiative of the celebrity endorsement. I think no one more credible than Mr. Amitabh Bachchan can be there, who has a strong presence and acceptance across the rural as well as urban population. तो आपके बच्चे को सुरक्षित रखना तो अपने से सलाह होगी आने वाले So I think this was one program, one initiative, which his dates were too much blocked. I think for 4 or 5 months. But when he have gone through the script and listened to this course for both zoonotics as well as maternal health, he gave the priority to this, and I'm thankful to the people like him who really are concerned not just about their own stature but also about the healthcare cause in the India. Coming on the plan of action, as we said that awareness is one part, but finally it ends with the action part. So as with the Arogya Shiksha, we have been able to bring some actionables across various states. Similarly, it has helped us in the community empowerment. The various programs, including Asha Connects, have really it has helped us to reach out to those needy mothers who really needed the due care across the ANC and PNC journey, right, for the RH negative. Some of the expectations I would have from the key stakeholders involved in the public health or the government of India is to
enable us to take this cause further to the deeper areas or the bigger heights of Rh negative, and to have a one common, guideline kind of thing, which is a uniform guideline which can be accepted across various states. Because right now the 10 states which I highlighted, everybody has got their own drafts in the guidelines. We want to have a uniformity in the guidelines so that all states follow, the single protocol, which ideally GOI, I would request the stakeholders to drive that. The next cause, and we are really privileged at BSV that the areas or field in which we are operating are the ones, which really makes a lot of difference to the rural healthcare more so, right? So the next one is the rabies prevention, the dog bite prevention. It's good to see that government has recently come out with a revised NAPRE guidelines, and there's too much of work which is done in the areas of rabies management. I think this is the group which is going to really play a lot of role in the rabies management. But one thing I can say is that we have a long way to go, because when we do a lot of programs in rabies, we still realize that the disease, the cause, the event may be very, very old, but the kind of knowledge we still have for rabies, we have a long way to go, right? Um, Rabies is one of the most deadliest disease. We all are aware, we all admit that. But the good part is it is 100% preventable, right? So we need to really drive our resources and energy to those areas which can help us, bring or achieving the NAPRE goal of bringing zero rabies death or dog-mediated rabies death by 2030. And I'm sure that with the kind of effort the concerned stakeholders are doing, we must be able to achieve that goal. Some of the key health initiatives by BSV in the rabies management is on the BARC alert. BARC is our Building Actions on Rabies Knockout program. Now, this is also one program which we started with a pilot in UP with the help of Dr. Pankaj Saxena, who looks after the zoonotics and rabies program. And across the 17 zones, and or you can say across 70 districts of UP, we did a lot of awareness building exercise, and there were a lot of questions which were raised, which really brings us to the understanding or point that there is too much of work to be done in the awareness of rabies management, right? Starting from as simple thing as wound washing, which can be one of the most efficient way to control the rabies, right? These are some of the programs we did across UP, and now again we have scaled it up across states of Gujarat, Chhattisgarh, Tamil Nadu, Rajasthan, right? Number of them who have actually shown the interest to take this awareness initiative to next level. So people from public health, people from the clinicians, from CSC, PSCs, the administrators, everybody was involved in this program. And, we gave a demo also on how to give vaccine, how to give immunoglobulins, which is the bite at Cat 1, Cat 2, Cat 3, where the concerned modalities have to be implemented. These are some of the snapshots which have covered some of the programs. And of course, next comes is our snake bite prevention. Now, this is again the third vertical where we have a very, very strong presence in terms of building the awareness. Now, if you see all the three domains, whether it is Rh negative or rabies or snake bite, one thing which is very, very common is the awareness, right? I think if we are able successfully being able to do the awareness part also up to even 50%, we will really see a lot of visible change in all these three domains. We all know that we have close to 3 million bite cases, and that is something which is on paper, which is reported, but there would be hundreds of thousands of cases which are not even reported, because still in our population there's more than 60% population which believes in going and reaching out to the natural healers or tantrics so-called, but not going to the hospitals, right? So that is one major goal we have as BSV, that we should be able to bring those patients to hospital nearby, treating centers, instead of falling in the hands of natural healers.
We still have more than 50,000 snake bite deaths across the country, and we are both rabies and snake bite. We are one of the biggest contributor to the global, burden of these diseases. We have a very good, beautiful campaign. The name "Saap Ka Waar Aspatal Mein Hi Upchar." I think the campaign itself says it loud and clear that what is the objective of the campaign, right? So we are doing various community empowerment programs, doing a lot of advocacy initiatives. Thanks to NCDC team who have come out with the National Action Plan last year, and with their support, we have been able to have an action plan, state action plan now in Rajasthan as well as Karnataka. Kerala has recently made snakebite notifiable, though the GOI has already made snakebite notifiable, but still, the states have to actually make it so in their respective states. So that is one major area wherein we are working closely with the stakeholders, the nodal officers, to ensure that snakebite is made notifiable across all states.
अस्पताल ले जाने के अलावा आप लोग सब ऐसे ऐसी बातें कर रहे हैं। अस्पताल ले जाने हाँ लेकिन सब तो जब तक हर साल मैं आपको बता दूं 5,000 से ज्यादा लोग अपनी जिंदगी गवा देते हैं। समाधान होते नहीं है, ऐसा मत होने दीजिए, समझे? यार आपका वार अस्पताल नहीं है, 300 रुपए आपसे अस्पताल नहीं जाएंगे।
I think, I'm sure that with these kind of initiatives going up to the various length and breadth of the country, the awareness of Saap Ka Waar Aspatal Mein Hi Upchar, should really make a lot of difference. Now, as far as BSV is concerned, we have done various rural contact programs, with the help of Impact team, and across schools, across healthcare centers, and across the Anganwadi workers, we have executed this program. The program was really, successful and fantastic. We have been able to reach out to almost 5,500 school children for generating awareness on snakebite, right? More than 134 centers and more than 1,000 healthcare workers in the Anganwadi. There have been a lot of work happening in the domain of digital health with the local influencers. So we all know that every district or every state, there are a lot of local influencers, which actually influence the population over there. So we are working closely with them, including people in pesticides, people in farmers, maybe the school teacher who is influencing the population over there, to take this course, because a lot of people over there, local population, they follow them. So we have done various programs or campaigns with the help of these local influencers, and more than 1.7 million views are already being achieved, with this program. I think we just started this thing 4 to 5 months back, and more than 1.7 million views have been achieved. So which really gives us an enlightenment that there are so many people who have actually gone to the channel and have gone through the snakebite, awareness. Again, these were various stakeholder management program, along with the community workers like NCC graduates, like disaster management team, like villagers, the sarpanches, the farm owners, all of them, to generate awareness on the snakebite. We also have partnered with the radio. We are using, all the mediums of digital health, whatever possible. And with the help of radio, we reached out to more than 75 cities across 6 languages. And, basically the jingle was played across the radio network to generate awareness on the snake bite.
सांप के काटने से जो मैं सांप के काटने से 4 साल से अस्पताल में ले जाते सांप का वहां अस्पताल में ही पहुंचा
सरकारी चिकित्सीय सलाह देना है कि क्या किसी भी स्वास्थ्य संबंधी समस्या चिंता या प्रश्न के हो अपने डॉक्टर से सलाह करें भारत सीरप्स एंड वैक्सीन्स लिमिटेड और 9 में लोगों द्वारा जनपद जारी है
Okay, so even in the snake bite, you see that various number of our efforts were being captured, and most of this, snapshot which came in the media actually was not, we were not involved in bringing any media news. So people who were locally being there, reporters and all those people, they actually came to know that something is happening on snake bite, dog bite, and they came and captured that. So that's all with Bharat Serums and Vaccines initiatives and efforts. I don't take any credibility of the work which is happening. The entire work is with the support of the various field warriors which I have in my team who really runs across the rural and urban population and generate the awareness. Thanks to Dr. Apurva from my team. She is handling our public health initiatives, and also Pramod and Akash, who handles the marketing for BSV Public Health, for driving these initiatives and actually, trying to have us one step closer to bringing change to the public health. Thank you so much. If there is any question, I'm pleased to answer.
Dr. Nitin, thank you very much. It was a very informative and a good change for all of us.
Thank you, sir. Thank you.
One thing I request you, this RH negative issue, if you can develop a state-of-art presentation review article, okay, we would like to publish it in Journal of Epidemiology Foundation of India, which is circulated free of cost to all our members of Epidemiology Foundation of India, which are about 7,459 as of now. So please do that. It will be a good service to all the public health experts also.
Sure, sir. Pleasure for us. Yeah. Thank you so much.
Thank you so much, sir. And now we have the last session, but so for that I invite Dr. Madhu Gupta. She is professor at PGI Chandigarh, and she has more than 20 years of experience of working in virology, and she has been actively involved in more than 17 vaccine trial from various for various vaccine, and she's also been on the advisory committee of state and national level on immunization. She is going to talk on epidemiology of pneumococcal diseases and what are the vaccine strategies for that. Over to you, Dr. Madhu, please.
So before I start, I request Dr. Sneela Garg, ma'am, to please be seated and please moderate this session.
Good afternoon, everyone. I think last 3 sessions have been really very interesting, and particularly with the advent of adult immunization. Now we are talking more and more about pneumococcal vaccine, and I'm sure Dr. Madhu is going to make, lot of changes in terms of, bringing out important facts on evolving epidemiology of pneumococcal disease. and dynamic vaccination strategy. Over to you, Dr. Madhu.
Thank you, ma'am. So at the outset, I'm very thankful to Dr. Umesh Kapil sir, Dr. Pradeep Agarwal for inviting me here and giving me this opportunity to present this topic in this August gathering. So the topic is evolving epidemiology of pneumococcal disease and dynamic vaccination strategy. So just a disclaimer, these are all my opinion. So regarding, I would like to start with the community acquired pneumonia and what are the global mortality rates because of this. So everybody knows that the lower respiratory tract infections. So as per the global burden data for the year 2021, this is published, there are approximately 344 million episodes that occur every year globally, and out of that about 2 million deaths occur because of LRTIs. Pneumonia constitutes and pneumonia causes about 2.1 million deaths as per GBD, and estimated incidence is about 1.5 to 14 cases per 1,000 years of observation. And community acquired pneumonia, it leads to about 4 million deaths per year and 7% of the total annual mortality rate. And 50% of cases require inpatient hospitalization. Mortality is about 0.7 per 1,000 persons per year. And most of these infections are bacteremic, that is 35% to 39%, and about 10% episodes are viral in nature. So coming to India, so India is responsible for 23% of global burden of community-acquired pneumonia and 36% of regional burden among under 5. So under 5, we already have a pneumococcal conjugate vaccine 13. Regarding adults, the data is mainly obtained from the tertiary care hospitals. So severe community-acquired pneumonia, there's a study on that. It reached 19% of all patients, and Streptococcus pneumonia is the main organism causing it, followed by Pseudomonas aeruginosa and Klebsiella pneumonia. The reported case fatality are between 14 and 30% in all community-acquired pneumonia patients and 47% in severe community-acquired pneumonia. So, and this is again the data that CAP leads to 4 million cases annually, 20% require hospitalization. 5 to 11 cases per 100 population is the annual incidence, and mortality among the outpatient patients is around 5%, but among the hospitalized patients it is 10%, and more than 30% patients they need ICU care. So if you look at the hospitalization days, so in the private hospitals, the average length of stay is about 9 days as versus 30 in the government hospitals. And general ward stay is 5 days in the private hospital and 8.5 days in the government hospitals. And outpatient requires at least 3 follow-up visits, which includes cost of traveling and their treatment cost for CAP monitoring post-CAP diagnosis. So if you look at the impact of the CAP symptoms on the daily activities, so among the hospitalized patients, fatigue at diagnosis is reported by 73.3% cases. Energy levels at around 3 months is reported by 73.4% patients between moderate to high. For non-hospitalized patients, the fatigue is reported among 63%. They reported it to be mild to severe, and the levels are moderate to high, which is reported by 73.3% patients. And if you look at this data, most of these patients who suffer with community-acquired pneumonia have other morbidities. Diabetes morbidity comorbidity was found in 22.6%. COPD is also 22.6%. Chronic emphysema 9.7%, and asthma 9.7%. Now, we also have certain estimates on the economic burden of community-acquired pneumonia among adult patients in India. In the government hospital, as per this study by Colby et al., it's around 6,000 in the inpatient and 200 in the outpatient.
While in the private setup, it goes to as high as 2 lakhs among the inpatients and around 4,000 in the outpatients. Recently, a very good study is published in BMJ, British Medical Journal of Public Health, resource utilization and cost of hospitalization with community-acquired pneumonia among older adults in India, and data is from 2018 to 2020. Dr. Anand Krishnan is also one of the author in this. And the major findings which this says that mean length of stay was about 6.2 days. 37% required ICU admission. Antibiotics and antivirals were used in 96% and 23% of admissions respectively. And the cost, mean TAP hospitalization cost was $305 in public and about 1210 USD in private hospitals. Substantial resources are used during TAP hospitalization, leading to considerable cost equivalent to 16% to 65% of per capita net national income, depending on public sector versus private sector hospitalization. So this is a very important piece of evidence on economic burden. Now coming to the key pathogens and trends leading to community-acquired pneumonia. So globally, Streptococcus pneumonia is the main causative organism and H. influenzae for acute bacterial pneumonia. And S. pneumonia leads to about 5 lakh deaths globally. And this is the global burden of TAP by pathogen. So Streptococcus pneumonia leading to about 98% episodes, Mycoplasma about 25 million episodes, and other organism about 46 million. There's a recent review by VK. This is a systematic review done among the using the Indian data, which shows that 33% cases of community-acquired pneumonia, it is Streptococcus pneumonia which is responsible for causing the pneumonia, followed by Klebsiella pneumonia in 23% and Staphylococcus aureus in 10% of cases. And this is the GBD paper published in Lancet, which says that out of the 18 pathogens, Streptococcus pneumonia was responsible for highest proportions of lower respiratory tract infection episodes and deaths, with an estimated of about 98 million episodes and 5 lakh deaths. So this, as you compare the burden with other organisms like RSV, influenza, SARS, COVID. So Streptococcus pneumonia is placed second only to SARS-CoV-2 in causing the serious respiratory illness and mortality. So what does it cause? Streptococcus pneumonia causes pneumococcal disease, and the disease has two spectrum, invasive and non-invasive or non-bacteremic. So as you see the lower part of this pyramid, 75% to 91% of pneumonia in adults is non-bacteremic, and majority of pneumococcal pneumonia cases in adults, these are caused by Streptococcus pneumonia. Invasive pneumococcal disease includes bacteremic pneumonia, bacteremia, which is sepsis, and meningitis, but the incidence is less as compared to non-invasive pneumococcal disease. This is a very interesting study by CMC Vellore, and Dr. Balaji is one of the author in that. They have generated evidence on invasive pneumococcal disease in Indian adults with this was a lab-based surveillance study from 2007 to 2017, which reported the overall case fatality rate of 17.8%. And pneumonia was 39%, meningitis 24.3%, septicemia 18.4%. The serotypes which were found positive among these positive cases were 1, 3, 5, 19F, 8, 14, 23F, 4, 19A, 6B. And most of these serotypes are now part of PCV 13, and now we have PCV 20 as well. They also reported penicillin non-susceptibility, low susceptibility to penicillin, which is about 6.4%. Another important study by their group Varghese et al. And they reported the serotypes among non-invasive pneumonia among adults. And the common serotypes in order of prevalence were 19F, 9V, 23F, 6B, 11A, 13, 34, 10A, 19A, 6A, which were covered by the vaccine, but they also found non-vaccine type serotypes like 13, 34, 35B, 31, and 16F. So, radiological findings, they reported as consolidation and multilobar involvement. So, in both the invasive and non-invasive, you can see that in invasive, most of the serotypes were covered by the currently available pneumococcal vaccines, while the non-invasive, the currently available vaccines do not cover these serotypes. Another important issue with the elderly is the immunosenescence. So the age-related diseases, which makes them more susceptible if they are infected with the Streptococcus pneumonia. They increase the morbidity and mortality risk to them because of accelerated aging leading to inflammation, oxidative stress, telomere shortening, DNA damaging, cellular senescence, reduced autophagy. All this leads to higher vulnerability, and the chances of pneumonia increase up to 4 to 20 times in these cases, and the severity also with the higher increase of getting admission in the ICU. So this paper basically presents that what is the risk as compared to the healthy. The first three categories you see among the healthy in different age group, 18 to 49, 50 to 64, and more than 65 years. As compared to this, you can see that risk of pneumococcal pneumonia is about 3 times among diabetic and 2.7% diabetes in the age group of 65 years. Similarly, the risk has increased in those suffering with chronic liver disease, chronic heart disease, asthma, alcoholism, smokers, chronic lung disease, and chronic renal failure. So risk has increased among this population. So now that was about the epidemiology. Now coming to the adult pneumococcal vaccine. So starting from the history, so we first started with developing a whole cell vaccine, but that was not found to be suitable. So in 1977, the first 14-valent pneumococcal polysaccharide vaccine was developed and it was introduced. And later it was further, the potency increased to 23-valent, and the PPSD was licensed, and this has been in use for quite some time now, since 1983. In 2000, the first 7-valent pneumococcal conjugate vaccine was developed, and after that in 2012 this was expanded to 13-valent, and the good news is now that it has been expanded to 20-valent pneumococcal conjugate vaccine 20, which is approved by FDA in 2021, and now it is available in India as well. So the serotypes covered by these pneumococcal vaccines. So as I have already mentioned earlier, we had this 23-valent polysaccharide vaccines with these specific serotypes, covering these specific serotypes. And PCV7 had these serotypes. I'm not taking the names. PCV13 had these, and PCV20 had these serotypes. So if you compare the polysaccharide with the now currently available PCV20, you can see, except for the 2, 9N, 17F, and 20, all other serotypes are covered now in the PCV20, and they provide additional protection against 6A as well. And if you compare the immune response of both these types of vaccines, the conjugate vaccines are far better. Why? Because they are conjugated with the CRM protein, which is a detoxified diphtheria toxin, and it leads to T-cell dependent antibody response. T-cell dependent anti-response is better because it leads to the development of memory B cell. So it leads to long-lasting immunity. Long-lived T-cell memory and booster response is better when conjugate vaccines are given as compared to the polysaccharide vaccine, which just produce polysaccharide-specific IgM response. So, and it does not affect the nasopharyngeal carriage rate, polysaccharide vaccines. So earlier, before the PCV20, we had this schedule that we used to give PCV13 first, and after 1 year, polysaccharide vaccine 23. And in high risk cases, the gap of about 8 weeks was to be ensured. But now, looking at the serotypes which are now covered under the pneumococcal conjugate vaccine, so we can actually recommend that we can give only 1 dose of PCV20, which will be good enough to protect the elderly population. So, what are the gaps in adherence? If you there's this data, and the evidence shows that people only take single dose PPSV 23 only. 23%, 45% take only PCV 13 only. So there are very few patients or individuals who complete the doses. Those who complete are 15% to 17%. So people are more adherent when there is a single dose of vaccines. And what are the gaps in the pneumococcal vaccination? Lack of awareness, especially among the healthcare providers also. So they are also not recommending to the high-risk population. Vaccine hesitancy, people are scared like after COVID-19. So vaccine hesitancy there. Policy gaps are there. So increase in non-vaccine serotype, people say that this could, they say ki other vaccine, which are not covered by the vaccine, they will rise. And vulnerable population, gap in the targeted vaccine effort for vulnerable population, and there is no special awareness campaign. Vaccine is as such is not available free of cost, so there is no point in awareness. But we can at the India level, why PCV20 was now it is in the market, and it is now it is better vaccine because of the prevalence of the high non-vaccine type serotypes, which, as I've already mentioned, that 15B, which is now covered by PCV20, that there are studies reporting non-vaccine type serotype infections. So this is another important study which shows what is the prevalence of serotype before vaccination and after vaccination. So as you can see that in the pre-vaccination era, the serotypes which are being covered by the PCV13, these in the post-vaccination era, the prevalence, the percentage have reduced except for 19A, 19F, where it has increased. And 15B, it was not there earlier, but now there are cases who are reporting being positive with the 15B serotypes. So this is also among the adults. So this I have already mentioned. So because of these reasons, I think it will be better that if you are recommending somebody the pneumococcal conjugate vaccine, 20 serotypes should be suggested, and this vaccine is developed on the same methodology as was used for developing the PCV13 CRM. It is conjugated with this genetically detoxified mutant of diphtheria toxin, CRM 197, which makes it T cell, which makes it better immunogenic as compared to the polysaccharide vaccine. So already we have data on the established efficacy, established real-world evidence on PCV13. We need to conduct immunobridging studies to compare the immunogenicity and efficacy of PCV20 as compared to PCV13. There are studies going on, and there are many studies which are in phase 3, and they are showing that the immunogenicity is equal or of that of PCV13 and PCV20. So, and this is the graph which shows that this PCV20 is producing serotype specific antibody response. So as you can see in the graph, for each serotype there are titers for each serotype, which is pretty good. So, and the serotypes which are there in PCV20, they are very specific. They are specific for preventing against mortality, ICU admissions, virulence, antimicrobial resistance, and also outbreaks. So these are the different serotypes which are involved in causing the disease, and after giving PCV20, there are chances that these will subside. So if you look at this comparison of PCV13 versus PCV20 in the invasive pneumococcal disease. You can see there are three age categories: more than 18 years and above, 19 to 65, and more than 66 years. So as compared to PCV 13, PCV 20 for all age group is better here, 66.7% coverage as compared to PCV 13, while it is similar to here polysaccharide vaccine 23. And here, if you compare PCV 20 versus polysaccharide 23, the coverage is for all age group is similar, but definitely it is better than PCV 13 for all age group for non-invasive community acquired pneumonia. So PCV 20 offers robust and long-term protection. It is T-cell dependent, induces immune memory, robust antibody response. It is single dose, so adherence will be better, and it has conjugation, so long-term immunity can be ensured. Protects against non-invasive pneumonia and nasopharyngeal carriage rate also it reduces, and it is effective in high-risk groups. So after these evidences, there is change in some of the recommendations. So the CDC ACIP has revised the recommendation. For individuals more than 50 years, they said, okay, give 1 dose of PCV 20 if the PCV 13 vaccine is given 1 year prior. 1 year prior. If it is later, then they can wait for another 5 years to get the PCV 20. Similarly, for other age groups. In India, coming to India, we in 2024, Indian consensus guidelines has come out, wherein IAPSM was also the part where PCV 13 was recommended, followed by PPSV 23. Now they have included PCV 20. What they recommend is those above 50 and more should get 1 dose of PCV 20, especially the high risk groups more than 60 years. Another important development is that ICMR is leading a national research priority research wherein they are generating an evidence on the effectiveness of pneumococcal and influenza vaccine given concurrently in reducing all-cause mortality among Indian adults more than equal to 60 years of age. There are 4 institutes. PJ is also one of the institute. I am the PI of that study from PGI. So we are looking forward to the results of this effectiveness study, where we are going to give PCV 20 with influenza vaccine. So the key messages to summarize that PCV 20 20-valent conjugate vaccine extend protection by including 7 additional serotypes, and all these associations, CDC, SCP, and now Indian consensus guidelines, they recommend to give this vaccine more than 50 years, provide better coverage, reduces nasopharyngeal carriage rate, long-term immunogenicities, and can be concomitantly given with influenza vaccine, and single dose is recommended. So that was all. Thank you so much.
Thank you, Dr. Madhu, for a very lucid presentation, and especially after SARS-CoV-2, adult vaccination or life course approach on immunization. And under this, pneumococcal vaccine has become the need of the hour, whether we talk of under 5s, and now when we are talking of over 50 years of age, because you really supported your cause with the evidence that you said that 23% of the global burden of pneumonia falls down, India is responsible for that. And both, when we talk of under 5s or when we talk of, outdoor patients, indoor patients, it is important cause of mortality as well as morbidity. So it assumes much more importance. And lastly, when you said that it is not only going to take care of pneumococcal, but other associated infections as well, when we are going to talk of PCV 20. But, despite all the associations recommending, whether it is Indian Medical Association, Geriatric Society of India, our own, IMA, or Physicians Association of India, everybody recommends. But the question now is that how to get it incorporated in our national immunization program. One is because the evidence is there. That is there, and I'm sure ICMR study is going to provide much more evidence in this. So what are your initial comments with regard to introduction in the national immunization schedule? We are talking of H influenza and all those, but all are available in the private sector. We have not made it as part of the, we recommend, but then we ultimately to be accessible to the last mile under universal health coverage, it has got to be, part of our system. So that is my, concern, and what you feel about this as a public health expert, and then we'll take some questions.
So, thank you, ma'am. That's a very, very pertinent question. How to take it forward to the policy makers? I think we are generating evidence in that direction. So maybe that study, which is a national research priority. As such, it is a national research priority. That means that this is a priority. So life expectancy in India is increasing. Maybe we need to do more advocacy. These two vaccines, I also consider influenza. So, but influenza is recurrent. But pneumococcal conjugate vaccine, single dose is, as I have shown, the evidence is there, is useful. But at the policy level, already seniors are here, you need to have more evidence on the cost effectiveness. Then cost also comes into play, and the real evidence, real time evidence from the phase 4, which is effectiveness studies, whether it is actually reducing the mortality or not. That will actually help and guide the policymakers better. So I think it is little early that whether we should include it in the adult immunization, but we as a country, I think, is quite capable and have demonstrated that we can implement adult immunization program in the country through COVID-19. So once they decide, I think we can take it up.
Any questions? And those who have taken, if anybody has taken vaccine, what has been the experience? That is also important.
My parents have taken, they are pretty fine.
I've also taken.
Great.
So, but important part is it has got to be subsidized, available and accessible. That is important.
Yeah.
Right now, majority of the pediatricians are only giving these adult vaccines.
Yeah, that is very strange. Not the physicians, but pediatricians are giving and advising it to the elderly population.
Because they want to keep their children safe. Because if adult in the family is going to suffer, the child is also going to acquire infection. So that is another important reason also, for one of the reasons, why.
And I think healthcare providers need to be educated themselves.
Definitely.
So there is a lot of gap here. Healthcare providers and those who, because in the OPD, all kinds of patients come. Those who can afford, they can at least get themselves immunized.
Thank you so much. If there are any questions, Dr. Please.
We can discuss all the questions and answers over a cup of tea.
Thank
Thank you, Dr. Madhu Gupta, and thanks to Professor Garg for sharing and helping us in
Thank you,
this.
sir. And for everybody's information, Dr. Madhu Gupta also runs courses on vaccinology. And this was the 5th course which you finished, 4th course. So those who want to learn more and more can, be in touch with Dr. Madhu. Thank you.
Okay, there is a important message. The quiz team has come, and the quiz leaders may please come up on the stage. Who is quiz master?
Good afternoon, everyone.
So we had an opportunity to conduct quiz, PG level quiz based on epidemiology and biostatistics, named Epimix 2025. And we, as a team, we want to thank the organizers from the depth of our heart to give us this opportunity. So overall, 18 teams registered for this event, and each team had 2 members. So overall, there were 36 participants, and we had conducted 4 rounds, and the teams which have turned out to be winners, team number 1 is, who stood first is team number 7, Dr. Vignesh and Dr. Madhura Sarkar from PGMI Chandigarh. Kitna? They will be awarded a cash check of rupees 5,000. So I request Umesh Kapil sir.
Sunila ma'am, please come on stage.
To hand over the prize. क्या है चंद्रवल्ली मिश्रा और शफिया. Please come on the stage. आगे इधर आ जाओ. You can come.
Yes, please.
So winners for this Epimix 2025 are Dr. Vignesh R and Dr. Madhura Sarkar from PGIMER Chandigarh. Please give them a big round of applause. The second team is team number 12, Chandramauli Mitra and Shafiq from Jawaharlal Nehru Medical College, AMU. Please come on the stage. कितना दे रहे हैं इनको? इनको कितना दे रहे हैं? नहीं उनको. They are being awarded a prize of rupees 2,500. The team which stood third is team number 9, Dr. B.T. Tejaswi and Dr. Suvigya Wadhwani from Lady Hardinge Medical College. Please come on this stage. They are being awarded rupees 1,500. And the fourth team is team number 6, Dr. Anjali Gupta and Dr. Seema Negi from PGIMS Rohtak. Please come on the stage. They are being awarded rupees 1,000 as a consolation prize.
हम लोग
बाकी सारे बच्चों को
हम लोग
सारे पार्टिसिपेंट्स को बाकी पार्टिसिपेंट्स जो भी हैं यहाँ पे प्लीज कम ऑन द स्टेज.
विनर्स भी आ जाएं,
अपना सर्टिफिकेट
अपनी सर्टिफिकेट लेके आ जाइए, सर्टिफिकेट चेक्स लेके। हाँ हाँ कोई बात नहीं, ऐसे ही बताना चाहिए।
आप तो आओगे आओगे।
आज ये दे देते हैं मैम सबको। पार्टिसिपेशन वाले
Please hold your certificates for the time being. Let's come together for a group photograph. Once that done, please come to us again and we'll complete the formalities that are left.
वही सपोर्टिंग स्टाफ में वाले मजाक कर
बेटा आगे चलो।
तुम्हें मिलेंगे ये तो सिक्योर वाला
कोई बात नहीं, यही है। हाँ हो गया ना?
एक ही
Okay, एक ही है बेटा।
एक दे दो ये तुम्हारे किसी और
प्राइस सेकंड प्राइस।
सेकंड प्राइस इसमें लिखा हुआ है ये वापस कर दो।
I'll do that क्योंकि बहुत सारे extra participants थे, we had to get. All participants are requested to stay in the room. We'll be completing. You can stay in the room in the auditorium. There's certain formalities left with your certificates, which we'll be completing soon. No, we'll do that. You take your seat.
इनका क्या है
मैम इनसे भी ले लेंगे।
हमारे सर ये रहेंगे
सर ये
आप लोग बच्चे सब बैठिए। ठीक है, I'll write all the names.
अभी कर
क्या क्या अनाउंस करना है? हम अनाउंस कर सकते जल्दी अनाउंस बोलना अनाउंस कर।
Dr. Ruchi Jual, Dr. Rucha Sinha, Dr. Rucha Sinha,
आराम से इच्छा से।
Dr. Sai Chandan Das,
right.
डॉक्टर दीक्षिका
आप कर लो मैं जाके दूंगा ना मेरे को देना है ना
डॉक्टर विदिशा वल्लभ डॉक्टर गगनदीप कौर
लिखा है तो
नहीं शी इज नॉट बस 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 मैम थैंक यू सो मच एक ग्रुप ले लेते हैं हाँ
थैंक यू
चलो बाहर बैठ के करते हैं